we ready to start?
Yes.
Can we have the display of CVs? Good afternoon, everyone. It's my pleasure and privilege to start the Gurukul classes, which are planning for next 3 days. And this is for the benefit of the exam going students who have already given their theory and they are now planning for the practical exam. And this program has been crafted taking all the senior people all over India so that our students get the benefit of interacting with the teachers all over India. They may become their examiners also, and they may be lucky. The students may be lucky to have them as examiners. So it's my privilege also to introduce the chief guest of the afternoon, none other than Professor Arup Kumar Majhi, who is the President ISOPARB, and he is presently Professor Shantiniketan Medical College, Bolpur, West Bengal. And he has authored so many books for the benefit of all the postgraduate students. Former Professor and Head OB-GYN, RGKR Medical College, and President Bengal Obstetrics and Gynaecology Society. At present, he is the President all over India of ISOPARB. He has 30 years of teaching experience and he has been examiner of UG, PG, DNB, nearly 100 publications in national and international journal. We are blessed to have you as chief guest today afternoon. Over to you, Dr. Majhi, for your words of wisdom.
Thank you, Dr. Mala, for your kind introduction. Good afternoon, everybody. Dear all postgraduates, esteemed faculties, and all ISOPARBians present here. It is highly appreciating that Gurukul classes have been organized by the Institute of Obstetrics and Gynaecology, Sir Gangaram Hospital, under the aegis of our esteemed organization, Indian Society of Perinatology and Reproductive Biology again. It is the regular endeavor of none other than our ISOPARB and Gangaram Hospital team, coordinated by none other than very dedicated lady, Dr. Mala Srivastava, a great academician, and this program is her mission and passion. And not only she is attached to the Gangaram Hospital, she is our Vice President, All India Vice President of the Indian Society of Perinatology, and also the Secretary of the our Delhi chapter of ISOPARB. It is a 3 days teaching program, already Mala has said, consisting of all the parameters of the postgraduate examination, long cases, the tummy, fetus, pelvis, and mechanism of the normal and abnormal labor demonstrations, instruments and operations, specimens, CTG, imaging, vivas, and also OSCE has been added this time in contraception in the form of the quiz. And I am really surprised and very obliged that there are so many stalwarts and the eminent teachers from throughout the country of our stream. After 5 days AICG, a big conference at Hyderabad, this is a very, very good academic feast, PG teaching that will be helpful for all the postgraduates appearing at the examination. I welcome you all this important program and wish a grand success of this teaching program of 3 days duration. Thanking you. Long live ISOPARB, long live ISOPARB.
Thanks, sir, for your words of wisdom. And it's a pleasure also to request Dr. Jaya Sood, Madam, our guest of honor. Madam is the Vice Chairperson, Board of Management, Sir Gangaram Hospital, and she has been very supportive of all the academic activities that we do. Madam has the chairperson of Department of Anesthesia in our hospital. And as we all know, She has got Lifetime Achievement Award as well as many accreditation to her credit. I hope Dr. Jayasud Madam has joined us. I think Madam is busy. She has not joined us. So we can directly go to the scientific program, and I will remind Madam to join whenever she's free, and we can have words of wisdom from her. Now we can go on to the scientific program. And for this first session, we have no one else but Dr. Arup Kumar Majhi, who is going to teach us the very basic of obstetrics and gynecology, and that is dummy pelvis and abnormal presentation. To have this session, we have very great chairpersons, great academicians who are going to chair the session of Dr. Majhi. We have Dr. Lakshmi Srikhande Madam. Madam has been the immediate past president of ICOG, which is a very academic wing of FOXY. She has been the national corresponding editor of Journal of OB-GYN of India, national corresponding secretary, Association of Medical Women's India, founder, patron, and president, ISOPARB Vidarbha chapter, chairperson, IMS Education Committee, president, Association of Medical Women, Nagpur Ratan Award, and under the hands of Union Minister Shri Nitinji Gadkari. Madam have received Bharat Excellence Award for Women's Health, received Nehru Dara Hansotia Best Committee Award. Madam has been chairperson of HIV AIDS Committee of FOXY, received appreciation letter from Maharashtra government in the field of Save the Girl Child, senior vice president of FOXY 2012, president Menopause Society Nagpur, president Nagpur OB-GYN Society, has delivered 11 orations and 450 guest lectures. Ma'am have so many publications. And last year we saw ma'am had done so many academic activities under the banner of ICOG, and we all have been a part of it. And I'm sure the entire India has benefited from madam's hard work and her dedication to academics. We are pleased to have you, and we are honored to have you, madam, this afternoon with us.
Thank you so much, Dr. Mala, for your kind words.
And we also are very honored to have Dr. Reena Vani with us. Dr. Reena Vani is another academician from Mumbai. Madam has been currently working at the Obs and Gynae, HBTMC, and Dr. R.N. Cooper Hospital as a HOD. Madam Reena does a lots of research in high-risk pregnancy, oncology, infectious disease, and high-risk obstetrics, as well as gynecology. And she's a great friend of us. And we all know that she is very dedicated to postgraduate teaching. And I'm sure everyone will benefit from her inputs into whatever sir says this afternoon. Over to you, the chairpersons, to introduce our speaker, Dr. Arup Kumar Majhi.
Very good afternoon. Dr. Arup Kumar Majhi has already been introduced by you, Dr. Mala. And we all know that he is currently the national president of ISOPARB, great academician, and he is the opening batsman for these Gurukul classes, which will continue for 3 days. And who can teach the basics of pelvis, basics of skull, the basic dummy pelvis, and normal and abnormal presentation. So we invite Dr. Arup Kumar Majhi to start with the first lecture on dummy pelvis and abnormal presentations.
Thank you, Dr. Mala and the team from Gurukul for having us as chairpersons. Obstetrics is something which does not change. In 200 years, the mechanism of labor hasn't changed, but the approach of students is something which needs to be honed and modified. So all the postgraduates and the students, and of course, even the consultants who have joined, I'm sure are going to benefit. And we are looking forward to having this as a very practical based discussion. And we will definitely save some time at the end where Dr. Majhi will be able to answer your questions. So over to you, Dr. Majhi, and we are looking forward to educating everyone on dummy and pelvis.
Thank you, Dr. Lakshmi. Dr. Reena Vani for kind introduction, and Thank you, Dr. Mala and the team, for inviting me for these important topics. In fact, I regularly attend the Gurukul physical classes at Gangaram Hospital. I cannot remember how many years, maybe decades, and regularly take classes there. But what I have found, and also the different examination, DNB and MS in the different states, I have seen, students actually therefore on the basics, what Dr. Saswati has kindly pointed out, the basics of the fetus, pelvis, and normal labor, and mechanism of the normal labor, and mechanism of the abnormal labor, that are very easy. If you follow my class for the students, the who are postgraduates here, if you follow my one by one, then it will be very easy, not so difficult. But you must have to read and follow our instruction. So without not going into the further comments, I am directly go to this. This is the pelvis, and in my next 1.5 hours, I will describe the basics of the pelvis and all the parameters of the pelvis, basics of the fetus skull, and relation with the fetus and the pelvis. And next, I will go to the mechanism of normal labor, and then mechanism of the occiputo-posterior position and the face presentation, why the labor is delayed, and also the face presentation, mechanism of the face presentation. And from this mechanism, when you want to conduct the labor, in case of occiputo-posterior position, face presentation, giving the normal vertex presentation, if you know the mechanism, that will be very easy to manage, conduct the labor. And lastly, I will show the mechanism for the postgraduates, mechanism in the different types of the pelvis, anthropoid, platyploid, android, and gynaecology is the normal. So first question is usually asked, the undergraduate question, but you must have to know, that the question is given, how to hold the pelvis in anatomical position. How to hold the pelvis in the anatomical position. This is the basic question. So before that, I will advise two things. You always hold the pelvis in anatomical position when examiner asks you, like this, by one hand, so that immediately after that, examiner will ask you to show you the mechanism of any labor. So you like this. In the one hand, make your right hand free. And how to hold the anatomical position? These are basic things. You anterior superior iliac spines and the symphysis pelvis in same coronal plane, and the pelvic arbitrary the pelvic inlet will make an angle of 55 degrees with the horizon. These are the basic things. And if there is a table, you just do like this, the touch of the table, the vertical wall, and you will see the anterior superior spine, symphysis pelvis is the touch it, and the vertical vertical table wall. And this is one thing. And second thing is, in before going to the pelvis in details, you see, always keep your hand in the pelvis, in the fetal skull, keeping the finger in the foramen magnum. Keeping the finger in the foramen magnum. Why? Sometimes I think when I am this side and examiner is that side, examiner, what does it do? They want to show the mechanism like this. But this is the aftercoming head of the breech. But so you must keep your finger in the foramen magnum. That will never, don't mistake. This is the basic thing. And always show the mechanism lever, head is in the pelvic cavity, not outside. Now I am going the details of the pelvis. You see details of the pelvis, basics of the pelvis. So next question is, the after holding the anatomical position, trace the pelvic inlet. This is the first or second question. The symphysis pelvis, pelvic crest, pelvic tubercle, superior border of the horizontal ramus of the superior ramus of the pelvis, and this is the iliopubic eminence, iliopectineal line, sometimes called lineo terminalis, sacroiliac joint, ala of the sacrum, sacral promontory. So again, on this side, sacral promontory, ala of the sacrum, sacroiliac joint, that is the pectineal line, iliopectineal line, and the iliopubic eminence, and the superior border of the upper part of the pelvis, and the pelvic crest, pelvic tubercle, pelvic crest, and symphysis. So this is the trace of the pelvic inlet. Now, after that, some of the basic thing is the pelvis. Is that what are the different types of pelvis? Uh, One is that false pelvis and the true pelvis. False pelvis lies above the pelvic inlet, and the false pelvis anteriorly in the abdominal wall, posterior by the lumbar spine, and laterally by the ilium bone. And the function of the importance of the false pelvis in pregnancy and labor is actually it supports the gravid uterus. And true pelvis, the pelvis which lies below the pelvic inlet, is the true pelvis. And pelvis is basically the mixture of the three bones that is united and ossified. One is the pelvic bone, one is the ischium bone, and the ilium, and behind is the sacrum. Behind is the sacrum and the coccyx. So this is about the true pelvis. Now come to the anterior from the pelvic inlet. Pelvic inlet, you can see the pelvic inlet. There are some diameters. First is I'll go to the shape, and there are different diameters. And what are the different diameters? Shape. Regarding the shape, in a female, there may be mostly cases of the gynaecoid pelvis, and other four pelvis are the android pelvis, anthropoid pelvis, and the platyploid pelvis. And mostly the gynaecoid pelvis is the female-like pelvis. And android means the wedge-shaped pelvis. These are all female pelvis. Android is the female pelvis where there is the wedge-shaped, there is the triangular shape. And anthropoid, anteroposteriorly larger than the transverse. And platyploid is where the transverse diameter is larger than the anteroposterior diameter. So this is the three types of pelvic based on divided in the based on this inlet. But in the different types of pelvis, the outlet and also the cavity are different. But a pelvis, female pelvis may be mixed. Suppose there's the gynaecoid and mix of the android, and it is called gyne-android. Means suppose the gynaecoid and android. The posterior part is the gynaecoid, and anterior part is the android type of pelvis. There are maybe 14 types of pelvis. These are all theoretical, actually. These are all theoretical. Postgraduates must know. Now the different diameter. So in case of gynaecoid pelvis, the shape is almost round, only anteroposteriorly small because of the sacral promontory. So this is this anteroposterior diameter, the three diameters. One is the anterior true conjugate, another is the obstetric conjugate, one is the diagonal conjugate. In fact, all the posterior point lies in the sacral promontory, but the anterior points are differ, and they are not actually in pelvic inlet. So true conjugate, this is true conjugate or anatomical conjugate. What does it mean? True conjugate means from the sacral promontory, and anteriorly it is the superior surface of the symphysis pubis, posterior border. Just listen, superior surface, posterior border of the symphysis pubis, superior surface, and posterior like this. This is actually the 11 centimeter. Why? What is important? It is the anatomically important. And obstetric conjugate from the sacral promontory up to the posterior surface of the symphysis pubis, but where it is the midpoint. It is the midpoint. Actually, it is the midpoint and most prominent part. Most prominent posterior surface, most prominent part in the midline. So that is the obstetric conjugate. So anterior point is when it is in the midline and most prominent point and posterior surface of some place. These 3 points. Why? Because that is the minimum diameter the pelvis head must have to pass. This is the obstetrical conjugate and the headache of the obstetrician. And now come to the diagonal conjugate. Diagonal conjugate is actually the sacral promontory up to the lower border of the symphysis. So you see the lower border of the simple spleen. This is the lower border of the simple spleen. From there to the lower border of the simple spleen. Lower border of the simple spleen. So, and it is 12 centimeter. Why it is important? This is the clinically important. Clinical important, but you can measure it clinically like this, like this. During clinical examination, you introduce your index and middle finger and try to reach the sacral promontory. And if the sacral promontory is reachable, you can assume normally the sacral promontory you will not be able to reach. You can think that the pelvis is probably anterocostally shorter, because in the broad pelvis, that is the gynecoid pelvis or anthropoid pelvis, it is not possible to reach. It can be possible to reach in the small gynecoid pelvis, anthroid pelvis, and also the platyploid pelvis. So this is the critically important. So 3 anteroposterior diameter, 11, 10, and 12, the true conjugate or anatomical conjugate, obstetrical conjugate, and diagonal conjugate. True conjugate is anatomically important, obstetrical conjugate is obstetrically important, and the diagonal conjugate is critically important. Now to the transverse diameter. Transverse diameter, there are 2 transverse diameters. 2. One is the anatomical transverse, another the obstetric transverse. Anatomical transverse means the iliopectoral line, the line joining the this is the farthest apart point of the iliopectoral line. Farthest apart point of the iliopectoral line. And this is anatomical, and this is actually 13 centimeter. This is actually 13 centimeter. And what is obstetrical conjugate? Obstetrical conjugate lies little behind the anatomical conjugate, the anatomical transverse diameter, and it is just behind. And what is importance of the obstetrical transverse diameter? Because the head actually passes through the obstetric transverse diameter. It is 1.25 centimeter, 2.5 centimeter, less than 1.25 centimeter from the transverse diameter. Next, the oblique diameter, very important diameter, sacroiliac. So that is from the oblique diameter from sacroiliac joint to the iliopubic lamina. It is 12 centimeter. It is right and left in respect to the sacroiliac joint. That is the sacroiliac joint. So if the right oblique diameter is the sacroiliac joint, left oblique diameter from the left sacroiliac joint to the iliac, it is 12. Another diameter of the iliac is the sacrocotyloid diameter. Sacrocotyloid diameter is from the sacral promontory to the iliopubic lamina. And it is actually important. Why? Because in case of flat pelvis, the anteroposterior too short, then the bipolar diameter may negotiate through this. That is the sacrocotyloid diameter is the 9.5 centimeter. So this is all about the different shape and different diameters of the pelvic inlet. Now about the pelvic outlet. Now come to the pelvic outlet. The pelvic outlet is not actually the plane. It is the mixture of the 2 plane. One is the anterior triangle, and there is the posterior triangle. An anterior triangle, there is the common base with the bituberous diameter, ischial tuberosity. There is the bituberous diameter, the ischial tuberosity. And this bituberous diameter, we can clinically measure with the fist, or like this, or like this. And the bituberous diameter, it is the normally 11 centimeter. An anterior triangle, so it is formed by the lower border of the symphysis pubis and the inferior rami of the pubis and the ischial tuberosity, and then the bituberous diameter. And posterior triangle is the ischial tuberosity, and tip of the coccyx is the anatomical. For anatomical, always think this is because there is an obstetrical outlet also. I'll go later. Anatomical is the tip of the coccyx. So this is the boundary. So it is anatomical outlet. There is obstetrical outlet also. I am coming to that later. Now come to what are the other plane in the pelvis. Other plane is the cavity of the pelvis. One is the plane of greatest pelvic dimension. Greatest pelvic dimension is almost a round plane on the round plane from the S2 S3 junction, from the S2 and S3 junction, S2 S3 junction, and which passes anteriorly to the posterior surface of the symphysis pubis. The maximum roomy plane, and there is no headache of the obstetrician at all. Obstetrician not deal with the plane of greatest pelvic dimension. But the most important plane is the plane of least pelvic dimension. Plane of least pelvic dimension is the lower border of the symphysis pubis and the ischial spine. And ischial spines are the big headache for the obstetrician for normal vaginal delivery. Because ischial spine, though the ligaments are attached there, the direction of the ischial spine, you can see the ischial spine, you can see clearly the ischial spine is the ischial spine. This is directed medially and to some extent posteriorly. It makes the pelvic cavity shorter. That is why this plane is called, the plane of least pelvic dimension. But so lower border of the symphysis pubis, both sides to ischial spine, and posteriorly the tip of the fifth sacral vertebra. And so 4 points. So there may not be 4 points. There may not be single plane, but this is the least pelvic plane. And another concept is there may be controversy. What is mid pelvic plane? It is said the mid pelvic plane is a plane which passes through the lower border of the symphysis pubis and ischial spine and crosses to the sacral promontory. It may be S4, S5 junction or tip of the fifth sacral vertebra. If crosses through the fifth sacral vertebra, then the mid pelvic plane and PLD are the same. So this is the concept. What are the importance of the mid pelvic plane? Number one, it is the lowest pelvic state, that is the minimum diameter, and there is a trouble for negotiation. And second, is the levator muscle attachments occur. Yeah, levator muscle. And internal rotations occurs here, and also the maximum flexions occurs due to resistance by the levator muscle. And also the station is judged for vaginal examination. The station is judged by pharyngeal examination in relation to the ischial spine. And also when there is a forceps application, we can see the station. And another important thing is the pudendal block anesthesia. And you will see the nerve hooks like this, posteriorly and below the pudendal nerve. So we will have to give the pudendal block anesthesia either through the vagina or through the perineum, guiding the ischial spine. And it is so the non-pregnant condition, the external os lies at the level of the ischial spine. So these are the importance of the ischial spine. That is the plane of least pelvic dimension. Now, I have already said what do you mean by the obstetric outlet. You know the obstetric outlet. It is actually the space of the pelvis, obstetric outlet, bounded above by the plane of the least pelvic dimension, below by the anatomical outlet. So plane of least pelvic dimension anteriorly the same point, and laterally the obstetric outlet formed by the ischium, lower part of the ischium, lateral one, and posteriorly in the coccyx. This is the obstetric outlet. So the postgraduates, you must know what is anatomical outlet in the pelvis and what is the obstetrical outlet. Anatomical outlet is the mixture of the true triangle, and the obstetrical outlet, it is the boundary it is the space or the part of the pelvis which lies above the plane of least pelvic dimension and below by the pelvic, that is the gynecological outlet, that is the anatomical outlet. So this is the difference. Now, the diameters of the plane of least pelvic dimension. Now, anteroposteriorly, the lower border of the symphysis pubis up to the tip of the fifth sacral vertebra, it is 11.5 centimeter. And bispinous diameter is the 10.5 centimeter. Normally, it's the 10.5 centimeter. And what about the anteroposterior diameter of the anatomical outlet from the lower border of the symphysis pubis to the lower part of the symphysis to the tip of the coccyx. But during labor, what happened? The coccyx is deviated posteriorly. Deviated posteriorly. So the resultant diameter becomes 13.5 centimeter. But it is actually the same like the 11.5 centimeter like the anteroposterior diameter of the pelvic inlet. And another diameter you must consider, that is the posterior sagittal diameter. Posterior sagittal diameter is actually the diameter of the posterior part. There is the posterior part of the different diameter plane. And in case of pelvic inlet, the posterior sagittal diameter, that the anatomical transverse crosses, and posterior part is the 5 centimeter, posterior sagittal diameter. And in case of PLD, the bispinous diameter and anteroposterior diameter crosses, the posterior part is also 5 centimeter. But pelvic outlet, that is the gynecological outlet, it is the 8 to 8.5 centimeter. And posterior centimeter, what is the problem? If the posterior centimeter becomes left, so there is no likely that space is the posterior part of the cavity is less. Cavity is less. Posterior part is the cavity is the less. So there is a chance of the prolonged labor, delayed labor, and the chance of rotation may be the delayed. That is the importance of the posterior sagittal diameter. If the posterior diameter in the inlet and in case of the PLD less than 4.5 centimeters, likely the contracted pelvis, and also the gynecoid pelvis in the outlet is the outlet, that is the diameter is less than 8 centimeter, that may be the outlet, that means the outlet. Now inclination of the pelvis. What is the inclination of the pelvis? Pelvic inlet, I have already said the pelvic inlet makes an angle of the 55 degree, 55 degree, and that is the pelvic inclination. But there is an angle of the sacrum, the lumbar vertebra, and in the pelvic inlet and the lumbar vertebra makes an one in the 135 degree. What is sacral angle? Sacral angle is the anteroposterior diameter of the pelvic inlet and the anterior surface of the upper part of the sacrum. This should be 90 degree. Why? Because the pelvis uses the sacrum, you see, the sacrum is above to downward, there is this curvature, good curvature. And for this curvature is absent, is called android pelvis, that the funnel shaped pelvis. And this curvature, concavity, there will be good rotation. Otherwise, in case of funnel shaped pelvis or android pelvis, there is the arrest at this level. This should be at least 90 degree. That is the sacral, that's the actual. Now come to the pelvic, subpelvic angle. Subpelvic angle, you see, this is my thumbs and index finger. The angle is the symphysis below the symphysis. The angle in the symphysis pelvis, that is the subpelvic angle. Thumb, you can say thumb and index finger, that is the subpelvic angle. This is the subpelvic angle. And this angle should be at least 85. Into the William Obstetrics, it is written that it should be the 90, more than 90 to 100, the subpelvic angle. So this is the, what is the pelvic arch? Pelvic is the arch from by the two pelvis, inner part of the pelvis. That is the pelvic arch. So pelvic arch is the configuration of the angle, configuration of the symphysis, lower part of the symphysis. Now what is the, there is a term is the waist space of Morris. These are waist space of Morris. If a disc of 9.5 centimeter is kept below the symphysis pelvis, there is a space is formed. That is called waist of Morris. If the subpelvic angle is less or pelvic arch is not good, so what will happen? The waist space of Morris will be larger. This is the, you can see the disc of 9.5 centimeter. If you see right here, the disc of 9.5 centimeter, you see there is a space. You say there is a space. You can see there is a space. There is a space. The below symphysis pelvis to the circumference, 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 there is a line. You can see there is a space. If this space is become more than 1 centimeter, that is the anteroposterior available diameter, more than 1 anteroposterior available diameter of the pelvic artery will be less. It should be not more than 1 centimeter. That is the waist space of, this is the waist space of Morris. Now you come to the different quadrant of the pelvis. Now different quadrant of the pelvis. Different quadrant of the pelvis, originally it was the 4 quadrant, 90 degree. But later on it is there may be 8 position. And originally is the left occipital anterior, right occipital anterior. I will come in later on also. And right occipital posterior, left occipital. But it has been found later there may be the 8 position. Left occipital anterior, and direct occipital anterior, right occipital anterior, right occipital transverse, and the left right occipital posterior, and also the direct occipital posterior. Another thing is the joints of the pelvis. Joints of the pelvis. These joints of the pelvis are very important so far as the labor of the concern. Joint is the symphysis pubis is joint. Symphysis pubis is the fibrocartilaginous joint. No synovial cavity, no capsule. And the sacroiliac joint is the synovial joint. There is a capsule, and also the synovial cavity. And this symphysis joint is relaxed in the late pregnancy, and also there is some widening of the pelvis due to the relaxity during the labor. And sacroiliac joint also relaxed, and there is the movement, superior gliding movement of the sacrum here. And in lithotomy position, what happens during the labor, the superior gliding movement of this joint, the sacroiliac joint, the pelvis become widened 1 to 2 centimeter. So delivery is facilitated. And it is the lithotomy position. It is the best in the dorsal lithotomy. Can you say, my postgraduate, what are any maneuver, the advantage of the movement of the joints are taken? That is the Magrovert maneuver in case of sacral, in case of Magrovert maneuver, in case of shoulder dystocia. What is done in shoulder dystocia? What is done? The leg is abducted, and then flexion. So what will happen? The symphysis pubis will go toward the cephalic part of the mother. So inclination will be decreased. So delivery will be the sacrum, the impacted anterior shoulder will be released. And also due to the superior gliding movement of the sacroiliac joint, that helps in the for the sacro, that is the Magrovert maneuvers of the shoulder dystocia. So these are all the basic thing. If I omit, please you ask what are the questions. Now to the skull. Now you would come to the skull. This is the skull, the fetal skull. This is the fetal skull. You can say the fetal skull, it has mainly the vault and the base. Now the vault and it is the base, vault and the base. And there are basically the one is the frontal bone, one is the parietal bone, occipital bone, and temporal bone. And part of the and the frontal and the face, there is the mastoid point also. So mainly the parietal bones, two sides parietal bone. This is the frontal bone, This is the occipital, and this is the face. And there are some sutures. You see, there are some sutures, and also the that is the fontanelle. Fontanelle, there are so much of about 4-5 fontanelles. The important fontanelles, one is the important fontanelle is, you can see, this is the posterior fontanelle. This is the posterior fontanelle. Posterior fontanelle, you can see, this is the posterior fontanelle, and it is the sagittal suture, and this is the lambdoid suture. So posterior fontanelle, it is the about 3 centimeter diameter, 3 centimeter diameter at the junctions of the 3 suture. One is the sagittal suture and 2 lambdoid sutures. And the fontanelle is actually the membranous part, but the posterior fontanelle, it usually becomes hard at the term and also after delivery. But the depression we can get. Depression you can do. This is very important for that to determine the position and also the head was flexed or not. Normally, if I get the posterior fontanelle or lambdoid, posterior fontanelle, or that is the bregma, you can say the lambda. you can say there the head is in the flexed condition. And anterior frontally, you can see that the 4 sutures, 2 coronal sutures and 1 frontal suture. These frontal sutures is united about 1.5 year, but other frontal sutures usually united at but there you can palpate. And this is the 1.5 centimeter membranous part. Membranous part. Normally, in case of flexed head, the posterior frontally is palpable, not the anterior frontally. If how to differentiate with the anterior frontally and posterior frontally during examination? Anterior frontally is there is the anterior the 4 sutures, but here is the 3 sutures, and posterior frontally is much wider, and anterior frontally is shorter. But till there is a membranous part, and and you will see there is the other frontally also at the frontally also the coronal suture and the temporal suture, the junction coronal suture and the temporal suture. And other also, that is the temporal suture and the lambdoid suture. These are also frontally, but less important in case of obstetrics. Now come to the areas. The areas that is very important. What are the different areas? In case of cephalic presentation, there are 3 important areas. One is the commonest is that is the commonest is the that is the this is the vertex. This is the area of vertex. What area of vertex? And this is the area. This is the area of the brow. So and this is the area of the face. So I am going to the how the demarcating anatomical land. So 3 areas. One is the area of vertex. One is the frontal area, that is the brow, and another is the face. And there is 2 poles. One pole is the occipital protuberance, and another pole is the represented brow. This is situated over the brow. And so that is the quadrilateral area. That is the vertex. Vertex is a quadrilateral area. You see, the vertex is a quadrilateral area. Anterior one part there is the anterofrontally, and another part is the posterofrontally, and 2 arbitrary line over the 2 parietal eminence. This is almost quadrilateral. And what is about the brow? Brow is the one part there is the anterofrontally and the coronal suture, and another is the supraorbital nose and the root of the nose. It is also called the nasion. This is also called the nasion or gabella. There is the glabella, the luck. Gabella or nasion and the supraorbital ridges. So this is the area of the brow. You all know the brow, the maximum diameter, that is the 14 centimeter vertical. If there is a brow presentation, in case of term baby, matured baby, vaginal delivery is not possible. You'll have to do persistent brow. You'll have to do the cesarean section. Now face. You hear me. You listen me properly. What is the face? Face, root of the nose and the superior. But what is the other point? The other point is the junction of the floor of the mouth. Junction of the floor of the mouth and the neck. Not the mentum. Some of the students do mistake. That it is the mentum, but it is the junction. You see, this is the junction. So face, you see root of the nose and this. This is the area, not this. This is the area of the face. So 3 areas are important. Now, what is presentation? What is presenting part? Presentation is actually that part of the fetus which come to the lower part of the uterus. Presentation. And presenting part, that precise part of the presentation which comes in relation to the internal. Like presentation in cephalic presentation, but vertex presenting part, face presenting part, brow presenting part. But in our practice, we mostly use the term synonymous because we do not say the vertex presenting part. We say the presenting vertex presentation. But for exam, what are the difference with the presentation and presenting part? You will have to answer like this. So these are the different presentation and presenting part. Now different diameters of the fetal skull, different diameter of the fetal skull. And before that, I want to say what are the importance of the sutures. Sutures, what is suture? Suture is the membranous part of the junction of the 2 flat bones. Suture. and these membranous parts become ossified near term or after that. But what is the importance for the presentation, to see the presentation, and also if there is a gap of the frontal suture, you may see there is the hydrocephalus. In case of hydrocephalus, there is the gap in the frontal suture. And what is the fontanelle? Fontanelle is the fontanelle. This also helps to determine the position and the attitude. And after delivery, the brain gets the space for enlargement. And usually, if there is in case of intracranial tension, that will be bulged. So these are basically some of the important. Now the different diameter, some anteroposterior diameter and the transverse diameter. Now, what is the girdle of contract? All pedagogists, you listen here, you know the term the girdle of contract. Girdle of contracts means that the circumference of the permanent edge contracts is the pelvic inlet. That is the girdle of contract. So it is that circumference of the presentation which comes in relation with the pelvic inlet. That is the girdle of contract. That girdle of contract changes in different position and different attitude of the head. So what is meant by the attitude? The term attitude is very, if you know the attitude, but what is that? Attitude is the relation with the different parts of the fetus. That is the attitude. Different attitudes, there are flexed attitude. Different attitude is the other attitude is the extended attitude and deflexed attitude. So it is the relation of the different parts of the fetus. This is the flexor attitude. This is the flexed attitude. This is the flexed attitude. And this is the extended attitude. What is lie? Lie is the relation between the maternal, that is the fetal spine, longitudinal fetal spine with the maternal spine or centralized user. This is the lie. This is the lie. So lie is relation between the fetal axis with the maternal axis, that is the maternal spine or centralized user. So these are the basic things. And what are the position? Position is the relation of the presentation when on the arbitrary area with the different quadrant of the pelvis or segment. I am coming to that again. That is the position. So you must know what is lie, what is presentation, what is positions, and what is inciput, and what is occiput. This must you do. Lie, majority of the cases, the lie are the, most of the cases, a lie is the longitudinal. And lie, in case of longitudinal lie, there will be cephalic presentation or the breech presentation, cephalic presentation, and there in case of other lie is the transverse lie or the oblique lie. Majority of the cases are the longitudinal, 99.5% of the longitudinal lie, and the transverse lie, oblique lie is only 5% cases. In longitudinal lie, the breech is only 3%, 3 to 3.5%, and rest in the cephalic presentation. In the cephalic presentation, the 96% are the vertex, and 0.25% is the face, and 0.27% is the brow. So the danger is less, but if you are danger, you must know the incidence is less. So again, I am going to total lie, 99% is the longitudinal lie, and 0.5% is the oblique or transverse lie. And among the longitudinal lie, 99.5%, 96% is the cephalic presentation. Cephalic presentation, breech in the 3%, breech is the 3%, and 0.5% to 0.25% is the face, and 0.25% is the brow, and rest are the vertex presentation. Now, different diameters of the anteroposterior diameter. I have already said the pelvic girdle. According to the in the attitude of the head, attitude and the girdle of contract, the anteroposterior diameter changes. How? The transverse diameter of the cephalic presentation is always the bifurcated diameter. A bifurcated diameter. It may change. How to have to come with that. Now, now the anteroposterior diameter First is the completely flexed vertex, sub-occiputo-bregmatic. Sub-occiputo. Come from, you go to the completely flexed, sub-occiputo-bregmatic. It is 9.5 centimeter. Below the occiput, below the point is on the below the occiput, and another is the anterior frontal, 9.5 centimeter. And sub-occiputo-frontal. Sub-occiputo-frontal is the same point in the behind, below the occiput, and anterior point is, remember, it is the midpoint of the, it is not the midpoint, it is the anterior end of the anterior frontal or midpoint of the frontal area. Are the same. This is the 10 centimeter. Sub-occiputo-frontal, it is incompletely flexed. Now coming to the deflexed vertex. It is deflexed vertex. It is the occiputo-frontal from the occiput to the root of the nose. It is 11.5 centimeter. Is the deflexed vertex commonly occurs in the vertex occiputo-posterior position. I will show the mechanism. I will show the mechanism. Vertex occiputo-posterior position. Vertex occiputo-posterior position, occiputo-frontal. Now the extension starts. When the extension starts, the diameter with the extension, slightly extension start, that is the mento-vertical. That is a partial extension, not the total incomplete, but the partial extension. Mento-vertical. You see the mentum, and it is the vertical. Vertical means the highest point of the sagittal suture. Highest point of the. So this is the 14 centimeter. The 14 centimeter, and presentation is brow. Vaginal delivery is not possible. 14 centimeter. Now more extension occurs. More than the submento-vertical. Submento-vertical means the root of the, that is the junction of the floor of the mouth and the neck up to the highest point, of the sagittal suture. So it is 11.5. It is the incompletely extended face. Incompletely extended face. That is the submento-vertical. And the submento-bregmatic, again comes down to the submento-bregmatic. It is the junction of the floor of the mouth and the neck, and up to the tip, up to the middle point of the anterior fontanelle. It is also 9.5 centimeter. So if again I repeat, sub-occiputo-bregmatic, sub-occiputo-frontal, occipito-frontal, then mento-vertical, submento-vertical, and submento-bregmatic. These are the anteroposterior diameter. But in case of face, the anteroposterior diameter is 9.5 centimeter, and vertex is also the 9.5 centimeter. So why face is abnormal level? Because the biparietal diameter in case of occiputo anterior, that is the vertex presentation, lies in the same plane. Means the sub-occiputo, parieto, and bregmatico plane. Same plane. But in case of face presentation, the circumference, face circumference is the bregmatico-temporal circumference. But the maximum biparietal diameter lies for above. So that is the abnormal lever, that is face. And there is also, the face is not a good dilator. And there is a membrane, there is a premature rupture of membrane or early rupture of membrane. So cord prolapse, so delayed labor and chance of cord prolapse. And so the chance of cord prolapse and rotation, also face presentation, chance of rotation, so face presentation is less, not like the occiputal. So this is the important question. The same diameter. So why this is the, in case of face presentation, same diameter in case of face presentation, it is the abnormal lever, and the occiputal anterior is the normal vertex presentation. Vertex presentation completely flexural is the normal. So this answer you must be ready in the exam. Now the transverse diameter. I have already said maximum biparietal diameter lies, the biparietal diameter is the 9.5. But there is another important transverse diameter. Supero-subparietal diameter. Supero means the above the supero-subparietal diameter is above, one is above, one is the below point. And it is the 8.5 centimeter. What happens is the when normally in case of labor, what happens? Sagittal suture is the sagittal suture lies in the transverse plane, transverse diameter of the fetus, transverse diameter of the pelvic inlet normally. But sometimes the anteroposterior diameter is short, or in case of even normal condition, the sagittal suture goes anteriorly or posteriorly. That is called the asynclitism. And asynclitism you learn, and take up with me, the asynclitism is the rule. This is the rule. Majority of the exclusion, not the bipolar diameter engages. Bipolar diameter engages. It is the super or subparietal engages, and it is more beneficial, particularly for the transverse, particularly when the anteroposterior diameter is short, in case of flat pelvis. So this is the asynclitism. There are two types of asynclitism. One is the anterior asynclitism, one is the posterior asynclitism. When the sagittal suture lies posteriorly, an anterior bone presents, that is called anterior parietal, the anterior asynclitism. And posterior asynclitism is the when the anterior, the sagittal suture anteriorly was posterior parietal bone presents, that is the posterior asynclitism. And anterior asynclitism is called negligence asynclitism, and posterior asynclitism is called the large cause asynclitism. So asynclitism, you must remember, this helps for the negotiation of the pelvic head. And the important definition of the engagement, important, it is the maximum transverse diameter, usually biparietal, passes to the pelvic inlet. Pelvic inlet. That is the definition of the engagement. And definition of the crowning, in contrast to the, that is the during labor, during advanced stage of labor delivery. That is the maximum diameter passes to the soft vulval outlet. Remember. So if you are asked what is the engagement, what is the crowning, engagement is the maximum biparietal passes to the pelvic inlet, and crowning is the maximum biparietal passes to the pelvic outlet. And there are other also the transverse diameter, bitemporal diameter, bimastoid diameter, that is of little obstetric significance, and I know going to that. Now we will come to the mechanism of labor. So I will going to finish the mechanism of labor, so you can get the question answers, some questions. Now mechanism of the normal labor. What do you mean by the mechanism of labor? What do you mean by mechanism of labor? It is the different movements adapted by the presentation through the passage through the pelvis for the birth. So that is the definition of the mechanism. It is the different movement of the presentation and during the passage through the birth canal, mostly the pelvis, soft and hard during the delivery, during the birth. So this is the presentation. So always I have always said, you do showing the mechanism of labor, you show like this, and that is the in anatomical position, and with one hand you practice, you make it practice one hand. Don't like this, like this. That is the movement of the like this. You be smart to hold the pelvis like this. You keep my hand where it is. You keep my where it is. One of the ischium and obturator foramen, and behind the ischium, just above the ischial spine, you keep on one hand. That is very, very easy to show. Then you there is the fetal head. This is the fetal head and skull. That is the fetal skull. And keep your finger for normal labor. Keep your finger inside the foramen magnum. And always during mechanism, you keep the fetal skull inside mechanism. So what are the different movement of the mechanism? First you remember. Then you describe the other number. First is the engagement, and next is the descent. Actually, the descent occurs during engagement also, if it is in labor. Descent, engagement, and descent, then flexion, and then internal rotation. Then the head is delivery by extension. Then outside delivery, that is the restitution and the external rotation. Is the restitution. Actually, the crowning is not the movement by the fetal head. It is the external manifestation of the during the just before the extension. This is the so again I am repeating the movement. engagement, next is the descent, next is the flexion, next is the internal rotation, and next is the head is delivered by extension, then outside restitution and external. So these are the basic movement adapted by the presentation. Now regarding the before describing, just use some the preliminaries, some preliminary. In case of normal labor, this is the undergraduate teaching actually. In case of normal labor, the lie is longitudinal, and presentation is cephalic and flexed. But in case of flexed condition, it is vertex, lie is longitudinal, presentation is cephalic, and it is vertex presentation. It will the common is the flexed attitude. It is a flexed attitude. Now engagement. Engagement occurs, the engaging diameter, there are two terms, engaging diameter and diameter of engagement. Engaging diameter of that diameter of the fetal head, which engages. And engaging diameter and the diameter of engagement, it is the diameter of the pelvis in which engages. So in case of flex vertex, what will happen? The engaging diameter is the suboccipital-bregmatic. They usually completely flex or doesn't occur at the bell beginning. Flexion completion occurs inside the. So it will be the either suboccipital-bregmatic or occipital-frontal. Suboccipital-bregmatic is the suboccipital-frontal is the 10 centimeter, slightly incompletely flexed part. Incomplete. So this is the what are the diameter of engagement? There are four positions. There are four positions I have already seen. At the diameter of the question, definitely. At the diameter of the engagement, in the right diameter of engagement, in case of anteroposterior diameter, suboccipital, in case of vertex, the diameter of engagement is the right oblique diameter. It is the LOA and ROA. It is the left oblique diameter. Left oblique diameter, and the left oblique diameter is the diameter of engagement. So engagement occur, but what is the transverse diameter of the fetal head? Is the biparate diameter. The same plane. It is the same plane. So engagement. Suppose there are different position: left occipital anterior position, right occipital anterior position, right occipital posterior position, right occipital posterior. And other four positions is the left occipital transverse, or LOL lateral, and direct occipital anterior, right occipital transverse, and the direct occipital posterior. But direct occipital posterior and direct occipital anterior during engagement, it is very less. Commonly occur is the occipital transverse, and more commonly occur is the left occipital transverse, that is the 40%. But if you are not instructed, examiner is instructed to show the mechanism in the particular position, you start with the left occipital anterior. That will be easier. In left occipital anterior position, it engages in the right oblique diameter. Engaging diameter is the suboccipital-bregmatic or suboccipital-frontal, and descents occur, and when it comes to the floor, the flexions occur, and flexion occur at the resistance. So where the flexions occur? It is the flexions occur at the level of the ischial spine, because there is the resistance by the levator ani. Though completion of the flexions occur till the end of the delivery, completion of that. And after the flexion only, when there is the minimum diameter count, that is the suboccipital-bregmatic, internal rotations occur. Occiput, there is internal rotation of the occiput. After the occiput, internal rotation occur. During the internal rotation, what happens? In the meantime, during the internal rotation, at the anteroposterior diameter lies in the anteroposteriorly, but that is the base of shoulder lies the left oblique diameter. Shoulder lies in the left oblique diameter. Shoulder lies in the left oblique diameter. So for the internal rotation, what will happen? There will be the torsion of the neck. And 1/8 torsion of the neck, but snake can sustain the 1/8 torsion. So then more descents occur, and our subocciput hinges under the symphysis pubis, subocciput hinges under symphysis pubis. So delivery of the vertex, then delivery of the subocciput hinges under the symphysis pubis, subocciput hinges under the symphysis pubis. Can show this pubis, delivery of the vertex, and lastly the delivery of brow, and lastly the face. So, and then as soon as the head is delivered, as the neck is torsion, is quickly the restitution of heart, 1/8, and then internally the shoulder also 1/8, and so external rotation occurs. So why internal restitution occurs? Restitutions occur due to the untwisting of the neck, and the external rotation occurred due to the internal rotation of the soul. So in case of left occipital anterior, the head is delivered, the face is towards the mother right side, left occipital, and also the right occipital posterior, head is delivered, mother is right, the left side. You saw like this. So first is the engagement, then more is the descent and flexion, then internal rotation, and there is internal rotation, there is the torsion, of the neck. And as soon as the head is delivered, delivered by the extension, what will happen? There is the restitution occurs, and followed by the external rotation, and then the anterior shoulder comes on the symphysis pubis, and the posterior shoulder, complete posterior shoulder delivery first, followed by the delivery completion of the internal flexion, and trunk is delivered, by lateral flexion. So this is the mechanism of the normal labor. You write down, put down your questions. I will just quickly go to the occipitoposterior and face, then I will face all the questions. So this is the mechanism of the normal labor in case of vertex presentation. Now come to the occipitoposterior position. Now what is the occipital position when occiput lies posteriorly? The commonly is the right occipital posterior. That is the occiput lies posteriorly. That is the posteriorly. That is the right posterior quadrant, right occipital posterior. This is the four quadrant like this. So this is the area where the fetal head will be there, occiput will be there, right occipital posterior, and this is the area left occipital posterior, Suppose the occipital posterior. I am not going into the details of the theoretical question why occipital posterior occur. Then we will not be able to finish. But that is also important question. Why occipital posterior? Some patient there is the occipital posterior, in other cases. The occipital posterior position. As I have already said, in case of occipital posterior, the head is usually the deflexed. This is usually the deflexed. That is the diameter. The engaging diameter is the occipitofrontal. Occipitofrontal. That is the from the occiput to the from the root of the nose. That is the root of the nose. So this is the deflexed vertex. That is the deflexed vertex, or it may be the suboccipitofrontal. It may be incomplete flexion. So this is the. So in case of occipitoposterior, lies longitudinal, engaging diameter is the occipitofrontal, which is 11.5 centimeter, or suboccipitofrontal, which is 10 centimeter. It engages in the right occipitoposterior. It engages in the right oblique diameter. It engages in the right oblique diameter. And majority of the cases, 90% of the cases, due to the completion of the flexion, it occurs the suboccipitobregmatic diameter, and long internal rotation. 2/8 internal rotation. So head is delivered, head is delivered, head is delivered, head is delivered by same the extension, restriction, and external. But one thing you remember, there is the shoulder, neck. So neck cannot sustain 3/8 rotation. So what will happen? So 2/8 normal rotate neck, and 1/8 keeping left the 1/8 twisting of the neck. And so delivery is normally like the delivery of like the is the occipital anterior. So this is the majority of the cases. So what will happen in case of occipital posterior? There will be prolonged labor. There will be prolonged labor and delayed labor. But majority of the cases, it is delivered as the vertex. But what happens to the other? It will depend on the degree of the degree of the degree. What is the degree of the deflection? Degree of the deflection. Degree of the deflection. I think degree of the deflection. Degree of the deflection. If there is mild deflection, what will happen? Mild deflection, occiput will go anteriorly. What is the go anteriorly? And it will be arrested in the transverse position. That is called deep transverse arrest, mild deflection. If does not further extension. Deep transverse arrest. Frequently the question is asked, what is deep transverse? Deep transverse arrest answers are in the term. Head is deep in the pelvic cavity, cerebellum lies transversely, and there is arrest. Usually, for a significant type of body, usually arrest means after full dilation of the cervix in the second stage. Arrest. So that is the deep transverse arrest. But suppose there is a moderate deflection. At the same time, the sinciput and occiput try to touch. Sinciput at the same time, touch the pelvic floor. So arrest occurs at this level. Arrest occurs at this level. That is the oblique posterior arrest. Oblique occipito-posterior arrest. That is oblique posterior, right oblique posterior arrest. But if there is a severe deflection, what will happen? Normally the occiput go anteriorly. But here is the severe deflection, sinciput touches the pelvic floor. So sinciput go forwards and occiput go behind. What will happen? So there will be occipitosacral arrest or posterior occipito position. Or there in some cases, in direct occipito-posterior position, in some cases, what will happen? Here occiput is in the hollow of the sacrum. In some cases, what will happen? The face-to-pelvis delivery. So face-to-pelvis delivery is related to the occipito-posterior delivery, not the that is not the face delivery. That is not the face delivery. What will happen face delivery? Root of the nose, that is the root of the nose, hinges under the symphysis pubis. Root of the nose hinges under the symphysis pubis. And the brow and the vertex is delivered. Brow and vertex delivered by the flexion, and the face is delivered by extension. So if you know the mechanism, you can give also the forceps application. And it was the known because what will be the direction of the force. In case of face-to-pelvis delivery, root of the nose hinges under the symphysis pubis. Head is delivered. That is the brow and the vertex by occiput by the flexion, and the face by the extension. So this is the face-to-pelvis delivery. Why there is the face-to-pelvis delivery? There is a more chance of perineal tear. That is the important question. Why in case of face-to-pelvis delivery there is a tear? Because in case of normal occipito-anterior position, the bipellar diameter lies anteriorly, but the bony cage. But in case of face-to-pelvis delivery, occipito-posterior delivery, the bipellar diameter, what does it do? Bipellar diameter stretches the vulval outlet. Bipellar diameter stretches the vulval outlet. And also, in case of occipito-posterior position, there is a space behind is less. That is why there is occipito position. So that is the position in the case of one of the cause of the complete perineal tear. Normally, in case of occipito, and the diameter of the vulval emergence, that is at the crowning, is the suboccipitofrontal diameter of emergence. This is the important question. And what is the diameter of emergence in case of occipital anterior position? In the vulval outlet, during the count, it is the suboccipitofrontal 10 centimeter. But here, it is the occipitofrontal 11.5 centimeter. That is, there is a more chance of probably perineal tear into the occipitoposterior position, face-to-pelvis delivery. And what is the other condition? Is the diameter of the fetal head is 10 centimeter suboccipitofrontal. That is the breech after coming head. In case of breech after coming head, the diameter, anteroposterior diameter after coming head is the suboccipitofrontal. That's the 10 centimeter. Complete flexion cannot be done in case of breech. It does not occur. But in case of your purpose is normal delivery, the region maneuver, so that the diameter of emergence is the 9.5 centimeter. That is the suboccipitofrontal diameter. So this is about the occipital. Now come to the face delivery. The face delivery. It is a common confusion and difficulty faced by the student, the different presentation of the face. This is a very easy way to remember. The how will the different position of the face. Suppose you take the fetal head, and you take the right occipitoposterior. Take the right occipitoposterior. There is right occipitoposterior. Right occipitoposterior. Make it complete extension. It will be LMA. Right occipitoposterior. Make it complete extension. It will be left ventro-anterior. That is way to remember it. What are the different position of the LMA means in case of right occipitoposterior, if it made extended, that is the LMA. Left occipitoposterior, it will be right mento anterior. And if you think the left occipito anterior, what will happen? Left occipito anterior completely extension, right mento posterior. So left occipito anterior is converted to right mento posterior in case of complete extension, and right occipito anterior converted to right mento posterior, left converted to left mento posterior, in case of complete extension, right mento, left mento posterior. So remember the first thing, left occipito anterior. What will happen? Complete extension, RMP. Right occipito anterior. If you do extension, RM is the LMP, and the left occipito and the left that is the right occipito posterior. Right occipito posterior. It will be LMA. Right occipito posterior LMA, and sorry, left occipito the LMA. Right occipito posterior, and left occipito posterior it will be RMA. Left ventro anterior. The denominator in case of face presentation is the mentum. An area of mentum, I have again says the face. It is from the anterior frontal up to the junction of the frontal, junction of the floor of the mouth and the neck. The function of the. So this is the area. This is the area of the face. Now come to the mechanism. Suppose you have the LMA. Always try to, when the examiner asked to show, you show the easier thing, not so going to the difficult thing. Now LMA, left ventral anterior. Routinely you say, lie is longitudinal, lies and presentation is the face, and head is in the attitude in extension. So lie is longitudinal, presentation is face, and attitude in extension. And the engaging diameter, you already know. That is the submento-bregmatic diameter or 9.5. Or it may be the submento-frontal diameter also. That is 10 centimeters. So submento-bregmatic you see. So here, instead of flexion, more extension. So engagement, then descent, and more extension. And then more extension, and then internal rotation shock, and more extension, internal rotation shock, and the submentum hinges at the position. Submentum hinges. So mentum goes anteriorly, and submentum hinges anteriorly. So everything is outside. So head is delivered only by the flexion. Head is delivered only by the only by the flexion. You see. Yes. You see. So here descent. Here the descent. And anteroposterior diameter is subming to brygmatic engagement and right oblique diameter. But you see, the bipedal is far away, not the same plane. So there will be delay. Internal root extension, completion of the extension, and there will be internal rotation. And the submentum hinges under the symphysis pubis, and head is delivered by the extension. You see, with this model. So left ventro anterior, the left ventro anterior, and internal rotation, extension, internal rotation, submentum hinges under the symphysis pubis. So there is no rest. The head is no remnant left out of the extension. Head is delivered by the extension. Head is delivered.
Sir, please hold the pelvis.
So this is the just 2 minutes. I will say about the left ventro posterior.
Majhi sir, just hold the pelvis bit higher. Students can't see the lower part. Yeah. And in the center of the screen, center. They are writing in the chat box that they can't see. So
the submentum hinges under the symphysis pubis. You see, submentum hinges under the symphysis pubis, and head is delivered by extension. That is, the face is complete. Then restitution, and there is the twisting of the neck. So restitution, there is the restitution. We'll do the untwist the neck, and there is external rotation, and that liver is the trunk is delivered by the lateral flexion. But what happens in the face to pubis delivery? In case of face to pubis delivery, root of the nose hinges under the symphysis pubis, root of the nose, and first the vertex and the occiput is delivered, brow vertex is delivered, and the face is delivered by extension. There are the dual movements in case of face to pubis, the occiput posterior. So if you know the mechanism of labor, it will help you to deliver, conduct the labor, and the forceps of the movement of the forceps. In case of occiput posterior, first you upwards and forwards, and forwards, and so the delivery occurs. Delivery of the vertex and the occiput occur, followed by the downwards. So the face. But in case of face, no upwards are needed. You just deliver it downwards. So if you know the face point. Now come to the ventro posterior. What happens in case of ventro posterior? So right ventro posterior. So the right ventro posterior. Mentum in the right side, and the right mentum in the right side, and the right posterior quadrant. And this is lies longitudinal. Head is extended like that. But here, what happens in case of occiput posterior? There is the long internal rotation theat, and that occurs in almost 90% cases. For here, only the 15 to 20% cases. That is why the chance of vaginal delivery is less in case of face to pubis of mentum. Only 15 to 25% cases. And what are the rest? That is, the more extensions occur, 3/8 rotations occurs, and the vaginal delivery occurs by the face delivery. But in the what is the rest? Whatever may be the extension, arrest occurs either in the right ventro transverse, or oblique ventro posterior, or direct ventro sacral arrest. And arrest, it is like face to pubis delivery. There is no such mechanism in case of face delivery. Like face to pubis delivery, I am again saying, there is no mechanism in case of ventro posterior delivery. So what will happen? There is an important question for the postgraduate. What will happen? What is the sternobigmatic diameter? Important. Sternobigmatic. If there is a ventro posterior, there is a more progress. There the chest will be chest will be telescope. Chest will be telescope. Chest will be telescoped in the sacrum. Chest will be telescoped in the sacrum. Chest will be telescoped in the sacrum. Chest will be, and there will be a sternobigmatic diameter. Sternobigmatic diameter. Sternobigmatic diameter, which is 18 centimeter. There will be obstructed liver. There will be like this. You see, like this. Sternobigmatic diameter. And there will be obstructed liver. Vaginal delivery is not possible. So this is about the mentoposture. I think I will not just one thing, 2 minutes I am saying about the mechanism of the labor in the different pelvis. So this is very easy. That is very easy. You can, in case of gynaecology, good gynaecology, they have seen. But in case of platypoid pelvis, what happens? Platypoid pelvis, it is routinely that the there is a superior subpart diameter engages. And if it is not possible entirely, the sacrocortical diameter. Then internal rotation, the more flexions occur, internal rotation occur, vaginal delivery occur. Problem is in the inlet in case of platypoid. Platypoid is a good pelvis. Only problem is the in the pelvic inlet. But what about the anthropoid pelvis? Anthropoid vaginal delivery is possible. Well, but there is a more chance of occipito-posterior and more chance of occipito-posterior and face to pelvis. In android pelvis, what happened? The triangular shaped pelvis, triangular pelvis, and the sacrum is the funnel shaped. So there will be delayed engagement or no engagement. If the engagement occur, there is engagement occur. Is there engagement occur? There will be obstruction in the pelvic cavity, or even the pelvic cavity. Then the outlet contraction, the delayed delivery. It's just like I say my student about in our profession, if you become a computer engineer, it is very difficult to get the chance like the platypoid pelvis. But once you enter, the no life. But in our profession, very difficult to get chance in the pelvic inlet. And also if you getting chance, semester exam, and after the delivery, you will say so many competitors in outside. That is but till it is the noble profession, and if you give your time, you will learn many things. Thank you all. Now questions. I am asking questions. I am not going into detail. Now questions. That left. Any question? I think there is so many questions.
Yeah, I can see only one question in the chat box for you, sir. Can you repeat why face with submento vertical diameter of 9.5 centimeter is abnormal labor?
9.5 centimeter submento. The question is in case of face presentation, the anteroposterior diameter is submento-bregmatic, 9.5 centimeter. But in case of occipito anterior position, submento-bregmatic. But in case of face presentation, the diameter is submento-bregmatic. Both are 9.5 centimeter. Why the face is abnormal labor? I think the question is like that. And why the face is because in case of face, the circumference which passes through the pelvic inlet, it is the bregmatico temporobregmatico circumference, temporobregmatico transference. But the biparallel diameter, which is the main transverse diameter, lies far above. So it will take time. And another thing, the face is a not good dilator of the cervix. Instead, that it is the smooth, and vertex is a good dilator of the cervix. The progress of labor in case of face will be less. Progress of labor in case of face will be less. And as there is a not good adaptation with the membrane with the face, so there will be early rupture of membrane. Is of face. So liquor is drained, the prolonged, and there is a chance of cord plug because there is a side, there is a gap, there is a chance of plug. These are the 3 important points why the face is abnormal labor, in spite of the anteroposterior diameter in occipito vertex presentation and face presentation are same 9.5 centimeter. And one common question is asked for the student: what are the different 9.5 centimeters in case of fetus pelvis? You say the biparallel diameter is the 9.5, and one case is the suboccipito-bregmatic is the 9.5, and submento-bregmatic is the 9.5. These are the 3 9.5 centimeters.
Another question is why phase 2 pubis delivery in anthropoid pelvis?
Why?
Phase 2 pubis delivery in anthropoid
More
pelvis.
in anthropoid pelvis. It's a good question. That is a good question. As there is the anthropoid pelvis, as the anteroposteriorly enlarged, and side to side is the decreased. Side to side is shorter. So the head, the occiput usually goes to the posteriorly to accommodate more posterior. At the posteriorly there is a more space. That is the occiput is more toward the more posteriorly.
Yeah, I can't see many more questions, but there is one request that can you please repeat the face presentation?
Repeat the face presentation.
Yeah.
Then I am with the presentation. Actually, presentation is very important. Their students are postgraduates are very confused. How will you show the different? Suppose the occipital anterior, left occipital anterior. You hold the left occipital anterior, left occipital anterior. If you completely make it extension, that will result the right mento posterior. Right mento posterior. Left occipital anterior, complete flexion, right mento posterior. And right occipital anterior, it will go is the left mento posterior. And in the right occipital posterior, if complete extension will be the left mento anterior. And left occipital posterior, it will be right mento anterior. So mechanism. Now mechanism is say, in case of face presentation, lie is longitudinal. Lie is longitudinal, no problem. Lie is longitudinal. And here is same. There was the engagement, descent and flexion in case of vertex presentation. But here will be the descent and engagement, and again descent, then extension, not the flexion. Then internal rotation, and head is delivered. It is delivered by rotary. Head is delivered by flexion. It is delivered by flexion. I am showing in left mento anterior. The engaging diameter is the submento-bregmatic. Submento-bregmatic, which extend from the junction of the neck and the floor of the mouth up to the bregma. That is 9.5 centimeters. But you see, the biparietal diameter lies far above, and so more extensions occur, and descents occur. The more extension occur, and mentum touches the pelvic floor. As the mentum touches the pelvic floor, so mentum goes anteriorly in extended condition, and then the submentum hinges. Is it visible?
Yes, it is visible.
Submentum hinges under the symphysis pubis, and head is delivered only by flexion, and then restriction and extension. This is very easy, but only to follow up how LMP occurs, how RMP occurs, element and first position. And in case of phase, it is said the RMP, LMP, LMA, and RMA. This is the first phase. But you describe the student. You are please describe in the LMA. It will be very easy, and that will be clearly written. Very easy in my book.
Yeah, I can see 3 more questions, sir. First one is how to tell clinically about asynclitism. Clinically about asynclitism.
Clinically?
Asynclitism. Clinically, how can they tell?
Asynclitism.
Yes.
Asynclitism. Yes, good question. Asynclitism is I have said, the sagittal suture, normally the sagittal suture lies at the sagittal plane. Sagittal plane of the pelvic index cord. You can see this is the sagittal suture. This is the syncretism. Sagittal suture lies in the transverse diameter of the inlet. Yeah. Okay. Now there is now. So this is the syncretism. When the sagittal suture either go anteriorly or go posteriorly, there are asyncretism. Clinically, how will you see? If you say the anterior parietal bone is more presenting and the sagittal suture will behind, that is the anterior parietal asyncretism. And if you see the sagittal sutures more anteriorly, sagittal sutures are more anteriorly and posterior parietal bone presents by palpation. It is the palpation if you get the sagittal sutures anteriorly, that is the posterior asymptotic. Posterior asymptotic. In posterior assembly, sagittal suture lies anteriorly. Posterior asymptotic. Sagittal suture lies anteriorly. That is called also the Lajko
photograph le lengi.
And asynclotism
Question
is
is
the
how you can explain high inclination in multipara. High inclination in multipara.
no, not the high inclination. Question is not the high inclination. It is the delayed engagement. Normally, the inclination is the two types. That is the normal inclination. Suppose there is the sacralization of the lumbar vertebra and lumbarization of the sacral vertebra. If there is the sacralization of the lumbar vertebra, sometimes may occur is the multigravida or Gandhi multipara, sacralization of the lumbar vertebra. What will happen? So the length of the pelvis will be increased. That is the high inclination. And lumbarization of the sacral vertebra, lumbarization of the sacral vertebra, that is the pelvic, that is the low inclination, that the pelvic cavity is low. So labor will be favorable. So that is the sacralization of the lumbar vertebra and lumbarization of the sacral vertebra. But regarding engagement, I can say, there one question, very important question. The engagement, in our student life, Dr. Lakshmi, you know, the engagement in case of primary gravida occurred before the onset of and before the onset of multigravida during. But there are a lot of studies it has been found. Engagement in case of normal pelvis and the baby is good size, engagement may not occur even in the at the term. Engagement may occur even during labor. So you cannot say that. It is clearly said, and I also give it in my book also. Not necessarily the engagement occurs in case of primary gravida before the onset of.
There is one question related to that only. Per abdomen, we are saying head is 2/5 palpable. Then vaginally, the head is at which station?
Achha, very good. Yeah. Very good question. I have fifth palpable is the keystone maneuver.
2/5, yeah.
During labor, that is a keystone maneuver. What will you see? That is a Achha, one important that during engagement, what occurs? During engagement, if you say this is the from the pelvic brim to the ischial spine, from the pelvic brim to the ischial spine, it is 5 centimeter. And in case of completely flexed vertex from the circumference of the biparietal diameter up to the lower bone of the fetal head is the 3 to 4 centimeter. So if there is a PV examination, we can get the lower pole at the ischial spine. You can say there is engagement occurs. Engagement occurs. Then engagement occurs, and by PV examination you can see the lower pole is near the ischial spine because the length of the pelvis from the brim to the ischial spine 5 centimeter for completely flexed vertex. Length of the circumference to the vertex is the 3 to 4 centimeter. So in 2/5 palpable, or 1/5 palpable, you will get by PV examination in uncupped. There is no caphot. The lower bone at the ischial spine. And diameter IMC, the symphysis pelvis diameter is 5 centimeter, and sacrum and the sacrum diameter, length of the sacrum is the 10 centimeter. And if you see the total curvature is the 12 centimeter.
How sacral arrest occurs? That is next question. Sacral arrest, how it occurs?
Sacral arrest occurs in case of occipital. Sacral occurs usually the sagittal diameter, posterior sagittal diameter of the lace. That is the sacrum. Sacrum is not well curved. Sacrum is not well curved. That is a well concave curve. Sacrum is not well concave curve. There is the cylindrical type, and that is the in case of android pelvis. And there is no progress of labor in the sacral area. That may occur also in the mentroposterior and also the occipitoposterior.
Yeah, another question is, sir, is face to pubes and face to pubis same?
Face to pubis?
Face to pubes and face to pubis same.
Pubes I do not know. Face to pubis.
Okay.
Festive pelvis and festive pubic delivery.
Yeah.
Festive pelvis and festive pelvis delivery.
Yeah.
These occurs in case of occipital-posterior position. 90% vaginal delivery occur. 10%, remaining 10%, some of the cases goes posteriorly, severely, and of some of the cases, where does not occur, the favorable cervix, a favorable pelvis, and the fetal head is good, not so enlarged. So the festive pelvis occur. Festive pelvis occur.
I can see one last question. By abdominal palpation, how can we tell position of the fetus? By abdominal palpation.
Position. That is position
of the
actually.
fetus by abdominal palpation.
Yeah, abdominal palpation. What will you see? Actually, best is to see the attitude of the head. Attitude of the head. Position, it is very difficult to see by abdominal position. You can see the attitude of the head. And position also can be seen, is very difficult. Attitude means if the sinciput and occiput, the sinciput lies and the occiput lies in the back. And back is the hard and smooth spine. So this is the occiput, and sinciput, where the hands are lies, sinciput. If the sinciput and occiput lies in the same plane, that is the deflex attitude. If the sinciput above and occiput below, that is occiput below, that is the flexed attitude. And if the sinciput below and the head is occiput above, that is the extended attitude. Sometimes you can go that whether this is the occipital position or not in suprapubic region. In case of in suprapubic in the suprapubic region, there will be elevation, and also occipital posterior position. The fetal husk count will auscultate more lateral to the. But these are very difficult. Not always easy for the beginners, actually. Is a beginner.
Yeah. Last question, sir. Is it necessary that cervix should be fully dilated to diagnose deep transverse arrest?
That is I am saying, what do you mean by arrest? Arrest. And I have also mentioned that majority of the cases is said, the older book you will see, the arrest means after full dilation of the cervix. But in many recent books, you will say, recent authentic book, the international book, the arrest may not occur. Arrest means it may be in the first stage also. Arrest in the, but for deep transverse arrest, take it granted, it is deep in the pelvis cavity, saltatus are live transversely, and the significant time after the full dilation of cervix. Multi-cavity, it is 2 or interprimary cavity and 1 in case of minor cavity.
Thank you, sir. I can't see any more questions. I think you have very well explained the normal and abnormal presentations. So thank you very much. Back to Dr. Mala.
Thanks, Dr. Lakshmi and Dr. Reena Madam, for having conducted this session so
your voice is not clear. Your voice is breaking. Dr.
And
Mala.
I must thank Dr. Arup, thank the chairpersons as well as the speaker, Dr. Arup Kumar Majhi, for nicely conducting this session. And I must thank Dr. Lakshmi Madam as well as Dr. Reena Madam for their great inputs. We are very happy to have a guest of honor, Dr. Jayashree Sood Madam, with us. And we request Madam to tell a few words of wisdom to all of us. Madam is the Vice Chairperson of Board of Management of Sir Gangaram Hospital. She is the Chairperson of the Anesthesia Department and Pain Management Department. Madam has been very academically oriented, and she has always encouraged us for all the academic activities of the hospital. She is the founder, member, trustee, and president of Indian College of Anesthesiology. Yes, Madam has done lot of works, and she's got Excellence Award, Lifetime Achievement Award, Teacher Excellence Award, Women's Day Award, and she has given at least 12 orations all over India. Madam is also very academically oriented, being editor of so many journals. Over to you, Madam, for your words of wisdom and encouragement for this Gurukul classes, which are going to have 3 days all over India. We are getting teachers from all over India, and students from all over India. We have almost 250 students together with us today.
Thank you.
Over to you, ma'am.
Thank you
Madam
so
is
much,
very
Mala,
nice
for the
person. I am fortunate to meet her in ninth, last month, 9 in the conference conducted by Gangaram Hospital. It's an excellent conference.
yes. Thank you, Dr. Majhi, for those compliments. Mala, you must be so happy to hear the compliments from Dr. Majhi. And good afternoon, everybody. It's a real pleasure to know that the Gurukul classes have started. Earlier, I remember we had them physically in our hospital, but possibly for whatever reasons, Mala, you all are holding it in the this thing mode, online mode. I think it enables more students all over India to join these very, very valid and important classes. And Dr. Majhi is taken the first class, Namaskar ji, which means so much. And the basic of the pelvis, I think, cannot be covered better than him. So we are really very happy and honored that you are here for this Gurukul classes. In our hospital, we always promote academic activities, and we're very proud that Mala and all the colleagues in the Institute of Obstetrics and Gynae are very academically oriented. And Mala, of course, I know is running several webinars in which she always invites me. And so all the students, I'm sure, have benefited a lot, not only in our hospital, but the others, as she says, 250 to 300 of them. Wow, that's a great number. Mala, congratulations. I know it's a teamwork. All of them are with you, but still, it's the lead that you have taken. Thank you, Dr. Majhi, once again. And thank you to the moderators, Dr. Lakshmi,
Thank you,
Dr.
madam.
Renu.
Thank you, madam.
Thank you so much. Thanks a lot. Okay, Mala, over to you.
Thanks, madam, for your words of wisdom. And we move on again to our scientific program. And for this session, this case presentation, case on anemia and pregnancy, I will invite the moderators. Dr. Manjupuri madam has been busy, so she has requested Dr. Ratna Biswas madam to moderate her session. Dr. Ratna Biswas is a professor director, Lady Hardinge Medical College, a senior professor, academician, very prone to teach the students. And we also have Dr. Achla Batra madam, who is also another senior person from, earlier she was in Safdarjung Hospital, now she's in Mata Gurjari Devi Hospital. Dr. Achla has been the president of NARCHI all over India, and she has also been the president of AOGD, very academically oriented and very keen to teach the student, and she's taken the program of Anemia Mukt Bharat. Another moderator for this session is Dr. A.G. Radhika. Dr. Radhika has been the secretary of AOGD and with special interest and expertise in evidence-based healthcare guideline development. She's been the honorary secretary, Association of Obs and Gynae, InGuide certified level 2 trainer for guideline development, national coordinator for clinical research, national corresponding editor, and she has been member of so many great societies. And we are all very happy that they have agreed to moderate this session. Over to you, the moderators, to invite the PG students, Dr. Smriti and Dr. Rutushree, to present the case.
Okay, you can
So
start.
thank
the
you so
case.
much. Dr. Achla, yeah, I think Dr. Achla can go, please. So
Yeah.
I just want to thank Dr. Mala for inviting us here. So glad to be here.
Yeah. Echo the statement. So I think we can start with the case.
Yeah. So we would like to invite the students to please present.
Dr. Smriti and Dr. Rutushree, they are the DNB students from our hospital. Please present your cases.
Dr. Rutushree.
Yes, ma'am. Ma'am, one second, ma'am. The file is not opening. Good afternoon, moderators. I am Dr. Rutushree. We are
turn on your video. Rutushree, presenting the case, please turn on your video.
Okay. Mrs. X, wife of Mr. Y, 25 years old, resident of Karol Bagh, New Delhi, belonging to lower social class, homemaker by profession, gravida 2, para 1, live 1 with 8 months period of amenorrhea, presented in antenatal OPD for the first time with complaints of weakness and easy fatigability for last 1 month and breathlessness on exertion for last 7 days.
Recording in progress.
History of present illness. The patient was apparently all right 1 month back. To begin with, she started complaining of easy fatigability and weakness, which gradually increased over a period of 10 days to an extent that she gets tired of on doing normal household activities. She also complained of breathlessness on exertion since the last 7 days. She becomes breathless on climbing 2 flights of stairs. Breathlessness is not associated with any chest pain or palpitations. No history of swelling of feet or abdominal distension. No history of sudden onset breathlessness or decreased urine output. No history of asthma, chronic cough or fever along with chills or rigor. No history of pica. There was no history of passage of worms, diarrhea or abdominal pain. No history of passage of blood in stools. No history of blood loss from any side. No history of easy bruisability, petechiae or purpura. No history of yellowish discoloration of face or decreased appetite. No history of hematuria or burning micturition. She did not take any iron or folic acid prophylaxis in this pregnancy. Her menstrual history. Age of menarche is 14 years. Her LMP was 3rd of Jan 2023. EDD by Nagli's formula is 10-10-2023. POG is 32 plus 4 for 32 weeks and 4 days. Her previous cycles were normal with normal blood flow, not associated with any blood loss, dysmenorrhea or passage of clots. Obstetric history. She has been married for 5 years. Gravida 2, para 1 with 1 living issue at 32 weeks plus 4 days period of gestation. She had 1 previous normal vaginal delivery in 2021 and delivered a female baby at full term, which was 2.5 kgs institutional delivery. She had exclusively breastfed the child up to 6 months. No history of any postpartum hemorrhage, and the pregnancy was uneventful. Trimester-wise history. She had spontaneous conception in this pregnancy. UPT was confirmed by self-tested urine pregnancy test at 2 months of amenorrhea. No visit at any healthcare center in first trimester. No history of radiation or teratogen exposure, fever with rashes, burning micturition, bleeding, or discharge from vagina. No history of excessive warmth. Second and third trimester, she started perceiving fetal movements from 5th month onwards. She had only 1 antenatal checkup in this trimester at 5th month, 5 months of amenorrhea at a local dispensary. She was advised all antenatal routine investigations and ultrasound level 2 scan, but she did not follow up with reports. She was given only 1 dose of tetanus toxoid. She was advised iron and folic acid tablets regularly, but she did not take. No history of headache, pedal pain in abdomen, blurring of vision. No history of polyphagia, polyuria, polydipsia. No history of leaking PV, bleeding PV, or pain abdomen.
Rutushree, can we see your previous slide, please? The first trimester one.
Ma'am, first trimester slide.
The earlier one.
Yes, ma'am.
Okay. Please
Can I
carry
go
on.
to the slide, ma'am?
Carry on, please.
Past history. No history of blood transfusion in the past. No history of jaundice, no history of tuberculosis, chronic illness, or recurrent UTI. No history of hypertension, diabetes, asthma, thyroid disorder, epilepsy, inflammatory bowel disease, or chronic kidney disease. No history of fever, recurrent sore throat, or joint pain in past. And no history of any drug intake. Personal history: she is homemaker by profession. She is a vegetarian. Bowel and bladder habits are normal. She does not have any kind of addiction. Socioeconomic history: she belongs to lower middle class according to modified Kupuswamy scale. Family history: no history of repeated blood transfusion or thalassemia in family, hypertension, diabetes, or bleeding disorders. Dietary history: her normal diet consists of rice, dal, roti, sabji, milk and milk products, and occasionally fruits like banana. On calculating the calorie intake, the total calorie intake was found to be around 1600 calorie per day, which is grossly inadequate, and protein intake was 20 grams per day on an average.
Great. Rutushree? So before you go on to the
Yes, ma'am.
examination, am I audible?
Yes, ma'am.
Okay.
Yes,
So
ma'am.
I would like to, before we go on to the examination, there are a few things that I, by way of suggestion and probably one or two questions on your history that you had presented. So I would advise Rutushree to, ask you to desist from saying no history of hematemesis, vomiting, this. Then you go to the next one saying no history of. So you enumerate about 10 times no history of. There is no need to say that.
Okay, ma'am.
Yeah. So as a postgraduate, you can, for example, in the primary situation, when you were doing history of presenting complaints,
Yes,
no
ma'am.
history suggestive of cardiac disease, meaning that she did not have complaints of breathlessness, pedal edema, or reduced urinary output. So because the way you present gets you marks, you could provide the same information in a more attractive way, and that makes all the impact, right? So you may not, it sounds very monotonous, and so was the case when you were also talking about past history. You can say there is nothing suggestive of renal disease or diabetes or hypertension. That is accepted. If you want to highlight any of the symptoms, that is also a possibility, but you need to do it in a good way. So number 2 is why she did not take iron and folic acid. So I think Garima Mahendra wants to know, should we also mention menstrual and OBS history? The answer is yes. I took up this question because it is related to your presentation and it's a simple one to answer. So why this lady did not take iron and folic acid, Rutushree? Well, are you Rutushree? I'm going on calling you Rutushree. Okay.
Ma'am, she was very non-compliant on taking iron and folic acid regularly
You
because
told us
she
that. You told
GI
us that she did not take.
Ma'am, she was experiencing a lot of GI side effects. That is why she was not compliant.
That is very important, Rutushree, why she did not take. Like that.
No, so when you said she had GI
highlighting.
intolerance, it means what? What kind of GI intolerance did she have?
She was. She said she has a lot of acidity after taking iron tablets and constipation and abdominal cramps occasionally.
So did she go back to the doctor and share this information with that doctor? Because she
No,
is
ma'am.
after all.
You have an ANC checkup in the whole pregnancy till now, ma'am. She was not following up with her with any local dispensary or any practitioner for further pregnancy checkups.
No, you said she had been once to the dispensary at 5th month of amenorrhea, 5th month of pregnancy, isn't
But
it?
till then, she not taking iron folic acid tablet. She advised folic acid after the ANC checkup, but she did not follow up.
No, but when she went there, they must have identified. No, they would have, at least in each visit they do a hemoglobin. Dispensaries are very good at that. They always do a hemoglobin urine checkup. Did you find out what happened at that 5th month follow-up? That routinely happens in all our dispensaries. So I think you need to go into the depth of whatever she has told you. And if she, what gravida was she?
Ma'am, she was gravida 2.
Gravida 2, and first was a miscarriage.
No, ma'am. Living issue. One living issue.
That is a living issue. So she knew very well, because that she supervised in the earlier pregnancy.
Ma'am, she had irregular pregnancy also.
So did she take iron folic acid in that pregnancy?
Ma'am, in that pregnancy also she took iron folic acids irregularly, but she had no anemia during her delivery.
Okay, but she had been taking, even though it was irregular, she had been taking iron folic acid. So here it's been a little different, and she confirmed her pregnancy in the first trimester at 2 months. You said during pregnancy test. So
Ma'am, I'm sorry, I'm not able to
did
hear
she go
you.
to the dispensary or any doctor when she conceived? Did she? You hear me now?
I'm
Can you
sorry,
hear me
it's
now?
not audible.
अभी आवाज आ रही है?
Yes, ma'am. Yes, ma'am. Audible.
Okay, so did she consult anybody when she conceived in the second pregnancy, first trimester?
No, ma'am.
समझ नहीं आ रहा. I think you can
No,
go ahead with
ma'am.
your. I am curious to know about this injection TT, because now there is a change in the immunization protocol. If this lady received injection TT, obviously she's gone somewhere. How did she receive a tetanus toxoid without going to a doctor?
Ma'am, she was given injection TT first dose when she went to the local dispensary.
तो गई थी ना, कितने वीक्स में मिला उसको?
Ma'am, 5 months of amenorrhea, 5th month पे गई थी.
उसी में मिला उसको. Okay.
हाँ, ma'am.
ठीक है. So from your clinical presentation, what is your provisional thought just by the history? What do you think
Ma'am,
is the possibility?
Ma'am, she might be having severe iron deficiency anemia, for which she is suffering
So
from
anemia,
these
iron
symptoms
deficiency
of
anemia.
easy.
What else? What else? Iron deficiency anemia. Number 2.
Ma'am, she might be having anemia of any chronic illness or thalassemia trait.
Why do you say chronic illness when you already given in your history that she doesn't have any illness? You
Exactly. Absolutely.
And you don't say iron deficiency, you have to say nutritional deficiency.
Nutritional deficiency.
So what kind of deficiency she have? You can't say from the history that she has iron deficiency anemia.
Yes, ma'am.
So what all deficiencies you think of when you say that she could be nutritional deficiency?
Ma'am, we can think of iron deficiency, folic acid deficiency, vitamin B12 deficiency.
And defecting the iron absorption.
Defective iron absorption.
Asking you deficiency, what other deficiency? You gave a dietary history, you found some deficiency?
You are muting yourself again and again. Please don't touch that microphone. No? Just speak.
Yes, from your dietary history, you think she can have other deficiency also, some other deficiency also? What is hemoglobin made of? What is hemoglobin made of?
Hemoglobin is
Hemoglobin
7.2. 7.2. The hemoglobin came out to be 7.2
No,
gram
I
per.
said, what is hemoglobin? Heme and globin.
Hemoglobin is made up of heme plus globin. Heme is made
What
up
is
of
globin?
iron and the
What is globin? What is globin?
additional elements are also required for synthesis of hemoglobin.
And is you
like
said
copper.
she's not taking enough in her diet. So what other deficiency can she have? B12, folic acid, iron.
Ma'am, globulin, ma'am, protein is also helping.
Protein deficiency also. would be there if she's not taking enough.
Ma'am, there are other elements also which are required for the synthesis of hemoglobin along with iron, like copper, manganese, lead, zinc, and vitamin C is also required. These deficiency of these elements can also lead to anemia.
Have you seen? Have you seen anemia? If other things are all right, anemia due to copper deficiency and
Manganese.
Yes, ma'am.
You've seen
Manganese deficiency.
Oh, chalo,
कम होता है ना?
Chalo, come to examination.
Yes, ma'am.
On examination, my patient was conscious, cooperative, and well-oriented to the time, place, and the person. She was sitting comfortable, thin-built, hydration status seemed adequate. Her height was 5 feet, and the weight was
Why
50
you are talking about hydration now? Like, is it a part of examination of everybody? What is the importance of hydration here? She was not having vomiting. She was not having diarrhea. Chalo, aage chalo. Hydration is not relevant here. Aage chalo. Rutushree, don't mute yourself again and again.
And in case you have logged in with two instruments, switch off one, because that is why you are getting the echo there and you are uncomfortable. Log in through only one device and keep yourself unmuted all the time.
You are muted again, Rutushree. Chalo, proceed.
Ma'am, it's not audible properly actually. That is why the problem.
Ma'am, her gait is normal.
I think there's another line in between height, weight.
BMI.
So is it relevant to write the BMI at 21.6 at this gestation?
Ma'am,
and her weight is 50 kilograms now or then?
Ma'am, her weight at present is 50 kg.
And your BMI calculation is based on the 50 kgs that you measured now? Is it?
How did you
So
know she was 50 kg? Did you ask her?
Pregnancy.
Don't change the slide. You need to answer this very important question that Dr. Achla has asked.
Okay. Ma'am, please repeat the question.
My question is, this BMI is pre-pregnancy, early pregnancy, and or now?
Ma'am, this BMI is pre-pregnancy.
How did you get the weight? She told you?
Because she was never registered anywhere. You yourself said she didn't register herself anywhere. And where was the need for this BMI to be mentioned at all? प्री प्रेगनेंसी वेट आप लोगों को कहाँ से पता चला, ये सवाल है आपसे. Now उसने first trimester में दिखाया. Her very first presentation to the hospital was at 20 weeks. How do you know she weighed 50 kg at that time?
Ma'am,
can you calculate pre-pregnancy from the current weight? Is there a way to say that?
I think the people managing this Wi-Fi need to look into this. There is a lot of disturbance. I think students and teachers, everybody is having a problem, please.
Yes, ma'am. Ma'am, this weight is not pre-pregnancy. This weight when she come to our hospital.
So is there any relevance of telling us a current BMI in pregnancy?
No, ma'am.
Then why have you put it there?
Okay, ma'am. Sorry, ma'am.
Chalo, आगे चलो. It's not a question of being sorry. You should know
Yeah.
you don't calculate BMI in pregnancy at the current weight when she's. If it was first trimester, yes.
Okay, ma'am.
Proceed.
Her pulse rate is 88 beats per minute, regular, good volume, bilateral synchronous with no radioradial and no radiofemoral delay. Her blood pressure is 110 by 80 millimeter of mercury on right arm in supine position. On her respiratory rate is 18 per minute. Temperature is 98.4 degree Fahrenheit, and her jugular venous pressure is not raised. On general physical examination, hair texture shows sign of malnutrition, pallor seen in the conjunctiva and skin, and clinically she appear around 6 to 7 gram per deciliter. Nails show platonychia, and there is no icterus cyanosis, angular stomatitis, cheilosis, and glossitis. There is no clumping cyanosis and the pedal edema. There is no palpable lymph node. There is no thyromegaly. On general examination, on auscultation of the chest, air entry equal on both sides, no added sound or crepitation heard. On cardiovascular system examination, apex beat heard on the left fifth intercostal space, and it is hyperdynamic as well as to heard normally. Ejection systolic murmur is present, and it is best heard over the pulmonary area, and it is not radiating to any side. On central nervous system examination, there is no focal neurological deficit.
Can you tell me what are the features of malnutrition in an adult hair? Children I have seen, but what did you find in a hair to say that malnutrition?
Ma'am, there is the alternate hyperpigmentation and the hypopigmentation of the hairs in the malnutrition patient.
Okay, I was not aware that adults also show this.
On per abdominal examination, on inspection, abdomen was uniformly distended. All quadrants move equally with respiration. Umbilical, central, and the avoided. Linea nigra and the stria gravidarum present. No scar mark or dilated veins seen. All hernial sites were free. On palpation, there is no organomegaly. Fundal height is around 32 weeks. Symphysiofundal height is 32.5 centimeter. Abdominal girth is 34 inches. On fundal grip, broad, soft, irregular mass felt suggestive of breech. And on lateral grip, right on right side, smooth and curved part felt on front suggestive of back, and on left side, irregular knobby parts felt suggestive of limbs. On pelvic grip, smooth, hard, ballotable mass felt suggestive of head. Liquor appears clinically adequate. Uterus is relaxed. There is no uterine tenderness.
Ruti, I would like to again, like in your history, you were same in the examination also. As a PG, if you just tell us, that abdominal examination, single fetus, cephalic presentation, you don't have to knobby part, suggestive of breech and volatile. Give so much time you waste, examiner will get, bored. What are you talking? You're not an MBBS. You are giving a PG viva.
Okay, ma'am. On auscultation, fetal heart rate is present and it is 140 beats per minute regular. It is heard along the right spino-umbilical line. And my provisional diagnosis is 25-year-old female, gravida 2, para 1, living 1, with 32 weeks plus 4 days period of gestation, with single live intrauterine fetus in cephalic presentation, with severe anemia, not in the heart failure. On
Your diagnosis of severe anemia on examination.
Ma'am, on examination we see the eye, then there is a palpable conjunctiva. On there is it is looking pale, and her hemoglobin is around 6 to 7. That's why we are call this hemoglobin on the basis of.
Rutushree, please go back to the previous slide and fix it there only. Let's not see this slide. So how do you know her hemoglobin is 7?
Ma'am, on examination, her conjunctiva is looking pale, and on examination, her palmar creases faintly. That's why we are call this severe anemia.
So what is your differential diagnosis?
Ma'am, iron deficiency anemia could be a cause.
Iron deficiency, you have
Nutritional deficiency anemia.
Nutritional
to see iron
deficiency anemia can be a cause.
Ritushri, can you hear me? Do you have biochemical eyes that you can see that her iron is deficient?
No, ma'am.
So why you say iron deficiency?
Nutritional anemia.
Nutritional
डॉक्टर
deficiency
ने अभी
anemia.
तुम्हें बताया उसी चीज को बता रहे हो तुम दोबारा ना. Now you correct yourself. She has already guided you earlier, isn't it?
Yes.
Yeah.
Nutritional
So
anemia can be a cause. Beta thalassemia can be a cause.
Anemia chronic
what beta
disease.
thalassemia? What?
Trait.
What
Trait.
did you say? Major?
Trait, ma'am. Trait.
Minor.
What else? Any other differential diagnosis?
Ma'am, there may be the anemia of chronic disease and
ये सारी बातें अभी हुई हैं, अभी तुम्हारे से डिस्कस भी हो चुका है. डॉक्टर अर्चना ने आपसे पूछा भी है, क्रॉनिक डिजीज आपने रूल आउट करा है, तो अभी आप ऐसे क्यों कह रहे हैं? Any other differential diagnosis? Let's not waste time, please. So in short, when you are going to give out your diagnosis, it is important for you to say my most probable clinical diagnosis is severe deficiency due to nutritional deficiency anemia. However, I have the following differentials in mind. Okay. So for example, if I say, can it be a renal disease? Can it be a chronic renal or renal disease? The
Ma'am,
lady
she
was
had no
breathless with
history of
anemia.
chronic disease in the past.
Doesn't matter.
She has no history of hypertension.
Doesn't matter. Is it not possible for it to have developed in the past 7 months?
Yes, ma'am, she could be.
हो सकता है ना? Any other differential diagnosis? So in your presentation, you should always be ready with a differential diagnosis. Your management is based on those, isn't it? You have one provisional clinical and followed by differential. Any other?
Symptoms are suggestive of another is always severe anemia, and that other system can be confused. Breathlessness. What else causes breathlessness?
Ma'am, rheumatic heart disease.
ma'am, anemia due to the chronic blood loss.
Heart disease, why you say rheumatic? Why you have to say rheumatic?
Ma'am, because
Heart disease could be heart disease. It could be heart disease.
It could be
But
heart disease.
you can't say rheumatic just like that. So anemia, nutritional deficiency anemia, heart disease, chronic renal disease.
Chronic renal disease.
Ma'am, malabsorption syndrome. Anemia due to the malabsorption syndrome.
And then with your history, you would say, okay, this is this, I don't think, and most likely diagnosis is nutrition. So when you give a provisional diagnosis, you always give a differential, and then you also say, these things I have ruled out by history, and the other things I would rule out by further investigations.
Yes, ma'am. Ma'am, we will like to send.
Don't go back to this. Why are you showing us this slide? See, when you present your case in the exam, you would not be privy to these investigation and reports. We want from you how you plan to manage this case. Okay, so you had a provisional diagnosis and you have the differential diagnosis. Now, how do you plan to manage?
Ma'am, first of all, we will like to order certain blood investigations like CBC with peripheral smear and also to differential leukocyte count.
You name the test and justify. Rutushree, please don't be in a hurry. You whatever you speak, it has to have a justification. So we don't understand what is CBC.
Ma'am, full blood count consists of hemoglobin along
I'm
with
not asking what it consists of. You just tell us without any abbreviations. Tell us what you want to do, want to get done, along with justification.
Ma'am, we will like to do a screening of hemoglobin first, and then all the red cell indices like MCV, MCHC, MCH, and also red cell distribution width. And we will we will also do a peripheral smear because peripheral smear can give us a more diagnostic approach towards various anemias, like in
Like
iron
what?
deficiency. Ma'am, like in iron deficiency anemia or thalassemia, we will see microcytic hypochromic cells. In hemolytic anemias like sickle cell anemia, we will see normocytic normochromic cells. In megaloblastic or folic acid deficiency anemia, we will see macrovalocytes. And if there is any other
So,
chronic
are
illness
you
or
aware, Rutushree, are you aware of the thalassemia screening program in antenatal mothers in the Government of India program, health program? It's come in a big way, hemoglobinopathies, sickle cell disease and thalassemia. So what are the two screening tests for thalassemia in the Government of India program?
ma'am, we do the Nestrov test, which is
Doing the
So number one is
Nestrov.
expand Nestrov. Expand.
Ma'am, no.
Naked eye.
इसकी spelling बोल के उसको expand करो.
Single tube rotation osmolality or osmolality fragility test.
Okay, so one is Nestrov. Number two, which is the other one for thalassemia?
HPLC, high performance liquid chromatography.
ऐसा है? What is the cost for a HPLC test? Incorrect answer. Any other?
You said
So
you
the second
will
one,
Niger index.
Ritushri, you said you will do red cell indices. So
Yes,
can from the red cell indices you can suspect thalassemia?
yes, ma'am.
How?
Ma'am, in iron deficiency anemia, the the MCV is low. In sickle, in thalassemia, the MCV is no, it is more decreased. In and the MCHC is also similar findings. In iron deficiency anemia, it is low, but in thalassemia, it is more decreased. The MCH values, the MCH
there is no
values,
clarity in your answer, Rutushree. हमें कुछ समझ ही नहीं आ रहा आप क्या बोल रही हो. It is decreased, it is more decreased का क्या
So
मतलब है?
there are two things we look at. Hi, I'm Ratna. I've joined a little late.
Yes,
Hello.
Yeah, we can hear you, Ratna. Please
Yeah.
tell me.
So there are two main important things you see. Now, one you said the MCV. Another important thing in the RBC indices, what you look at.
MCH.
No, but it's not MCH.
No.
MCH.
You were talking about Menzer's index,
You know
no?
what is
Right now.
MCH and what is MCH?
So what is the other thing in Menzer's index?
Okay.
You can just look at that specific thing and know it is thalassemia or not. Huh? No. Without even calculating the index, you will know. If you see that, it is the RBC count, which is high.
Okay, ma'am.
Why is RBC count high in thalassemia?
because of
This is a
Yeah,
very
you're saying
thing to understand that when you're looking at a red cell indices, you have a hemoglobin of suppose say 8 and the RBC count is 5. So it will give me a clue immediately without calculating anything that with the hemoglobin of 8, I can't have a RBC count of 5. That means RBC count is high. In thalassemia, this is production of defective cells. Lot of cells are produced which are very small, but the hemoglobin is low. That is the basis for menstrual sex. Do you understand?
Yes, ma'am.
Yes, ma'am.
So what
and
is
as per the government policy, screening tests are two. One is an estrog, the other is MCV. So the cutoff in pregnancy is less than 80 femtoliters.
Yes, ma'am. Less than 80.
But you didn't say that. Huh? It's important for you to know.
Yes, ma'am.
So how do you plan to manage?
You had said one thing that you will get a CBC done and a peripheral smear done to know what type of anemia it is.
Yes,
What
ma'am.
else will you get done?
And we will also do iron studies.
Anemia profile.
तो अभी आयरन स्टडीज पे कैसे पहुंच गए? अभी तो और चीजें भी होती है ना ब्लड में.
Ma'am, iron studies, we will also like to do vitamin B12 and folic acid levels.
श्री, आपके सीबीसी में हो गया?
No, ma'am.
नहीं, ma'am.
Are they important?
Leukocyte
count, platelet count, are they important?
Yes, ma'am.
Why? Why are they important?
Ma'am, because in infection or sepsis, which can also be a cause of anemia,
Rutushree,
yes.
as sepsis? Does she look septic?
No, ma'am.
Why do you want to know the TLC and platelet? Why? In a case of anemia. Why we want to know TLC and platelet also counts?
There could be a picture. We can be dealing with a picture of pancytopenia, where the TLC count is low or platelet count is low. Which
So what is the commonest cause of if the TLC is low, hemoglobin is low, platelet is low? What is the most commonest cause of that?
Ma'am, vitamin B12 deficiency.
Okay. So how will you confirm that?
I'm measuring the
Ma'am,
vitamin.
we will look at the peripheral smear reports and then we will confirm by doing the serum vitamin B12
So what
levels.
does the peripheral report tell you? How do you identify that it is B12 deficiency? It could be.
We will see megaloblasts,
Macrocytes and
macrovalocytes. We could see hypersegmented neutrophils
and jovel body.
Okay. So what other test other than that you will do? Peripheral smear, hemoglobin, or CBC?
Yes, ma'am.
Then the causes of anemias, other causes?
Ma'am, anemia due to the malabsorption syndrome, anemia due to the chronic disease.
No, that is.
We have gone through this discussion. Now you are getting asked the investigations that you wish to undertake.
And we will also like to see baseline investigations like
baseline नहीं, अभी तो बात हो रही है इस मरीज के मैनेजमेंट की. ऋतुश्री, आप जिस तरीके से जवाब दोगे ऐसी वाइवा चलता रहेगा और फिर वो 1 घंटे में इनकंक्लूसिव रहा तो people will get impatient. You see, you think and answer. Take a minute, hear the question properly and then answer. है ना? आपने कहा CBC with peripheral smear. We have discussed that. What else?
Now you expand on this, na?
Ma'am,
see, we have potential of chronic renal disease.
Ma'am,
yes. Right.
Urine routine micro, occult stool blood test for see the hemoparasite parasites and rootworm infection, and the urine routine micro, and the KFT for determining the chronic renal disease, and LFT for the chronic liver disease, for the diagnosis of the chronic liver disease. And
Chronic liver disease. Kyun? Why do you think, what is it that that's in your mind?
Ma'am, because it may also cause the anemia.
What kind? Tell us. Is this lady, you have done her examination, everything is fine. Renal disease, the presentation can be different, but liver disease is difficult to miss. What else?
You will all have a battery of investigation written in the textbook, but you have to tailor your investigation according to what you have taken the history and examination.
Is there a place of thyroid function test?
Yes, ma'am. Thyroid function.
But
ma'am, hypothyroidism can also cause anemia.
Well, there is no thyroid.
Chalo, expand.
So traditionally,
yeah. Radhika, you were saying something?
no, traditionally, the investigations are done to know the cause, type, the severity, isn't it? I thought it is very simple to answer this basic question that we had asked you. So the answers remain the same. To know the cause, type, and severity of anemia, the basic investigations, the initial steps of investigations address these three queries. वही जवाब देना है आपको भी.
आपका जवाब इस तरह भी हो सकता था कि we had got the routine investigation, जिसमें already urine routine is already a part of routine. Thyroid is a part of routine in our system. So you have ruled out thyroid and no finding in the urine, and then you expand over your finding. Like if you find this in CBC, then you will proceed like this. If you find this in your CBC, you will proceed like this.
So now your indices that you were talking about, including serum ferritin and everything, now is the time that you can actually tell us. If the hemoglobin is less than whatever, you estimated it was 7, isn't it?
Yes,
and rest of the parameters and MCV, MCS, then what do you plan to do?
Ma'am, once we see that the hemoglobin is less, the red cell indices are decreased on peripheral smear, it is a microcytic microchromic picture, then we will order, we can suspect iron deficiency anemia in this case, so we will order iron studies for further confirmation. Iron studies consist of serum iron, serum ferritin, TIBC, and transferrin saturation. In iron deficiency anemia, the ferritin will be low, iron will be low, TIBC will be high.
What is normal? What is normal serum ferritin and what is the...
Ma'am, normal serum ferritin ranges from 15 to 150. And normal iron, ma'am, normal iron ranges from 60 to 150. And the TIBC ranges from...
Rutushree, unit.
Ma'am, micrograms per ml.
Okay, and what can you find in anemia, iron deficiency anemia?
Ma'am, the iron will be less the iron will be less than 60. The ferritin will be less than 15.
So does it matter the severity of anemia? The more severe the anemia, lesser would be ferritin. You need to quickly answer the questions. These are very simple questions, isn't it? Okay. So ferritin, TIBC. Expand TIBC.
The normal TIBC ranges from 250 to 435. 435 micrograms per ml.
What is the percentage saturation?
The percentage saturation is between 30 to 80%.
What happens in anemia?
Ma'am, in anemia, the iron, ferritin, and transferrin saturation is decreased, and TIBC will be increased.
Okay, so now how do you plan to manage this lady at 32 plus 4 days of pregnancy? Hemoglobin is 7.
Yes, ma'am. Ma'am, since she is not compliant to oral iron, then we will, and she has likely chances of loss to follow. That is why we will plan for parenteral iron. Before that, we will have to see that we will have to confirm that it is iron deficiency anemia. We will have to confirm that she has no hypersensitivity reaction to any oral preparation. Um,
How do you
we
confirm
need
that? Oral preparation, hypersensitivity reaction? हमें कुछ समझ ही नहीं आया.
For parental preparation.
for
This is one lady, you
parental
yourself says that she had gastritis and she was unable to take. Now you tell us, is there a difference in the rise of iron, whether she takes it orally or parenterally?
No, ma'am, the rise is almost the same.
So if this lady were to come to you at 20 weeks and she says, I am unable to take iron because I have gastritis and constipation, what would you have done?
Ma'am, we would have suggested her alternate iron therapy.
Alternate iron therapy.
Alternate days iron therapy, intermittent iron therapy.
Anything else?
She's able to tolerate.
I think just changing the
Or we will
iron
suggest her
preparation would probably help.
oral preparation in the form of syrup.
Syrup. That's a formulation. That is not preparation.
Better, yes, ma'am.
You can change. Can you change the salt,
It's not like syrup.
which is most gut friendly salt? What about the type of salts?
Don't see the responses online. Please give your answers.
Ma'am, iron sulfate, iron ascorbate, iron citrate.
So as the size of the molecule reduces, the side effects also reduce. So which is the latest one?
Ma'am, the latest one is iron ascorbate, which we routinely
It's not the latest one.
use.
No? But other than the formulations, what can be the other instructions that you can give to the lady? If she says, you want to still continue with the preparations which are available in the government supply, okay, she is not able to afford anything else. So what can be simple advice that you can give to the lady and that might actually help her?
Ma'am, we will advise iron-rich diet.
Ma'am, first of all, we ask about the
अरे गोली इसको खाने के लिए एडवाइस क्या दोगे आप? गोली खाना है उसको, ये तो हमने डिसाइड कर लिया.
अच्छा
मैम आप फॉर मैम अगर जीआई सिम्टम्स कम करने के लिए मैम उसे ये बोलना है मैम आफ्टर 1 hour आफ्टर द मील एंड द टैबलेट शुड बी टेक विद द विटामिन सी एंड विद द लाइम जूस
to increase
to increase the iron absorption and increase the amount of the green leafy vegetables and the citrus containing fruits.
No, here is a situation where she is having constipation
together.
And
Can she take her iron and calcium together?
No, ma'am.
No, ma'am.
Ma'am,
Not
calcium,
to take iron and calcium preparation together. And we will also tell her to avoid tea, coffee, or any phytate containing products while she is taking iron.
Okay, so the point was she has two problems. One is gastritis, the other is constipation. So yeah, it is.
Ma'am, we will also advise her to take a lot of fluids and high fiber diet.
Okay. So with these instructions, what are the other interventions as given by government or anemia prophylaxis and management program?
Ma'am, we will also like to deworm the patient because
what is a drug and what is the dose? What is the prescription for that?
Albendazole is a 400 milligram single dose and mebendazole is 500 milligram for 3 days.
Once a day, twice a day?
Twice
a day, ma'am.
Okay. What else? Tell her not to have iron with tea. So there are about 4 instructions which are given in that national guidelines. You need to know that. You might have said it at various points, but when you are asked such a question, you need to enumerate all the 4 or 5 points. It's important. Okay, what are the other steps in management of this lady? So you said you wish to give her parental iron. What preparation would you like to give and how do you calculate the dose required?
Ma'am, dose is calculated by the Ganzoni formula, and it is calculated by the weight of the lady in pre-pregnancy body weight in kg, and target hemoglobin minus present hemoglobin into 2.4 plus 500.
So which are the two formulations allowed in our country in antenatal mothers? Is it two preparation or one preparation?
Two preparations.
Name them.
Ma'am, ferrous carboxymaltose and iron sucrose. Two preparations.
So FCM is approved by DCGI for antenatal mothers during pregnancy. No, it is not. Even though it is there in the government program, still the DCGI thing is not there. So iron sucrose. So tell us in detail about how to give iron sucrose. Hemoglobin is 7 and you plan to give her parenteral iron. Tell us the dose that is required. How will you give? How will you dilute or whatever? And all the instructions.
Ma'am, we will take 1000 mg of FCM and dilute it with 200 ml of.
No, you said her weight is 50 kilograms and the hemoglobin is 7, isn't it? Yes, how much is the deficiency?
Deficit is
weight is 50 kilograms.
11. We take the target hemoglobin to be 11.
10.
Sorry.
Is it 10 or 11?
Ma'am, 11.
11,
Okay.
ma'am. Third trimester mein 11.
Okay, so you mean it was lesser in the second trimester? ऐसा है?
Ma'am, in the second trimester we try to hemoglobin. Ma'am,
Try to kuch nahi. What are there has to be clarity in your mind. It is all clearly defined. So we will take it as 11. Deficiencies of 4. How much is the iron required?
11 minus 4.
So आप लोगों ने calculate नहीं करा था पहले. Tell us how to give iron sucrose. What is the maximum dose? How it is given?
Ma'am, iron sucrose is given in a dose of 200 milligrams.
How much iron sucrose is available? What is the formulation? What is the composition in a single ampule or a vial or whatever you want to tell us?
Iron sucrose is available in 2 vials, which is 2.5 ml and 5 ml vial. Each 2.5 ml vial contains around 5,000 mg of iron and
5,000
500
mg. 5 grams.
Sorry, 500 mg, ma'am. 500 mg. 500 mg. So we take if the total iron deficit कितना हुआ? Ma'am, according to the total iron deficit which we have calculated, we will take the number of vials 50 and dilute it in 200 ml of NS, and we will slowly give it over a period of 30 minutes.
सारा एक ही बारी में दे दिया जाए.
कितना maximum we can give in a day?
You're talking of iron sucrose. Are we giving total dose infusion in iron sucrose? Are you people giving in Ganga?
No, ma'am.
Dose infusion?
No, ma'am.
No, ma'am.
Alternate days. On alternate days.
Ma'am, we are given iron.
What is the maximum allowable dose per day?
Maximum allowable dose
1000 milligram.
1000 milligram.
Are you
What
sure?
are you talking about?
For iron sucrose.
Talk of one thing.
Incorrect answer.
Ma'am, 600 mg
per week.
So per day, how much you will give? How much per day?
200 mg.
Yes. So why are you confusing then?
Yeah. कहीं तुम 1000 milligram per day कहते हो, फिर तुम कहते हो 600 per week, then per day. So these questions are standard questions. You'll always get asked. तो अभी इसको देने के बाद when do you review?
Yes, ma'am. We will call her for follow-up in after 2 to 3 weeks with a repeat hemoglobin test.
In 2 weeks, you expect the hemoglobin to rise?
Ma'am?
In 2 weeks' time, do you expect the hemoglobin to rise?
No, ma'am.
So what will rise? What you can check after 2 weeks if you want to call her at 2 weeks?
Ma'am, iron therapy is adequate if the rise in reticulocyte count is around 5% in 7 to 10 days. And hemoglobin rises over a period of 2 to 3 weeks by
What is the
0.8
standard
to 1%.
normally? When do you call the patient for a repeat hemoglobin?
After 3 weeks.
3 to 4 weeks.
3 to 4 weeks.
Okay, so now this lady has responded fortunately, but her hemoglobin remains at around 9, and at 35 weeks she comes back again saying that she has abdominal pain. She's gone into labor, 35 weeks. Hemoglobin 9.
Okay, ma'am.
What is your plan?
Yes, ma'am. Ma'am, we will keep up in propped up position. We will have adequate blood, arrange adequate blood products.
Adequate क्या होता है? What is adequate?
Ma'am, we
Please
will
arrange adequate blood for her. It may be 4 units, it may be 2 units, maybe no blood. So what is adequate? Adequate is not a scientific word to use.
Okay.
See, iron deficiency anemia given very clearly in the guidelines. So I don't think there should be any confusion in that.
Ma'am, at least 2 units of blood cross match has to be done.
Yeah, just cross match, nothing else.
Yes, ma'am. Propped up position, we will try to give her intermittent oxygen therapy.
9 gram you want to give her intermittent oxygen therapy, why?
And why prop up also?
She's not 7 gram or 6 gram that you want to give her oxygen therapy and proper.
And we will allow spontaneous progression of labor.
I think our time is up, so we can just
and after delivery, we will do active management of third stage of labor also.
Yeah. That is
and prevention of PPH.
Yes, ma'am, to prevent PPH.
And maintain asepsis because they are more prone to infection, postpartum infections also.
Yes, ma'am.
Maintain hydration in the postpartum because they are also more prone to embolism.
Yes, ma'am.
Anemic patients.
Yes, ma'am.
So I think our time is up.
Yeah, time is up. Set is ready.
Yeah.
So, but I think anemia is something, which all of you will get. Somebody or the other will definitely get a case.
Thank you very much, Dr. Achla, Dr. Radhika, and Dr. Ratna for a great discussion regarding the case of anemia in pregnancy. I think this is a very important topic and every PG should know each and everything about the anemia because in the case, always there will be one case of anemia. I think it was a very great discussion but every PG should be prepared with the anemia in pregnancy case. Thank you, Dr. Achla, Dr. Radhika. So I think we should move for the next case.
Thank you for giving the opportunity.
Yeah, thank you very much.
Thank you so much.
Bye. Bye.
Thank you. Yeah. So now we are moving to another case. That case will be presented by Dr. Payal and Dr. Maria, which is case of hypertensive disorder in pregnancy. And for the case discussion,
my MOCs had Madam joined because she was having some problem with the link, Dr. Purnima.
Excuse me, am I audible?
Yes, ma'am.
Yes, you are.
Other
Yes.
sound coming in background.
Yeah, so now I invite Dr. Payal and Maria for the presentation of case on the hypertensive disorder in pregnancy. And for the discussion, I invite moderators. Dr. Girja Wagh. Dr. Girja does not need any introduction. She is Foxy Vice President-elect for 2024. She is Professor and HOD Department of Obs and Gynae in Bharati Vidyapeeth Medical College, Pune. Dr. Girja, are you around? Dr. Girja is around?
Yes, she's being seen.
You have to unmute yourself, Dr. Girja.
Doctor of Gestosis since 2014.
Yeah.
A member of the Central
Hello.
Supervisory Board.
Hi.
Yeah. You are around, Dr. Gidja?
Yeah, I'm very much there. Thank
Yeah,
you so
you are
much.
welcome. Yeah, you are welcome here for the case discussion regarding the hypertensive disorder in pregnancy. And now I invite Dr. Shashi Lata Kabra. Dr. Shashi Lata is Senior Specialist, Department of Ops and Gynae, DDU Hospital. And I invite Dr. Surekha Tayade. She's a professor, unit head from the Jawaharlal Nehru Medical College, Swangi, Wardha. So I think all the moderators are around.
Yes.
Yeah, so now, so all is to you, and Dr. Payal will present the case of hypertensive disorder. Dr. Payal, are you around?
Yes, ma'am.
Dr. Payal?
Yes, ma'am, we are around. We are sharing the screen.
Yeah, so you can present your case. Dr. Payal, you are not audible.
Yes, ma'am. Ma'am, we have shared the screen.
Is there any problem?
No, no, ma'am.
Yeah, so be loud.
Yes, ma'am.
Yeah. Present your case.
Good evening, everyone. Today's case is hypertension in pregnancy, presented by Dr. Payal and Dr. Maria. She is ex-28-year-old female, resident of Patel Nagar, New Delhi. She is a housemaker.
Please change your slide. Change your slide.
Yes, ma'am.
Payal, your slides are not moving. Your slides are not moving.
Ma'am, we are...
Click on enable editing, then show your full screen. On the top, there is option enable editing.
Are you okay, Payal?
Yes, ma'am, we are sharing, ma'am. Second. Give us
Yeah.
one. Ex-28-year-old female, resident of Patel Nagar, New Delhi. She is a housemaker belonging to upper middle socio-economic class according to modified Kuku scheme. Married since 2020. Primi gravida, her last menstrual periods were on 18th April 2023. Her expected date of delivery was on 24th January 2024. At the time of admission, her period of gestation was 34 weeks, 2 days. She is a known case of gestational hypertension. She presented with 8 months of amenorrhea, routine antenatal visit, when her BP was found to be high, around 150 by 100 mm Hg with proteinuria.
Dr. Payal, be slow and okay. Yeah.
Yes, ma'am. History of presenting illness. Patient came to antenatal OPD for routine checkup at 8 months of amenorrhea. Her BP was taken, which came to be high according to the patient as told by the doctor, and she was advised admission for further evaluation and monitoring. There was no history of headache, blurring of vision, epigastric or right upper quadrant pain. No history of vomiting, no history of chest pain, breathlessness on exertion and palpitations. No history of decreased urine output. No history of swelling of feet or excessive weight gain. No history of pain in abdomen, leaking per vaginum or bleeding per vaginum. First trimester. She had spontaneous conception. UPT was done at home when patient was 10 days overdue, which was positive. She visited SGRH at 2 months of period of gestation. She was advised antenatal investigations, which reported to be normal. She was advised tab folic acid, which she took.
Little louder, Payal.
Okay, ma'am. USG rating scan was done, which was normal, corresponding to the LM. NT-NB scan was done, which was normal, but uterine artery PI was high. Tab ecosprin 150 mg once daily was started.
There was no history of excessive nausea or vomiting, no history of fever with rash or burning micturition, no history of bleeding per vaginum, spotting per vaginum, discharge per vaginum, no history of drug or radiation exposure. In second trimester, quickening at the she felt quickening at 5 months of amenorrhea. She was booked at SGRH and immunized against tetanus at 4th and 6th months of gestation. Second ultrasound with 5th month level 2 scan was done, which was normal. There was history of regular intake of tab iron, folic acid, calcium, and ecosprin daily. The history of high BP records for which tab labetalol 100 mg twice daily was started. There was no history of epigastric pain, blurring of vision, headache, decreased urine output, and swelling of feet. No history of excessive hunger, thirst, frequency of urination, and recurrent UTI. No history of easy fatigability, dyspnea on exertion, palpitations, chest pain, and syncopal attack. No history of fever, bleeding, or leaking per vaginum. There was history of two visits, antenatal visits in second trimester. Third trimester, patient continued to perceive adequate fetal movements. There was history of intake of tab, iron, and calcium and ecosprin regularly. No history of leaking and bleeding per vaginum. No history of excessive thirst, hunger, or urination. No history of blurring of vision and epigastric pain. No history of yellowing of skin, sclera, or itching over the body, and discoloration of urine or stool. No, on her second visit in third trimester at 8 months of amenorrhea, she came to antenatal OPD for routine checkup. Her BP was taken, which came to be high, around 150 by 100 mmHg. She also developed proteinuria and was advised admission for further monitoring. Patient did not have any complaints of nausea, vomiting, headache, blurring of vision, epigastric, or right upper quadrant pain. Her menstrual history. She attained menarche at 14 years of age. Her LMP was 18 April 2023. EDD was on 24th January 2024. She was sure of dates. Her previous menstrual cycle was regular, occurring at 28 days interval, lasting for 3 to 4 days. She had average flow, soaking 2 pads per day, and associated with mild dysmenorrhea. Obstetric history. She was married since 2020. She is primigravida, had spontaneous conception. Patient was using barrier contraception on and off. Past history. She is not a known case of diabetes, hypertension, heart disease, SLE, renal disorder, asthma, and there is no history of tuberculosis. No history of any other prolonged medical or surgical illness. Personal history. She had regular, normal sleep pattern, no addictions, no smoking, non-smoker, non-alcoholic, no history of drug abuse, no bladder or bowel complaints, no known allergies. History of hypertension, family history. She had her mother had hypertension 10 years back, which was controlled on oral medications. Diet history. Mixed diet. According to 24-hour recall method, calorie intake was 2600 kilocalories per day and protein intake was 60 grams per day, which is adequate. She belonged to upper middle class according to modified Kukuswami scale.
General physical examination. Skin comfortably, conscious, cooperative, well-oriented to time, place, and person. Average build and well-oriented, well-nourished. General condition fair. Height 160 centimeter. Weight 64 kg.
Your sound volume is very low. Can you use some microphone or can increase the volume?
Come closer to the machine. Then you'll be heard.
Is it okay now?
Yeah. No, your Payal, there is some problem with your laptop.
No, she has to come closer. Come closer, you'll be heard. Come closer, beta, to the speaker.
Weight 52 kg, BMI 20.3. Head to toe examination. General condition fair, febrile to touch, hydration adequate, no pallor, icterus, cyanosis, clubbing, no chiliosis, glossitis, bilateral pedal edema present, grade 2 pedal edema. Orodental hygiene maintained, no palpable lymphadenopathy or thyroid enlargement, JVP not raised, breast showing normal changes of pregnancy, no inverted nipples. Temperature 98.6 degree Fahrenheit, pulse rate 86 per minute taken in right radial artery, good volume, regular, no radial or radiofemoral delay, all peripheral pulses palpable. SpO2 was 98% on room temperature, BP 150 by 100 millimeter of mercury in
So,
right
Payal,
arm
please
and one.
tell us what is the definition of gestational hypertension? What is the
Ma'am,
normal BP and what is the cutoff?
Yes, ma'am, gestational hypertension is systolic BP more than equal to 140 mmHg and diastolic BP more than equal to 90 mmHg in a previously normotensive women measured on two occasions 4 hours apart. And it also returns to normal within 12 weeks postpartum.
Yes.
first
So it can be
diagnosis
either more than 140 or equal to 140 or more than 90 or equal to 90.
Yes, ma'am.
What is made you say that your patient had gestational hypertension, Payal?
Ma'am, can you repeat
Why
the
are you
question?
saying that your patient has gestational hypertension? You have been mentioning it twice, you said in your history. You said your patient has gestational hypertension. Why?
Ma'am, she had BP which was more than 140 by 90 mmHg. We checked it twice on two occasions, 4 hours apart.
When?
And after
At what
it was diagnosed.
gestational age?
Ma'am, after 20 weeks of gestation, it was diagnosed.
After 20 weeks, when?
Ma'am, around 24 weeks.
At 24 weeks, she had BP rise. And then
Yes,
you
ma'am.
started her on labetalol.
Yes, ma'am.
So tell us the classification of hypertension. Which category will you put in gestational hypertension and which one in pre-gestational? Tell us the classification.
Ma'am, classification of hypertension is gestational hypertension, then preeclampsia, eclampsia, then chronic hypertension, then preeclampsia superimposed on chronic hypertension.
And you have mentioned in your history, primary gravida, no history of a spontaneous conception, maternal history of hypertension. What does this all signify?
Ma'am, primary gravida is a risk factor for preeclampsia, and spontaneous conception I have mentioned because ART, if the pregnancy is by ART, then that is also a risk factor for preeclampsia.
Yeah.
And maternal
And
history,
even if the mother or sister is had preeclampsia, then this is an important
that is
history.
also a risk factor.
Yeah. And you have mentioned that uterine Arti pulsatility index. So what is the significance?
Ma'am, that is the predictor for preeclampsia. If the uterine artery pulsatility index is more than 90 percentile for that gestational age, then it is risk factor. Then it is predictor for preeclampsia.
So what are the other predictors of preeclampsia? This is a very important burning question nowadays.
Ma'am, one of the predictor is if the mean arterial pressure is more than 90 and if SFLT to PLGF ratio is high and if PAP-A is low. These are few predictors.
Any clinical or medical predictors? These are biochemical.
Yes, ma'am. Ma'am, ma'am, excessive weight gain during pregnancy.
BMI more than 30, and then even
BMI
births
more
when
than
it
30.
is more than 35. In interpregnancy interval, if the interpregnancy interval is big, more than 5 years, then it becomes a high risk factor. Payal, are you able to hear? I'm not able to hear you.
According to history, also we can find if she is prone to developing preeclampsia.
So you've started aspirin. So
Yes, ma'am.
what is the indication for starting aspirin and what is the dose?
Ma'am, dose is 75 to 150 mg once daily, taken at night. And indication for starting is, ma'am, aspirin trial was done, and according to that, if we start aspirin, then there is 62% reduction in developing of preterm preeclampsia.
Basically, what is the pathology that's behind preeclampsia?
Ma'am, pathology of preeclampsia is if there is absent vascular remodeling, if the cytotrophoblastic invasion is not, if there is abnormal cytotrophoblastic invasion due to increase
No,
in
you describe it as there is failure of secondary trophoblastic invasion of the spiral arterioles.
Yes, ma'am.
So what happens because of that?
Ma'am, because of that there is placental ischemia, and because of that there is a narrowing of spiral arterioles, and there is high resistance in spiral arteriole. Because of that there will be uteroplacental insufficiency, which will cause placental ischemia.
Yeah, exactly what happens that this tunica media is not replaced by endothelial cells. So there is a resistance in the vessels and that leads to ischemia. And this is called fetal syndrome.
Yes, ma'am.
So then this is half answer. So what is preeclampsia syndrome?
Ma'am, after that there is endothelial injuries, and because of that there will be capillary leakage.
No, that's the fetal syndrome. And in response to the fetal syndrome, the mother responds. And that is the maternal syndrome. And mother responds by production of anti-angiogenic factors, which leads to generalized vasoconstriction and capillary leakage. So it is to be understood like this.
Yes, ma'am.
Carry on.
And ma'am, aspirin balances the level of thromboxane A2 and prostacyclin. So by decreasing vasoconstrictor and increasing vasodilator, it helps in preventing preeclampsia.
Yes, the only preventive method for preeclampsia. Yes. And there is one more method, one more medicine which we can give for prevention of.
Ma'am, in case of low calcium intake population, we can give calcium. 1200
yes, if the calcium intake is low, then we can give 1 to 1.5 gram of calcium daily to the mother. It may decrease her BP, right? Next, carry on.
Systemic examination, respiratory system, bilateral air entry present and equal, CVS apex beat in fourth intercostal space in left axillary line, S1, S2 normal, no murmur heard, central nervous system, no sensory motor deficit, all reflexes normal. Abdominal examination, inspection, abdomen is uniformly distended, no abdominal wall edema, uterus ovoid in longitudinal axis, umbilicus is central everted, linea nigra and stria gravidum present.
Come near to the microphone.
All quadrants moving equally with respiration. All hernial sites are free, no dilated veins or scar marks.
Yeah.
Palpation, local temperature not raised, no organomegaly, uterus corresponding to 32 weeks size, relaxed, dextro-rotated, SFH 32 centimeter, uterus relaxed, non-tender, fundal
So
grip.
what is the significance of this symphysial fundal height in a case of gestational hypertension or preeclampsia?
FGR.
Ma'am, it is clinical indicator for FGR.
Yeah, the sensitivity is around 80%. It is one of the best screening method for fetal growth restriction, and many a times we may get fetal growth restriction in case of gestational hypertension and preeclampsia. Next.
Fundal grip soft, broad, and irregular, non-ballotable podalic end was palpable at fundus, suggestive of buttocks. Left lateral grip smooth, curved part suggestive of back. Right lateral grip soft, knobby part suggestive of limbs. Superficial pelvic grip hard, globular, round, ballotable part suggestive of head. Deep pelvic grip converging, suggestive of non-engaged head. Uterus relaxed, liquor appear clinically adequate. EFW 1.6 kg. FSH heard along the left spino-umbilical line, 144 beats per minute regular. Local examination, no bleeding present, no leaking PV, no discharge per vaginum. Per speculum, per vaginal examination not done. Investigation, blood group B positive, viral markers non-reactive, urine routine microscopy, protein plus, urine culture sensitivity, no organism found. 75 gram glucose, 2-hour OGTT, 24 done at 24 weeks was 116 milligram per deciliter. TSH 3.16. Hemoglobin 13.1, platelet 1.98 lakh, TLC 12,600, bilirubin 0.9 milligram per deciliter, AST 28, ALT 27, BUN 12.6, serum creatinine 0.6, ET 9.5 seconds, INR 0.86, APTT 32.6, total protein 6.3 gram deciliter, serum albumin 3.6 gram per deciliter, LDH 370, 24-hour urine protein 600 milligram in 24 hours, Urine PC ratio 2.45, fundus normal, ECG within normal limits. Forced urine hospital.
Yeah, carry on. So, what is the correct method of BP measurement?
Some correct method of BP measurement is after the rest of 10 to 15 minutes, BP should be measured in
5 minutes,
sitting or
5 minutes.
okay, ma'am. BP should be
Yeah.
measured in sitting or semi-reclining position with feet supported. And patient should not have taken caffeine or tobacco 30 minutes prior the BP measurement. And arm should be at the BP should be measured in both the arms at the first antenatal visit. Arm should be at the level of heart.
And the leg should not be crossed.
Yes, ma'am.
And if the patient is lying, then you can take in semi-reclining position.
Yes, ma'am.
And about the, will you tell anything about cuff details? What size of cuff is required for what circumference of?
Ma'am, length should be
Arm.
0.5 times the circumference of upper arm circumference, and width should be 40% of arm circumference, and it should
Actually,
encircle.
the inflatable bag should cover 80% of the arm circumference. Yeah.
And
And
it should encircle 2/3 of arm.
And where do you use a thigh cuff?
Ma'am, in case of obese patients, if the arm circumference is more than 33 centimeter, then we can
More
use
than
that.
44 centimeter. 33 is normal. If it is more than 44 centimeter, then you use thigh cuff.
Okay, ma'am.
So this is very important because sometimes we fail to measure BP correctly and this may misinterpret. And which correct type do you use for normal BP measurement?
Ma'am, 5. If 5 is not heard, then 4.
Yeah, correct. So some new terminologies have come up like white coat hypertension, delta hypertension. So can you elaborate on that? Masked hypertension.
Ma'am, white coat hypertension is when the BP is normal at when the BP is high in office or clinic setting, but normal at home.
More than 140 by
More,
90.
So what is the significance? What is the significance of patient having white coat hypertension?
Ma'am, these patients have tendency to develop hypertension in future.
Preeclampsia and complications of hypertension, right?
Yes, ma'am.
And what is delta hypertension?
Delta hypertension is
What is mean arterial pressure?
ma'am, mean arterial pressure is systolic BP plus 1/3 of pulse pressure.
Systolic BP? No.
Ma'am, systolic BP.
Diastolic BP plus systolic BP minus diastolic BP divided by 3.
Yes, ma'am.
So that is the mean arterial pressure. So in delta hypertension, there is a sudden rise of mean arterial pressure. In spite of that, this patient is still having BP below 140/90, the cutoff. So these patients are at higher risk of gestational hypertension, preeclampsia, and its complications. So it is not only that BP should be more than 140 or 90. If any sudden rise of BP is there with higher MMFG, even then that is risky.
Yes,
So next, carry on. So you have given labetalol to this patient. So you tell me the chemical nature of labetalol, the dose of labetalol, the side effects of labetalol, contraindications of labetalol,
yes,
and the highest dose of labetalol.
Labetalol is alpha-1 blocker and non-specific beta blocker. Initial dose is 100 mg twice daily, and maximum dose that can be given is 2400 grams.
2400
milligrams.
Yeah.
Yes, ma'am. Contraindication is, ma'am, in case of bradycardia, congestive heart failure, heart blocks, and asthma and COPD.
Yeah, because it leads to severe bradycardia, which is never given like in bradycardia, right? So there we can give. Can you give some other medicine?
Yes, ma'am. Nifedipine can be given if.
Yeah, nifedipine should be, which preparation of nifedipine should be given?
Immediate release.
Immediate release. How many preparations of nifedipine have?
Ma'am, 3: extended release, sustained release.
Sustained release, intermediate release, and immediate release. In gestational hypertension, we use only the immediate release. And I would like to talk about alpha methyl dopa also, though it is now not available in market, but 250 milligram dose it is a time-tested drug, and we used it for years and years, alpha-methyl-dopa, in gestational hypertension.
Yes,
And what are the what you have talked about contraindications and maximum dose? Yeah, so you have covered labetalol, right? So carry on.
Post during hospital, her BP recordings were persistently more than 140 by 90 mmHg. Dose of tablet labetalol was increased to 200 mg thrice daily. BP monitoring done every 4 to 6 hourly. Fetal monitoring done. Gradual increment of tablet labetalol to 200 mg 4 times daily done. She had been perceiving adequate fetal movements. BP remained uncontrolled despite adequate doses of 2 antihypertensive, and she complained of excruciating headache not responding to painkillers.
So what
On
is
day
the
4
significance of this excruciating headache?
Ma'am, it is sign of impending eclampsia.
So what are the other signs of impending eclampsia?
Headache, epigastric pain, blurring of vision.
It can be an epigastric pain or a right hypochondrial pain.
Right hypochondrial.
Blurring of vision, and what else?
Nausea, vomiting.
Nausea and vomiting. Out of these, blurring of vision and headache are most important. They are very immediate sign of impending eclampsia. So next.
Now you also mentioned fetal monitoring done. What do you mean by that? What fetal monitoring did you do?
Ma'am, ultrasonically surveillance was done. We did ultrasound fetal well-being Doppler for this patient. As the Dopplers were deranged in this patient, we were doing the Doppler ultrasound twice weekly.
Twice? Dopplers twice in a day?
No, ma'am, weekly.
Twice weekly. So now she was in the hospital for how many days since the first time you diagnosed her proteinuria?
Ma'am, for 4 days.
So twice weekly is not out of question, no? So you did it at the time of admission. And on a daily basis, what fetal monitoring was going on?
Ma'am, NST monitoring was done.
So what are the changes in NST if you are taking these 2 types of antihypertensive?
Ma'am, there can be loss of beat to beat variability. And there can be fetal bradycardia also.
Oh, sometimes, yeah, that may be possible, but then, yeah. So now here you were saying not responding to painkillers. What painkillers you have given her? You're saying that there was headache which was not responding to painkillers.
Ma'am, we gave her acetaminophen.
Why acetaminophen?
Because it is a safer drug.
It is safer. Why it is safe?
Ma'am,
what are you concerned about? Which are the 2 organs you are concerned about in this patient?
Ma'am, liver and kidney.
Absolutely. So in here, if acetaminophen doesn't work, is there any other medicine which you can give for analgesia?
Ma'am, tramadol.
Tramadol. So despite giving these, she did not respond.
Yes,
and then you have mentioned that you found that there was AEDF. What do you mean by AEDF?
Absent end diastolic flow.
What does that imply? Absent end diastolic flow means what?
Ma'am,
What
there
does
is
it mean?
increased resistance and
There is
increased resistance, ma'am.
Increased resistance is uterine artery pulsatility index. AEDF means what? How does it categorize the fetal growth restriction as? 1. And what does it mean? How much is the morbidity, fetal morbidity associated with? How much hypoxia can happen?
Ma'am,
Yes.
it signifies hypoxia, and in this diastolic flow is decreased.
Yeah, so end diastolic flow is important for tissue perfusion. You understand, the baseline tissue perfusion itself is absent. That means the baby is definitely going into hypoxia, yet not gone into acidosis. So this is the time that you have wisely decided to deliver her. Okay, but then how did you deliver her?
Ma'am, we did cesarean section for this patient.
Any reason why? What was the rationale of doing a C-section?
Ma'am, as she had already developed AETF, there was more, she was at more risk of fetal hypoxia. She could not take the stress of normal vaginal delivery. That is why.
You can't call it as normal vaginal delivery at this gestational age anyways.
Preterm vaginal. Yes,
So
ma'am.
what you would say, you should use your terminology a little correctly. So vaginal
Yes.
birth, the duration of the vaginal birth and the uterine contractions. What will happen when there are uterine contractions and the baby with AEDF is sitting inside the uterus? If the uterus contracts, she goes into labor pains. Okay, let's say there is uterine contraction. You decided to induce her and the uterus contracted. What will happen to the baby?
Ma'am, can you repeat the question, please?
See, if there is myometrial contraction, as it would happen, let's say we decided to induce labor and she started having uterine contractions. You
Yes,
understood
ma'am.
this part of the question?
Yes,
What
yes,
will
ma'am.
happen to this baby?
Ma'am, there can be fetal hypoxia, further fetal hypoxia because of contraction of the vessels.
Fetal hypoxia is already there because of AEDF. There will be severe fetal distress, acidosis, and a high risk of intrauterine death or stillbirth.
Yes,
Isn't
ma'am.
it? So what
Yes,
do you
ma'am.
want to do now? Therefore, you have done a cesarean section. Now, what was the gestational age at which you have done this cesarean section?
Ma'am, 34 weeks, weeks, 5 days.
So what are the risks of this baby when it is going to be born? With an AEDF, with a very high chance, about 80 to 70% hypoxia, and 34 weeks of gestation.
Ma'am,
So what are the morbidities this baby will have?
ma'am, prematurity and
One, prematurity. Two,
respiratory distress. Ma'am, baby can have respiratory distress syndrome and
okay,
intraventricular hemorrhage,
yeah,
necrotizing
enterocolitis. Yeah. So now we are more concerned about now immediately pain birth issues, isn't it? When the baby is going to be born. How will you prevent these complications? Can you try to prevent these complications?
Ma'am, by giving corticosteroids.
One
Low
is
maturity.
corticosteroid. Yeah. So have we given corticosteroids in this patient?
Ma'am, at 32 weeks of gestation, corticosteroid was given.
Were given. So now after 4 days, after 14 days, when she decided to deliver, is it essential to repeat one or that was enough?
No, ma'am. No, ma'am, it is not essential.
It is not essential within 14 days to repeat, isn't it? You may consider a rescue dose only after 20 to 21 days if essential. Anything else could be done at 32 weeks because that time also the delivery was imminent, but we decided to stabilize her.
For neuroprotection, magnesium sulfate.
What is the dose of magnesium sulfate for neuroprotection?
20.
Dose of magnesium sulfate for neuroprotection?
4 grams.
Is 4 gram enough? So 1 gram per, yeah, there's no need of giving a loading or anything. No? 1 gram per hour is also fine for 24 hours.
Yes.
Are you understanding? So that will be your neuroprotection. And now any precautions if you decided to do a C-section, because you don't want the mother as well as the baby to be jeopardized. What are the precautions you would take while doing a cesarean delivery in a patient of preeclampsia who is having hypertensive crisis?
Ma'am, we have to arrange adequate blood products.
Okay, that is preparation. Anything else you will do?
And ma'am, during after delivery of baby, we do not have
Nay.
to give methyl ergot.
Before that, what will be the anesthesia that you will perform? Give which anesthesia?
Regional anesthesia is preferred.
Regional which? There are 2 types of regional anesthesia we can give.
Epidural.
You will choose an epidural anesthesia, but sometimes always epidural anesthesia is not available in all parts of a country. So which is the other alternative?
Spinal anesthesia.
Spinal. What precautions will you take when you are giving a regional anesthesia? What will happen when you are giving spinal anesthesia in these patients? There'll be blood pooling, no? There can be hypotension, which can affect both the mother as well as the baby. So you have a small preemie who has an absent and diastolic flow, and you are giving spinal because that is essential, that is safe also. So how will you try to prevent jeopardizing baby further? What precaution will you take while you're giving the spinal anesthesia? What will you do? There is a concept of co-load. Do you know what is co-load?
No, ma'am.
Or preload? Have you heard preload,
Yes,
co-load?
ma'am, hydration IV fluids of that should not exceed 60 to 80
Yes.
ml per hour.
Yeah, so you will give her adequate hydration before she is taken for anesthesia. That is one. You may consider giving her DVT stockings beforehand so that her peripheral pooling will not occur. And the moment the anesthesia is fixed, you can give her a semi-reclined position so that by the time you're doing painting and delivering the baby's perfusion will be properly maintained. Understood? Because this is a small baby. Now, delivering a small baby, you will take a big incision, isn't it? While you may have to take a little compromised incision on the uterus. Okay. So where will you take incision on the uterus so that you cause less jeopardy to the baby? 34-week size. Lower uterine, of course, but where on the lower uterine segment? Is the lower uterine segment well formed in this patient?
No, ma'am.
No, it is not very well formed. So now where do I choose to take the incision?
I'm on most dependent part of
That is, that nose dependent part is a very narrow part. No, it's a most narrowest part.
Yes, ma'am.
And how will you then manipulate through that and deliver this small little baby? So on the, how do you identify the lower uterine segment? How is lower uterine segment identified?
Ma'am, for that fold of peritoneum.
The loose fold of peritoneum which is attached to it. So when the attachment starts from above, the most upper part of that attachment is the widest part of the lower uterine segment.
Okay, ma'am.
So about 1 centimeter to 2 centimeter below that part, you can take your incision so that you get an advantage of the widest diameter and you are able to manipulate this baby better, isn't it?
Yes, ma'am.
So these are the important things that one has to remember.
Yes, ma'am.
Okay.
So,
then
Payal, you
now,
have said that, okay, ma'am.
And what
Carry
about the blood loss? Now, if let's say the patient has soaked while you are doing all this, she fully soaked 4 regular mops, surgical mops. How much is the blood loss?
Ma'am, 80 ml into 4, that will be 320 ml.
Okay, now 320 ml blood loss of this patient. We saw her body mass index and her weight. What will you look for? Whether this patient, because now you have given her spinal anesthesia, you are taking a patient of hypertensive disorder for C-section. How will you identify shock? Whether she's losing more blood, whether she's going into hemorrhage.
Ma'am, if the BP is falling and patient is having tachycardia.
Yeah, so you have to be aware of this, that her tachycardia may not reveal immediately because she has been taking labetalol for a long time in a high dose.
Yes,
so you will have to be very, very wary about how much blood she's losing. Even little blood loss will quickly go into shock. Because why? She already has a compromised intravascular blood. Isn't it? Against the regular 6.5 liters, this woman must be having only 3 to 3.5 liters in her body. So even if she loses little, she will go into exsanguination and you may not be able to diagnose it. You understand? So you have to be on watch for this, how much blood loss is happening, so that you can quickly give her some sort of a replacement or maybe at least, ensure that she's not bleeding too much. What kind of oxytocin can you use in her? So that she doesn't, because there's high likelihood that she will bleed and have atony, plus you have caused trauma by doing a C-section. So which oxytocin?
Ma'am, oxytocin, carbitocin can be given and ergot derivatives are avoided.
Yeah. Now you have given her oxytocin active management. You gave her. How is the dose given? Oxytocin active management?
Ma'am, 10 units after the delivery of fetus, baby.
Baby. Now, is
Within
this going
1
to be
minute.
enough? Is it
No,
going to
ma'am.
be enough?
No, ma'am.
Then what will you start? Prophylactically, you will have to take care, because we don't want her to bleed. So prophylaxis, you gave her 10 units intramuscular, and we know it's not going to be
And
enough.
20
So we will.
units.
So you said one drug, carbitocin. So you'll give 10 units oxytocin. You are justified by giving a carbitocin here, because currently, even if the trials are going on, carbitocin holds true only for prevention of PPH. Understood? It is not for therapy as yet. So you can consider giving carbitocin for sustained action.
Okay.
Understood? Now, if she still bleeds, she's still continuing to ooze and bleed, or can you give something else prophylactically as well? Apart from oxytocin, is there some other drug which can help us in this situation?
Tranexamic acid, 1 gram.
Tranexamic acid. Yes, we can consider giving 1 gram of tranexamic acid. And any other drug? You can, carbitocin we discussed, oxytocin, carbitocin ho gaya. Then what can you escalate as the third choice? You can give her carboprost, isn't it? Is there any contraindication for
Ma'am, we
sublingual
should
or
not use carboprost as prophylaxis of postpartum hemorrhage.
not as prophylaxis, as treatment, only for
Only as
therapy.
treatment.
Yeah, only as treatment. That's what we said. She's still bleeding. I said she's bleeding now. So then what will you do? Okay, so I think that's my set of questions. Now let's move on again.
Yeah. So, Payal, you have mentioned that this patient had proteinuria. So besides proteinuria, there are some other lab signs also for diagnosing a case as to be severe preeclampsia. So what are those signs? Because you mentioned about those investigations. So what abnormality can you get?
Ma'am, if there is thrombocytopenia, then if the LFT is deranged, ALT and
No,
AST
thrombocytopenia value. You have to mention the value. How much below?
Ma'am, less than 1 lakh.
Yeah.
If ALT and AST are raised more than twice the normal value, and if serum creatine is raised more than 1.1 mg per deciliter or twice the normal value.
And even if there is pulmonary edema, then that too is also a clinical sign. That too means severe preeclampsia. So is there any role of peripheral blood smear?
Ma'am, in case of HELLP syndrome, there is hemolysis, then cystocytes and blood cells can be identified in peripheral smear.
And helmet cells, yes.
Yes, ma'am.
So it may give you an idea about hemolysis actually. So we have to get this routinely done. So let's discuss a little bit about eclampsia. So can you tell me what does eclampsia mean?
Ma'am, eclampsia is generalized tonic-clonic seizures, which developed in case of a female who is having high BP, increased breathing.
And it is said that after 20 weeks, if any female develops convulsion, this is to be taken as a case of eclampsia unless proved otherwise. Okay. So what is the management of eclampsia?
Ma'am, magnesium sulfate is given. Loading dose of 14 grams.
No, first you tell me the generalized management, ABC.
Yes, ma'am. Ma'am, we have to stabilize the patient. We have to prevent the injury. So mouth gag is kept to prevent the tongue bite. Side
You
railings
have to
are
place
raised.
the patient in left lateral position.
Left lateral position.
With a railed cot. Yeah, you pull up the rails of the cot. Yeah.
Suctioning of mouth is done. To oxygenation, 8 to 10 liters per minute is started. And
you have to shout for help also because you need help. And then?
Then, ma'am, magnesium sulfate is given prior to antihypertensive.
Okay, so what is the dose and how will you prepare it?
Ma'am, loading dose is 14 grams. According to Pritchard's regime, loading dose is 14 grams. 4 gram, 20% MgSO4 is given IV, and then 10 grams is given in each 5 gram in each buttock. 50% of MgSO4 is given intramuscularly.
Okay, you tell me how will you prepare the IV solution, that 4 gram IV, 20% solution?
Yes, ma'am. Ma'am, in one vial there is in 2 ml there is 1 gram of MgSO4. So we'll take
Which
8
one you are
ml.
using, 25% or 50%?
Ma'am, 50%.
50%, okay.
And we will mix
So
it
how
with
many ampoules of 50% will you take?
Ma'am, 4.
4 ampoules of 50% you have taken because that contain 4 gram. And then what will you do?
Ma'am, we will mix it with 12 ml NS to make it 20 ml. Then it will be 20%.
And how will you give it? Slowly, fast, bolus?
Slowly, ma'am. Slowly.
Slowly. 1 ml per minute you can give. Okay. So that's about intravenous dose. And about intramuscular dose?
Ma'am,
how many ampoules will you take for one side?
Ma'am, it is 10 grams, so 5 vials.
5 ampoules for one side.
Yes. For one
Yeah.
side from 2.5. 2 vials.
No. Total you are using 14 gram.
Yes,
So 4 gram you have use is an intravenous and 5 gram each for intramuscular. So on each buttock you are using 5 ampoules. So total 10 ampoules you are using. It is not 2.5.
Yes, ma'am. Yes.
That means you have never given. You have never given magnesium sulfate to your patient. Am I right, Payal? 5 gram to be given in one buttock, 5 gram to be given in another buttock. Though root is intramuscular, and you have to mix lignocaine, 1 ml of 2% lignocaine, because what happens to the patient? If you give, because the amount is 10 ml, it is a huge amount for intramuscular dose, right? 5 gram magnesium sulfate means 2 ml, 10 ml. So what happens to the patient?
Ma'am, to avoid pain, we mix.
You have to tell, it is a painful injection, you have to tell the patient that it will cause little warmth.
Yes, ma'am.
Some heat sensation. So that's why you are giving lignocaine and you have to tell the patient. Okay. So the amount is huge. It is 10 ml in one buttock.
Yes,
and then next?
Ma'am, next is we will give her antihypertensives, injection labetalol.
Yeah, you first complete magnesium sulfate. Then next, after how many hours will you give?
Ma'am, after 4 hours, after checking for deep tendon reflex, respiratory rate, and urine output, we
So
will
this time, will you give in both the buttocks or a single buttock?
I'm single buttock, alternate buttock.
5 ampoules. That means only 5 ampoules in one buttock, right?
That's a neat
And how long it to be continued?
Ma'am, till 24 hours after post delivery or till after 24 hours since the last seizure, whichever is later.
Whichever is later. So how will you monitor magnesium sulfate?
Ma'am, we will check for the magnesium sulfate toxicity by checking for respiratory rate, urine output, and the patellar reflex.
Okay, so which one is the first sign to go in magnesium toxicity?
Ma'am, patellar reflex.
Yeah, deep tendon jugs, patellar reflex. So can you tell me the therapeutic level of magnesium sulfate?
Ma'am, 4 to 7 milliequivalents per liter.
And when it is more than 7, then the patellar reflex goes, right?
Yes.
So when does the respiratory rate come down?
Ma'am, after 10 milliequivalents.
Yes. And complete cardiac arrest can occur at 25.
25 milliequivalents.
Yeah. And what should be the minimum urine output?
30 ml per hour, ma'am.
Okay, suppose a case has come to you with history of convulsion outside at home, and you do not know about her urine output. So will you give her magnesium sulfate loading dose?
Yes, ma'am. Yes, ma'am.
Why?
Ma'am, our priority is to stop the seizures at first. Then we will.
So at first you will always give the loading dose, and you monitor urine output for further doses.
How much is the serum level after a loading dose? You're given 4 grams of magnesium sulfate. How much serum level is achieved with that? When you're given it in that 20 minutes precautions?
Ma'am, 5 to 6 milliequivalents.
Yeah, because that's the therapeutic dose. So that's enough to get those levels. You need not have the urine output know-how for that. because anyways magnesium, you know, it doesn't cause nephrotoxicity, but it is excreted from urine. That's the reason why you want to. Understood? Any other alternative ways of giving magnesium sulfate?
Ma'am, there are different regimes, Juspan regime, Sibai regime, Dhaka regime. These are
What
IV
are you
regimes,
doing in
ma'am.
your institution? How are you giving in your
Ma'am,
what regimen?
Pritchard.
You're using the Pritchard's regimen.
Pritchard regime, ma'am.
Pardon? Pardon?
Pritchard regime.
They are using Pritchard regime, yeah.
Okay.
So even in severe preeclampsia, you give magnesium sulfate. So what is the dose there? In severe preeclampsia, patient has not yet started convulsions.
Same dose.
Yes, Payal?
Ma'am, same dose. Same
Yeah, there
loading
is
dose,
no
ma'am.
difference in the profile, in the dose of prophylaxis and the loading dose of therapeutic magnesium sulfate. It is always the same.
Yes, ma'am.
So what is the mechanism of action of magnesium sulfate?
Ma'am, it inhibits the release of neurotransmitter glutamate, that is excitatory neurotransmitter. It also blocks the glutamate NMDA receptors. It also blocks the entry of calcium via the voltage
These
gated
are
channel.
biochemical and theoretical things. One very important thing is that the conversion is due to cerebral vasoconstriction and it causes cerebral vasodilatation.
Yes, ma'am.
Right? It causes cerebral vasodilatation. So so magnesium sulfate is almost complete. Now coming to other medicines, you have given a labetalol, right?
Yes, ma'am.
So if it is a severe hypertension, what is the dose of labetalol and how will you proceed?
Ma'am, we will start with 20 mg IV dose, and if the BP is after 10 minutes, if the BP is not settled, then again 40 mg is given. Then after again 10 minutes, 80 mg followed by 80 mg can be given, and maximum dose is 300 mg, which we can give.
Can you name some other antihypertensive which can be used in severe hypertension?
Ma'am, nifedipine tablet can be given, and IV hydralazine can be given.
Nifedipine should be immediate release. And what is the initial dose?
Ma'am, 10 mg.
10 mg. Okay.
And in case of pulmonary edema, nitroglycerine can be given.
Okay. Would you like to give furosemide in any case?
Ma'am, in case of congestive cardiac failure only.
Yeah, the only furosemide is never used as an antihypertensive. It is only to be given when patient has signs of pulmonary edema.
Yes, ma'am.
Okay. So what is HELP?
Ma'am, HELP syndrome is hemolysis, elevated liver enzymes, and low platelets. In about 85% of cases, BP is raised, and it has been found that in about 15% of cases, there is no
excellent presentation on genetic testing and all details you have explained very nicely. So we should be all aware of the testing.
Hello?
Yeah.
Yes, ma'am.
So please elaborate on TBC classification and Mississippi classification of HELP.
Yes, ma'am. Ma'am, in Mississippi classification, there are 3 classes. In class 1, the platelets are less than 50,000. LDH is more than 600. AST, ALT is more than 70. In class 2, AST, ALT, and LDH are of same values, but platelets are between 50,000 to 1 lakh. And in class 3, platelets are more than 1 lakh.
So which one has the worst prognosis?
Ma'am, class 1.
Class 1 where platelet count is less than 50,000. Actually, the anemia which occurs in the case of preeclampsia is macroangiopathic type of anemia. And so suppose if the patient has got HELP, can you get some other complication of placenta with that?
Ma'am, yes, ma'am.
What is that? What type of placenta you may encounter in a case of gestational hypertension? Some problem of placenta?
Ma'am, edematous placenta.
Some sort of antepartum hemorrhage.
Yes, ma'am, abruptio can.
Abruptio placentae, yes, abruptio placentae. There are 2 types of placenta, antepartum hemorrhage, placenta previa and abruptio placentae. So abruptio placentae may occur in a case of gestational hypertension and preeclampsia, and it is a clinical diagnosis usually. What are the signs and symptoms clinically?
Ma'am, bleeding per vaginum and
Yes.
woody hard uterus.
Yes. And if there is severe coagulopathy, DIC and coagulopathy, then even fetal IUFD can occur.
Yes, ma'am.
And the abdomen is tense and tender.
Yes,
So what are the short-term and long-term complications in a case in fetus with mother having preeclampsia?
Ma'am, in short-term complications, there can be obstetric complications fetus that can be FGR
Yes.
and fetal hypoxia.
Oligohydramnios, preterm birth, we have already discussed. Even intrauterine fetal death may occur. And what else? Baby can have a low Apgar score, no ensuring fetal heart rate. And somebody already mentioned they require more of NICU admissions.
Yes, ma'am.
And long-term complications?
Ma'am, long-term maternal complications.
Fetal.
Ma'am, long-term fetal complications can be.
These babies are at risk of developing NCDs.
Yes, ma'am.
Okay, all kind of non-communicable diseases because they are growth restricted.
Absolutely right. Fetal origin of adult onset of disease, it is called. So they can have cerebral palsy, low IQ, hearing loss, visual impairment, coronary artery disease, hypertension, insulin resistance, diabetes mellitus, all these.
What will happen, if you have a patient, for example, of who is gone into labor and you find that there is an abruption which has given rise to AEDF.
Yes,
what does that mean? How much is the jeopardy? How much if there is AEDF seen and the placenta is separated? These babies have to be very quickly taken out. You know what happens otherwise? They may die.
Yes, ma'am.
If at all. Okay, that has to be remembered. Nearly 70% of their fetal circulation can get affected.
Yes, ma'am.
So now after delivery, what will be the instruction? She is a primi gravida. She has a 1.6 kg baby now to look after. And she has been having so much of hypertension. So immediate care would be what? Post-delivery, what would be her immediate care?
Ma'am, post-delivery, we have to measure her BP4 hourly. And
for how long?
Ma'am, we have to measure it till 1 week on alternate days. And it should be measured once between day 3 and day 5. And post that, it should be measured on weekly basis till 6 to 8 weeks.
Yeah, you can even tell her to do what is called as home BP monitoring. She can do her home blood pressure monitoring. Can you shift her antihypertensives?
Yes, ma'am. Ma'am, if she was taking beta methyl dopa, then it should be stopped because it causes postpartum depression. And
anything else? Are there any better options that you can give? Because she's been taking labetalol for such a long time, isn't it? So can we shift it to something?
ACE inhibitors can be started.
ACE inhibitors can be started now for her. Okay. Then what else? What else will you tell her? When is she supposed to come back? What are those 6 signs for which she should report to the facility immediately?
Ma'am, if she's having any signs and symptoms, premonitory signs and symptoms.
So those 6 signs, yes. Yeah. Headache, blurring, nausea, acute pain in abdomen. All this, she will have to come back. Then what would be your contraceptive advice for her?
Ma'am,
This is the last question because now I think it is 5 o'clock already.
Yes,
how much is the time? Yeah.
Ideally,
intrauterine contraceptive device would be the best one. When should she plan her next baby?
Ma'am, after 3 years.
There has to be a spacing of 3 years at least because she's a young woman here right now. And what are the long-term issues for which you will tell her that she has to put herself under care?
She can have chronic hypertension, chronic kidney disease, cerebrovascular disease, cardiovascular disease.
So she has to be told to observe lifestyle changes. And what about She comes to you, doctor, now please remove my IUCD. I want to plan my second baby. What would you do?
Ma'am, we will counsel her and
First, investigate her, isn't it? Simple things which are avoidable are anemia, any renal parameters are abnormal, vitamin D deficiency. You can start her on supplements at least 6 months ahead, and then we may try to reduce the complication. Now, in your patient, she had gestational hypertension, which converted to preeclampsia. You had started her on low dose aspirin very early. So maybe there was little alleviation of the symptomatology. She would have probably gone into early onset preeclampsia very early. But maybe these preventive measures and the antenatal care, which picked it up early, started antihypertensive, must have helped her to an extent. Next time, she's again at risk of developing these complications.
ma'am, we will ask her to have to do physical exercise at least 4 times weekly, and to reduce weight and to have DASH diet.
Absolutely. Thank you. Congratulations. I think you have really done very well. I hope my other co-examiner also agrees to this.
Yes, ma'am. It was a pleasure to share this chair with you. You are the boss in hypertensive disease of pregnancy, ma'am.
I
And
enjoyed.
Payal, you did very well.
Thank you, ma'am.
Both of you did very well. Good. Keep it up.
And we almost could cover many important things. I think, yes.
Thank you, Dr. Girja, and thank you, Dr. Shashilata Kabra. I'm really delighted to see the questions. Actually, you asked really basic and very important questions, which we encounter day and day, night. And these PGs, they should know these important aspects of the hypertensive disorder in the pregnancy. So I think Payal, I tried to give all the answers, and she did very well. I'm happy.
Yes.
That's really good. And thank you
really
very much
well.
again. You have done the wonderful discussion with these PGs, and you have given the important points to all the PGs. Thank you.
Thank you so
Madam,
much,
with
ma'am,
your
for giving this
permission-
opportunity to us. You know, this
And
topic
thank
is so near to.
Yes, very, very. And madam, thank you. Can I take your leave, please, with your permission?
Sure, Dr. Girja. Really.
And
Okay,
dear
thank
students,
you.
you can read Gestational score also, which is an Indian
Gestational India
guideline.
Association, as a madam was
I will
asking
share
about
later on.
maternal factors. So you can just
Yes.
use that, for
Yeah.
Gestational India score, which can help you to identify patients earlier.
Yes.
Yes.
Thank you very
Thank
much for
you.
taking your precious time and to
We
enlighten
enjoyed.
your PGs. And
We
giving
enjoyed. We
points.
enjoyed.
Yeah. Thank you very much. And for the
Okay.
further proceedings of the day, now I invite Dr. Purvi to invite Dr. Ashok for the next session. Dr. Purvi, are you around?
Yes, ma'am, I'm here.
Over to you. Okay.
Okay, ma'am. Yes, ma'am.
Yeah. Thank you.
Good evening, everyone. I'm Dr. Purvi. Taking forward today's scientific program, I would like to call upon Dr. Ashok Kumar. He is Director Professor, Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Science, and Dr. Ram Manohar Lohia Hospital, New Delhi. Sir, are you around? Dr. Ashok. Next topic is on instruments.
Ma'am, he is not in Zoom.
He's not on Zoom.
Yeah.
Okay.
Sir, please join with video. Ashok sir, please join with audio setting as the audio is not. Sir, please join with audio setting as your audio is not showing.
Good evening, sir. Now taking forward our today's scientific program to our next lecture on contraception. For contraception, we have Dr. Shobha Gudi, ma'am. Ma'am, Dr. Shobha Gudi, ma'am is Professor HOD of St. Philomena's Hospital, Bangalore. She is a postgraduate teacher and examiner, chairperson of FOXY 2019 and 22, and president Bangalore Society of Obs and Gynae 2018 and 19. Ma'am, are you there? Ma'am will be joining us in a short while.
Hello, everyone.
Welcome, ma'am.
Yeah, welcome. I'll just take a minute to get the right
Yes,
screen.
ma'am.
Right.
Meanwhile, I'll introduce you again.
Yeah. No need of again.
No, ma'am, everyone should know. Welcome, ma'am, Dr. Shobha Gudi, ma'am. She's Professor HOD at St. Philomena's Hospital, Bangalore. She's a postgraduate teacher and examiner. I welcome you. She's here for today's lecture on contraception.
Just give me a minute so that I can do the right
We
thing.
can hear you, Dr. Shobha. We can hear you.
Yeah, I know you can hear me. Yeah. Okay. Just a minute, huh, Mala? I'm just trying to get. I was in another meeting, so I have a little bit of a problem in reorienting with the PPT. I'm just getting it now.
हमारे पास है सब कुछ, जाओ उसको आने दो. बोल दिया.
Okay, so I think I must go ahead now with my talk, and I will share the screen now. And I'm sorry for that slight delay there. Okay. I think just a moment. I'm not able to get the Zoom place for myself. Yeah, got it now. So contraception for postgraduate education pretty much is extremely important, because I think if you are having the correct perspectives now, it will kind of make you conversant with this part of care which is often neglected. And many a times women feel that this is something which need not be discussed, which is often understated and behind wraps, and even families do not like to approach this subject. They feel that it is nobody's business how many children they want, but it is actually a very important societal matter. It has demographic impact, and most importantly, which you should never forget, it has profound effect on the reproductive health of the woman if the pregnancies are not spaced appropriately, and secondly on the health of the neonate. So in your practice, in your work, if you feel that your women should remain healthy, should remain not anemic, should remain free from unsafe abortion, and the emotional stress of even a safe abortion, and the physical impact of that, I think it is very important that you are well versed with all the methods of contraception and the ways of providing them to your clientele. So with reference to your examination, I think the methods of family planning are what are very relevant for your viva and your table viva, and a lot of medicines and devices will be placed on the table, including the contraceptive pills and the intrauterine devices, even the natural methods, even the barrier methods, everything will be placed on the table, and you need to know. I still remember one of my postgraduates came back and reported to me that she was told a kind of a device which looked like a barrier, and she was asked the specific use and where is it that you would advise the woman to use this for about 3 months or 4 months, like that. So the eventual answer came out to be a female condom, because we do advise women to protect themselves against pregnancy when the husband has undergone vasectomy, and for the next 3 months he still will be fertile, and the semen will still contain active spermatozoa, and he may feel that he is post-operative, so he does not need to use the barrier, and the woman is therefore unprotected against unplanned pregnancy. So some questions like this, tricky questions like this may come across. A very common question for postgraduates is when an intrauterine device is displaced and an X-ray is shown with a displaced IUCD. So today, because the era of X-ray is not there, maybe you will have an ultrasound picture, or even maybe you will be asked about the uses of hysteroscope, where one of them is the location and removal of a misplaced IUCD. So on and so forth. But let us get some basic facts about contraception right, because in India, the story of family planning is much different than in the rest of the world. Before we proceed, one more important fact is that the government of India has a very strong, robust family planning program in place. And when you visit the GOI website on maternal health, that is MOHFW, and when Ministry of Health and Family Welfare, when you visit the website, you are able to find what are known as the blue book, the green book, the red book, and so on and so forth. There is even a yellow book, and all these books are representative of or contain a very rich information on individual methods as is available in the public basket. So you need to understand that the public basket or the GOI, the Government of India, through its outlets of government district hospitals or even city hospitals or even medical colleges, provides the basket of contraceptive, which includes a few methods, including male and female sterilization. It includes combined pill, it includes emergency contraception, it includes intrauterine devices, and today it also includes the contraceptive implant. Having said that, the private sector has many more methods to offer, and some of them you will become alerted to as we go across this presentation. So female sterilization actually predominates the contraceptive method mix in our country, and the use of pills and condoms have considerably increased if you look at the NFHS 5 data, the National Fertility Health Survey data. But still a lot more needs to be achieved. Traditional method use remains unchanged, and age, education, a surviving son, religious, social group, household size, region, economic condition of the women are significant determinants of contraceptive use. Okay, so these are some of the studies which have outlined the socio-economic factors which determine the use of contraception. Of interest is this pie chart. It's a very interesting pie chart because you can see this yellow which indicates sterilization, and it's hardly desirable because it's the female permanent or limiting method of sterilization, but very often this is opted for by women who have had 3 children and more. And our efforts are to provide spacing methods because that is what gives a better hold on the rate of population growth and population stabilization ultimately. So we must have a paradigm shift to offering the spacing methods. So if you can see here that this is 0.5, this 3.1% is the intrauterine device, you can increase it considerably. Pill is 8.2%, again underutilized. The lactational amenorrhea method is here. The injectable is here, and the male condom. So all of them have a huge potential of improvisation. So there is another thing which also comes to the mind is whether there is a medical need of contraception in India. That means you have to think as physician, because you know when you are an OB-GYN, then you have both. You're both a physician and you are also a surgeon, right? So as a physician, do you feel that prescribing contraceptives is necessary for your women's health? And you'll soon understand that the answer is yes, yes, and yes, because you need to prescribe contraception to, you know, reduce the number of abortions, okay? Because unintended pregnancies, which are nearly half of all pregnancies, and it's almost 70 per 1,000 women aged reproductive age group, and see how it ends. The 48.1 million pregnancies are total annually, in which planned birth are only 43. The entire remaining thing is unplanned. And how does the unplanned one end? Sometimes it ends in the birthing of the unintended pregnancy, unintended births, then which gives a poor planned family structure, and then all the secondary effects of social economic burden on the family. 33% is induced abortion, a huge burden on the healthcare system. And then 5% are the miscarriages which happen to these pregnancies, and the part of it is the miscarriage of the intended pregnancy. So what I'm trying to convey here is non-provision of contraception leads to huge reproductive wastage. And as kind of children of the Almighty, we have no right to allow this to happen. Now, this is a little backdated slide which also says that COVID-19 infection may lead to upsurge in unwanted pregnancy. So we are actually facing the same threat again today. And please understand that whenever there is a pandemic or a disaster situation, the women's maternal health and reproductive health takes a backseat. So the unmet need for modern contraceptive in India has declined only slightly in the subsequent NFHS data. Maybe today it is around 11% or 10%. And the 46 million women with unmet need, 11 million only were past users of the modern methods. Almost remaining 2/3 are non-users, and the large amount of heterogeneity in India with a difference of 55% points to modern contraceptive use. So that needs to come down. So these are demographic data. And we soon come to the types of modern contraceptive method mix, which is available globally. You can identify some of these methods. Definitely, you know about the barriers, you know about the intrauterine devices, the injections, the sterilization methods. You may not be familiar with, and of course, the natural methods like these, the interruptions and the calendar methods or the safe method. You may also have seen about the diaphragm or the cap, which can be used by the woman. Douche is no longer there, so this actually needs to come out of the picture. But please see about this also, the female condom. The hormonal ring, which is extremely beneficial for the woman, contains both estrogen and progesterone. The implant with the least pregnancy failure rate, and the contraceptive patch, which still has to come to India. So the modern contraceptive method mix in India, this is what is seen in the public sector. Okay, I just now told you, right? LAM method is highly, the lactation amenorrhea method, highly propagated. You can see the sterilizations, the barriers, pills, injections, and the intrauterine device. But still, this is all missing. The non-hormonal contraceptives, fortunately, the Centroman or Chaya has recently got included into the government basket, and we have a different MEC wheel for that. Then we have the implant, which has also come into the basket, the female condom and other natural methods. But then what is also missing here is the emergency contraception. So please remember that the emergency contraception needs to be added here, and it is a very valuable tool to prevent unintended pregnancies. Now, the choice should be individualized. So at any given point of time, a woman has to be offered a basket of choice. That is very, very essential. So then we have less effective methods, and then we have the more effective methods. And this is how the effectiveness chart needs to be presented to the woman. She needs to understand that the natural methods which most couples perform, like the withdrawal method, not only leads to an incomplete, experience of sexuality, but also high risk of failure and unintended pregnancy. The barrier methods are next, and then come the hormonal methods and the injectables, but the best ones are the implants, the intrauterine devices, and then the sterilization. On the right side is also told to the woman and the couple, what is it that will improve or make the method more effective. So, for example, if it is told LAM, then they have to go for exclusive breastfeeding, and it will work only for 6 months and only if the woman is amenorrheic. So that is how the effectiveness chart can be offered for counseling. So have some categorization of the methods, have some orientation that it can be reversible and non-reversible, like the limiting method of sterilization. But the reversible can be short-acting and can be long-acting and can be the barrier methods, which are the coitus-related methods. So the SARC methods, or the short-acting reversible methods, one of the main ones is the hormonal contraceptive pills, and the other one is the non-hormonal contraceptive like the Centroman. The hormonal OC pills are combined progesterone only, and they can also be the emergency contraceptive pill or the levonorgestrel pill. The OCPs were introduced very long back in the 20th century, as early as 1960, and today almost 1/4 of women in the reproductive age worldwide are using this contraception method, but the combined method, but in India it is still less. Okay, it is less, as I had shown you in the pie chart. Is it effective? Extremely effective. Okay, very effective. And with perfect use, you can see that the Pearl index is less than 1 per 100 women years of use. But with the typical use of missed pills, concomitant other medication, etc., it becomes 8 with typical use. So if you have better counseling, then you get a better failure, protection for the woman. When it comes to POPs, there is a slightly higher incidence of failure, but even then it is equitable, it is almost equal. But with the typical use, the risk may go up a little. And then we have the ormeloxifene, which is 1 to 2 pregnancies, and the emergency pills, which are also fairly effective, maybe 1 to 2%. Okay, and the sooner it is taken after the act, the more effective it is. So that is how the EC pill. Well, it is important to just once, for consultants, I don't do this, but since you're still studying and your minds are so overcrowded with information on the action of all drugs, this kind of reiteration is helpful. And you must know that the oral contraceptive pills have a profound effect both centrally and on the target organ ovary. It even acts on the cervix. Consistent use will even act on the endometrium. So there is a reason why both estrogen and progesterone are combined, and the inhibition of follicular development and ovulation through inhibition of the pituitaries and the ovaries is a very profound effect, and that is why it is so effective, because ovulation and corpus luteum formation is completely inhibited. And there is thinning of the line of the endometrium, so implantation also cannot happen, and the cervix also has very thick mucus, so the sperms cannot ascend. So it is on a multiple level. And as I said, it was introduced much earlier, and the earlier COCs were containing very high level of estrogens, 35 microgram ethinyl estradiol for many years. Only after that it was realized that we can have a lower levels of estrogen to be effective. So the different regimes, you must be very familiar. These are the current day regimes. We are not talking about the contemporary pills which are available. So the combined oral contraceptives can be used traditionally as a 21/7, that is 28-day regime, in which 21 are active hormones and 7 are inactive. You are all familiar with these pills. It is important to become familiar with the 24/4 regime, where it is again a 28-day regime, but there is only a 4 pill-free day, which is extremely useful for the woman. And then there are extended regimes where the pills can be used in tandem without giving a break or a hormone-free interval. And then there is a continuous regime where it can be taken uninterrupted for about a year. So all of them have place in clinical practice. So if anyone asks you about the evolution of COCs, then information like this are very useful. The 60s, where the first oral contraceptive was introduced in the US and in Europe, and 70s, the progesterone only came. 80s, when biphasic and triphasic became recognized as separate types of pills. 90s, when low dose pills were introduced. And in the 2000, at the beginning of the 21st century, where the extended continuous regimes and the newer progestins and non-hormonal pills, everything became available. Natural estrogens also got added, and still research is underway how to improvise the safety of this. Also, the progesterone has changed over the years. The estrogen has remained ethinyl estradiol. It's the progesterone which has changed. I'm re-emphasizing on the content because as prescribing physicians, which you are going to soon become, you must exactly know the molecule that you are writing. So earlier it used to be norethistrone, then levonorgestrel. Levonorgestrel pills are still available in the government basket. You all know that Mala D and Mala N contains levonorgestrel. Then you have the third generation desogestrel, Gestodine and norgestimate is not available in India as part of COC, but desogestrel is there. You all know that. And the fourth generation miracle pills are the drospirenone containing and the dynagist containing. Again, chlormazidine and normegestrel is not there. What are low dose COCs? Those which contain less than 35 microgram of ethynyl estradiol are low dose COCs, very beneficial, and the lowest possible dose of the progestin is included. So contemporary COCs have the low dose one 15 to 20 micrograms and the moderate dose 30 to 35 micrograms. Usually 20 micrograms ethynyl estradiol pill are as effective while possibly reducing the hormone burden. Only all the side effects, like nausea, bloating, breast tenderness, everything comes down. But the only thing is it is not able to kind of stabilize the endometrium that well, and breakthrough bleeding can be a problem. Nevertheless, choosing a low dose pill is of extreme benefit because discontinuation of OCP may happen with high dose pills because of side effects, and the woman may fall prey to unintended pregnancies when she gives up on the COC. Okay. So the low dose pill has got clinical and economic benefit. So low dose pills have a place in the management of young and older women alike. Or older women deserve lower doses of estradiol because that is safer for them, even though they might be becoming estrogen deplete. We shouldn't be using higher dose pill for the perimenopausal women who require COCs. And today it is good that we have the estradiol valerate and dynagist combination, which is very suitable for this age group women because it is natural estrogen. The available combinations are listed here and will not go into this slide. It is too much. Most of you must be thinking how to balance the benefit versus the side effects. The primary benefit is preventing the unwanted pregnancy, but we need to understand that improving cycle control is one of the huge benefit. It also prevents cancers, ovarian, endometrial, and colorectal cancers. And by preventing unsafe abortion, it reduces maternal mortality. Those are the benefits that we cannot take away from the profile of COCs. They're huge benefits. The side effects, however, the minor side effects you should know. I spoke about breakthrough bleeding and the other symptoms. And decreased libido, however, is a very transient effect, and soon the woman adjusts to the less amount of wetness that she experiences and she can get around it. And weight gain is more of a myth than a fact. Pills do not cause weight gain. It is more of a lifestyle problem. And then you need to know what is new in COC. And this is how you must know that the drospirenone is the new content amongst it, and so also is the dynagist. The newer progestogens have higher progestogenic potency, so you must know that. And the dynagist, which is the new one, is actually derived from testosterone. Drospirenone is derived from spironolactone. And considered a little more metabolic friendly and metabolically neutral than dynagist. Advantages and disadvantages of the progestins. You need to know that the older progesterones had excellent contraceptive efficacy, but had a potential for for older women and smokers. They were not very healthy. Okay, so whenever you have OCP containing dynagist, which has a lower androgenic activity, and inhibition of ovulation is not likely to trigger androgen-related side effects. Okay, and it is a hybrid progestogen and has pronounced progestogenic effect on the endometrium, and little affinity for other receptors, the estrogen, glucocorticoid, and mineralocorticoid. So side effects of bloating are less, and anti-androgenic activity is 30% of that exhibited by cyproterone acetate. So this is where drospirenone scores over Dynages, because drospirenone containing pills have got better anti-androgenic effect. So they are more suitable for PCOS, etc. This is about levonorgestrel, also a healthy molecule. Important to know about this because it is there in the public sector, and a very large number of women are given this. Actually, door-to-door delivery by ASHAs happens of levonorgestrel containing COCs, and also reasonably safe. But the newer progesterones have some better effect, though they are more expensive and cannot be there in the public basket. Levonorgestrel is associated with expected increase in BMD, so it is in favor of levonorgestrel. Let us move ahead. Okay, we come to the injectable, which contains the medroxyprogesterone. It has got a benefit because it is safe in breastfeeding mothers, lactating mothers. After 6 weeks, it can be initiated after delivery, and also helps in endometriosis related pain. And it is associated with increased rates of weight gain in obese subjects is again a myth, because I think there is a reference there which says that it is again a lifestyle factor. We come to drospirenone as a progesterone as a part of COC. Is derived from spironolactone, has significant anti-mineralocorticoid, significant anti-androgenic property, inhibits ovulation, and alleviates menstrual migraine, pain in endometriosis, and also increased bleeding of AUB will be reduced with this. And then it has approval across. It helps in acne, it helps in hirsutism. The progesterone only pills, which you are already familiar, you must have heard of the mini pills. So whenever there is a contraindication for the use of estrogen, for example, hypertension, then progesterone only pills may be the choice. Incidentally, they are also, the levonorgestrel is also used as emergency contraception, though it is a different formulation. It is 0.75 milligram. And it can be initiated at any time during the cycle. The POP can be initiated. So it is also a quick start method. Minor adverse effect is spotting, irregular spotting, but there is a huge benefit of a safety profile, and there is non-contraceptive health benefits because it does help in menstrual problems, premenstrual syndrome, and also protects the woman against anemia and is safe in breastfeeding women. As I had started speaking about the injectable contraceptive DMPA, it is in the National Family Planning Program, the 3-monthly injection. So you must know that today we also have the subcutaneous variety. We don't have the NET-N. We don't have the combined. We have only DMPA. And that is DMPA is in 2 forms. One is the intramuscular and one is the subcutaneous. Intramuscular is 150 milligrams. The subcutaneous, which the woman can inject herself, is 104 milligrams. Now, the injectable contraceptive is also known as, a very confidential method for the mother, for the woman, and it is also known as the woman's best friend because it is a long-acting method, it is reversible, it is an injectable form, and the family need not know that she has gone and got an injection, so it's very, very confidential. The adverse effects are very minor. We must understand that when we give them once in 3 months injections, they should also be told that there is no protection against STI, and wherever there is risk, the barrier must be used. And should be taken every 12 weeks meticulously, and return of fertility is around 10 months from the date of the last injection. So if a woman needs spacing for 3 years, then she can be given this method for 2 years, and automatically she gets protection for 2 years and 10 months. So that serves the purpose. Only few conditions like severe liver dysfunction or breast cancer or thromboembolic disorder or poorly controlled hypertension are all contraindications. Well-controlled hypertension, well-controlled diabetics can always receive this as against the combined pill, which cannot be given in well-controlled hypertensives also. The benefits are, however, much more than the adverse effects. Okay, it gives benefit from menstrual symptoms, drug interactions are very, very minimal. Here is where it scores over the COCs and the implants, the injectable. It has very less side effects or drug interaction with anti-epileptic drug or antiretroviral therapy, all of which are enzyme inducers and reduce the efficacy of the combined pills. But they do not reduce the efficacy of the injectable DMPA. Of course, it protects against ectopic and benign breast and ovarian problems, and even some protection against extra growth of fibroid, anemia, endometriosis, relief of pain, PID pain is relief, and of course, it protects against endometrial cancer. Preventive effect is there, possibly even against ovarian cancer. And the specific cohort of women who are suffering from sickle cell anemia, if they are offered injectable contraceptives as a method, then it reduces the incidence of sickle cell crisis in these women. That is very important. So then we come to, this is a wrong picture for this thing. Okay, so it is just an addition here. But what is important, what is shown here is the contraceptive implant. Okay, the implant provides sustained slow release of the steroid progestin. And today what we have is the etonorgestrel. Maybe we have it in the, okay, we are going on to the subcutaneous. I have already told you about the subcutaneous, a very small needle, and may be useful in women who are at high risk of developing hematoma during IM injection, like women with ITP, etc. They will, and also it is self-injectable. So the LARC methods, if anyone asks you, are you familiar with LARC methods? You can just kind of rattle off the copper IUCD. You can say progesterone only system. Always speak of it as an LNG IUS. It's an intrauterine system. Then injectable contraceptive and the implant. Okay, so that is important. They are all reversible. And implant, especially once you remove, and the intrauterine devices, once you remove, the return of fertility is the very next cycle. Are there any misconceptions in the mind of the providers about intrauterine devices? So let us read the bottom line. Long-acting IUD is safe, effective, should be advocated in patients requiring long-term use. Okay. Now, insertion is difficult, expulsion is common. Women request early removal. It's painful. Testing is needed before IUD, and the partner will feel the IUD. These are all myths. These are all myths, and providers have to do a lot of myth busting while providing contraception. So the NICE recommendation supports the LARC method. So does the ACOG recommendation. And we need to know about SARC versus LARC, because SARC short-acting method depends on the patient's compliance, whereas the long-acting method has got higher satisfaction rate and does not depend on compliance, because once you provide, it is done. What about male contraception? Are there any options? Okay, so far, whatever the qualities which are given here are for an ideal contraceptive, which is acceptable, no interference, and no side effects, long-term, short-term, cost-effective, available, effective, easy to use, and rapidly reversible. So, the options are very limited for, and most of the ones listed here are actually still under investigation, and answers have not been found for other methods. So barriers and vasectomy only remains, with the exception of RISUG method, which also has, not crossed the phase 3 trial. So in India, I have spoken about the contraception prevalence rate, and you can give a ballpark figure of the mean contraception. MCPR is mean contraception prevalence rate of about 54%. You will not be wrong. And this is the unmet need state-wise. And you can see that in UP and Bihar, it is very, very high. And the way forward is a better mix of the contraceptive methods. I already told that the pills, the IUDs, even the barrier should find a bigger space on the pie chart and the limiting method should reduce, then only we have optimization of contraception service. So there's still a large unmet need. Sterilization should be adopted wherever it is possible, but then we must promote modern method of contraception. So this was the talk which I needed to give. A few questions can be taken for quiz if there is time, or I can wait for questions from the audience, whatever you say. Depends on you.
I cannot see any questions in the. नहीं, there are questions.
अच्छा ठीक है, आप पढ़ दो फिर.
नहीं ma'am. नहीं, there are no questions for this lecture. But the lecture was very detailed. I hope it was very beneficial for the PG students.
Okay,
It was
so
very
can you see
collaborative.
my screen still or not? No?
Yes, ma'am. No, not the screen. There is a question about frameless. Can you tell something about frameless?
Frameless IUD. Okay, frameless
Yeah.
IUDs are still not freely available in India. But anyway, we are waiting on that. And frameless IUDs are very, very suitable for for nulliparous women and young women who are looking for intrauterine contraception. I will try and share some of the questions if you don't mind, because I think
Yes, ma'am.
I
Yes,
was asked by Mala to do some quiz, and
Yes,
it would be good if we can have this quiz. So laparoscopic tubal occlusion, can you see, dear? Can you see my?
Yes, ma'am. Yes, ma'am.
I'm also trying to see the chat. Status of Ashok. Okay, Ashok is no longer recommended because the Ashok is the hysteroscopically placed quinacrine pellets into the tubes, and actually it causes more uterine damage than is acceptable by the standards of contraception, safe contraception. Mrinalini has asked about postpartum contraception summary. Almost every method can be given as postpartum with few exceptions. But if you feel that you should have a ready list in your mind, then it starts with postpartum IUCD. The prescription of centrochroman also can be given as early as 3 weeks post-delivery can be started. POPs also can be started as early as 3 weeks post-delivery. And then implants can be placed before the woman is discharged from the hospital. COCs can be started after 6 months of postpartum, and injectables can be started after 6 weeks of postpartum. So Mrinalini, I would very much recommend you to type on Google WHO chart for postpartum contraception, and you'll get a very wonderful chart. And that will kind of be enough for your exam. Payal has asked what is the difference between Pomeroy and modified Pomeroy. So can Payal tell me, I think I will stop sharing for a second, and we'll address Payal and Sunayana, and for that I will take the gallery mode, okay, and stop sharing for a minute. Payal, beta, can you, they are not on the same platform?
They are, ma'am.
I can't see them.
Probably their camera is off.
Acha. Payal, no, because I can't see any of the pigeon boxes also. I mean, I can't see the windows also.
Okay.
Usually in gallery, we see all the windows, no?
Yes, ma'am.
I can't see. So probably they have joined from a separate link.
From a different link, yes, ma'am.
So Payal, can you, if you can say, what is the traditional Pomeroy method? So the traditional Pomeroy method said that we need to use an absorbable suture, right? And we need to take a knuckle of tube of 1 to 1.5 centimeter. And we are able to cut a loop of the tube. That was the original Pomeroy method. And we need to use an absorbable suture. And the principle behind it is that if you use an absorbable suture, then once the suture is absorbed, the two ends of the tube fall apart. They fall apart, and it's important not to damage the mesosalpinx in between. It's important to cut 0.5 centimeter of the loop, or not definitely more than 1 centimeter, so that it remains even a potentially reversible method. No crushing, no cauterization of the ends, no cutting of the mesosalpinx. All that is not recommended in the original Pomeroy's, because the effort was to keep it potentially reversible. Now, whatever else is done, for example, if you make it delayed absorbable suture, or if you crush the ends and evert them, which sometimes I do in women who have really a large number of children. And if you cauterize on the mesosalpinx, or you cut the mesosalpinx, all of them become modified Pomeroy's. So modified Pomeroy's is not a defined method. It is any further deviation of from the traditional Pomeroy. You can call it modified Pomeroy. What is quick start contraception? That is a very, very good question on quick start contraception. See, sometimes women report to the clinic, but they are not ideally in the post-menstrual phase. They may be in the premenstrual, or they may be peri-ovulatory. And for example, they might want an intrauterine device insertion, they might want a pill prescription, etc. And that is when, if they choose the method from the basket, for which ideal time is post-menstrual, but the woman has not come post-menstrual. So instead of turning the woman away and saying you come back after next period, it makes a lot of sense to give her the method with counseling, and then cover the rest of the next 7 days with some other method like direct contraceptive, and telling her that she should return if she misses the period. Because if an escape ovulation and pregnancy has happened, then you must catch it early. So that is quick start contraception, and in the majority of cases where it is given quick start, pregnancy does not happen, and the woman is able to continue it in a more traditional way from the next cycle onwards. For example, if she has started the pill pack on the 9th or 10th day, which is not conventional way to start, in this cycle, she continues the pill pack and stops it after completing the entire pack, and when she gets the withdrawal, in the next cycle, she is able to start on the 2nd day as is recommended. So that is what I wanted to tell. I think our time is up, dear.
Yes, ma'am.
We may have to stop. I don't think there is time for the quiz, right?
If 5-10 minutes, then you can continue.
Yeah, I can take the first 5 questions maybe. So
Okay,
I'll
ma'am.
share my screen and do the. Is that okay?
Okay, ma'am.
Because some
Yes,
people are
ma'am.
asking about the quiz. Yeah.
Yes, ma'am. For
Only
few
if it
questions.
is okay for you, I will do. Otherwise,
Yes, ma'am. Few questions.
ठीक है फिर. अच्छा, ये तो पहले वाला open हो गया. Can you still see my screen?
Yes, ma'am.
Okay.
First question.
1 minute, I'm doing. So laparoscopic tubal occlusion can be performed concurrently after 2nd trimester abortion. What is it? Anybody? Can you tell? So the answer is it should be can be performed after 2nd. Yeah, concurrently after 2nd trimester abortion, it will be a little difficult. It can be performed maybe after a few days of 2nd trimester abortion. Okay. 24-year-old female comes to family planning OPD desiring contraception. Husband was outside and is now coming back home after 5 months. Okay, her Lempi was 20 days back. She wants to start Mala in. When can she start? Okay. All right. So the answer is quick start. This is what was your question when women request any time if reasonably certain that she is not pregnant. So for this, to be reasonably certain that she is not pregnant, there is a chart. Okay. The chart which is again available on the MOHFW website. If more than 5 days since LMP, she needs to abstain or use additional method for the next 7 days. This is what I have explained last time. So that is clarified for you. A woman comes for COC Malayan on day 10 after abortion, after an MBA. Can it be given to her? So the options are no, she needs to come 1 to 5 of the next. Yes, can be given, no history of unprotected sex since her last period. Backup is required. Yes, but she needs to be given higher dose. Never do higher dose. C is automatically out. Okay. And yes, she can be given and no backup is required. So D is also not correct. So what is the answer? The answer is B, that it can be given, provided there is no such history, which is outlined here, and backup is required. So it's similar to quick start. 30-year-old wants to get a copper IUCD inserted. She wants to know at what time of the cycle, so that additional backup is not required. So this answer, all of you know that it should be right within 5 days of the period, so that she doesn't require any backup. Okay, there's a lot of chat going on. It is for all the they are giving answers. Oh, so sweet of them. All of them are giving answers, and I'm not able to take the answers. Okay, I'm not able to check it out. That I think another person you must do if you want to. Okay, 30-year-old wants to get injection DMPA. She wants to know at what time of cycle she should take DMPA, so that additional is not required. So this also may be a similar answer, is within 5 days. So in summary, contraceptive method and when is backup required, it's a good chart to remember, and for how many days. So for copper IUD, it is not needed any time of the cycle. So this will also help you to remember that copper IUD is also used as an emergency contraceptive method. All right. So remember that backup is not needed. Anytime you can put in the copper IUD. LNG IUD backup is required if she is more than 7 days, and the protection needed is additional protection is for 7 days. Injectable more than 7, protection for 7. Implant more than 5 and protection 7. CHC, that is combined pill, more than 5, then protection is needed. Backup is needed for 7 days, and POP is similar, but the backup for POP is less, is only required for 2 days. Okay. So 27-year-old, this is the last question because I am out of time. A 27-year-old has delivered a baby 7 months back, right? And she is using POP and she has missed the pill, usual time of the pill. It is a 75 microgram desogestrel pill. So you must be knowing the missed pill interval for each. So this is the FSRH. I would recommend this website for your difficult questions on contraception, because you will get many answers in this website. It is the Faculty of Sexual and Reproductive Healthcare, Faculty of Sexual and Reproductive Health of Women, and the guidance. It is showing this traditional POP and the desogestrel POP. That traditional POP, the missed pill interval is very, very short, but in desogestrel POP it is 12 hours, and the recently available drospirenone POP, actually the missed pill interval is as much as 24 hours. Okay, so when it is traditional POP which is missed, take a pill as soon as remembered. If more than one pill has been missed, and take the next pill at the usual time. This may mean taking 2 pills in one day. An additional method needs to be used for the next 2 days. All right, next 2 days. But for desogestrel, the missed pill is 12 hours. So up to 12 hours, there is a chance that if she takes the missed pill, she will not become pregnant. So I think, okay, clearly understood is what Payal is telling. Okay, then shall we stop here? If a client forgets to take 2 pills, what she should do? So we will go on. Take the pill as soon as possible and continue taking rest of the pills. So up to 2 pills, it is possible to follow. This will be the last question, dear. 19-year-old comes to FPOPD day 2, desiring and wants to start. Do you need to do any essential and mandatory examination before she starts? So let me look for this answer, because there's something known as essential tests before starting contraception, and they have been categorized as A and C. So very few need to be are mandatory. So the options are blood pressure, clinical breast examination, PSPV, and all of the above. So let me look at some of the options. 1, 2, 3, 4, you must tell, okay? Okay, so most of them are telling all of the above. And Kit 2 is telling 2 and Sandhya is telling 1, that is blood pressure. So good answers have come. Preeti has told 1, Farah has told 4, all of the above. Okay. So at least they are responding. I'm happy. Divya says 4D. Let me look at here. So as I told that A, B, C are there, and for combined hormonal contraceptive, essential and mandatory test class A is only blood pressure requirement. If you are giving them any local methods like this, then only PS and PV examination will be needed. For CHC prescription, you don't need to do a PSPV unless they have some symptoms related to that, like menstrual problems, etc. Then you have to investigate that. But otherwise, in a normally menstruating woman, you require only the BP. Rule out hypertension before giving combined hormonal pill. So essential and mandatory tests are class A. Class B contributes substantially to safe and effective use of the contraception, and class C does not contribute substantially. So this kind of categorization of tests which are required is developed by ACOG, and it is available in the website. Because unnecessary examination is a barrier for taking up contraception. Remember, it is a barrier, and adolescents are not comfortable with all this. Okay, all right. I think we shall stop because this can go on forever. Thank you, Purvi, for that extra time.
Thank you so much, ma'am. Thank you for your time.
Yeah,
Thank
and
you so
I
much,
really enjoyed, interacting with the young minds of our country. Yeah. Thank you so much, girls, boys.
Thank you, ma'am. Thank you. Now taking forward today's evening with the next topic of Adnexal mass. The case will be presented by Dr. Arti and Dr. Nikita. And the moderators will be Dr. Seema Singhal. She is Associate Professor, Department of Obs and Gynae, Vardhaman Medical College, Safdarjung Hospital, New Delhi. Dr. Sharda Patra, Associate Professor, Lady Harding Medical College. And Dr. Urvashi Meglani, Senior Specialist, Deen Dayal Upadhyay Hospital. I welcome all the moderators. Dr. Seema, are you there?
Yeah, hi, I'm there.
Hi, hello, ma'am. Welcome. Please welcome, ma'am. Yeah. Dr. Arti and Dr. Nikita.
Good evening, ma'am. Good evening. We are not able to share the screen because previous screen is showing on it.
Okay.
Ma'am, is the screen visible?
Yeah, screen is visible. Ma'am, shall we start?
Yes, you can start. I think Dr. Seema is there. I think we should
Yeah,
start.
sure. Please start. Please start.
Yeah. Okay, ma'am. Yeah.
Yeah, okay.
Please start.
Good evening, everyone. We are presenting the case on Adnexal mass.
Echo.
Good evening, ma'am. My patient name Miss XYZ. She is 29-year-old female. Her education is she is a graduate. Occupation, she is teacher by profession. Socioeconomic status, she belongs to upper middle class as per modified Cooper-Swamy scale. She is resident of Noida, Delhi.
Her menstrual history. Minar, 12 years of age. LMP 12th December 2023. Her current cycle are she bleeds every 3 to 5 days, and her cycle is 45 to 60 days, which is irregular. Her flow is average. She uses 2 to 3 pads per day. Moderate dysmenorrhea, which starts 1 day prior to her menses and lasts for until day 3 of her menses, for which she does not use any analgesics. Her previous cycles were regular, lasting 3 to 5 days, with duration of every 28 to 30 days cycle. Flow was average with no dysmenorrhea. She is unmarried, not sexually active. Her presenting complaint were pain in abdomen, which was suprapubic in region, and right iliac fossa since 1 month. History of present illness. She presented with complaint of pain in abdomen since 1 month, which is localized to suprapubic and right iliac fossa. It was insidious in onset. It was dull, aching type, intermittent with continuous discomfort, non-progressive, non-radiating, no aggravating factor, relief on taking analgesic, not associated with nausea, vomiting, dizziness, sweating, dysphoria. She also complained of irregular menses since 2 years, associated with dysmenorrhea. She had no history of loss of weight, any change in appetite, bloating, or early satiety. No history of evening rise in temperature, no history of contact history with tuberculosis or any abnormal vaginal discharge. No history of burning or painful maturation, increased urinary frequency, incomplete voiding or blood in urine. No history of constipation, diarrhea, painful defecation, or blood in stools. Past history, no history suggestive of diabetes mellitus, tuberculosis, asthma, or hypothyroidism. She had no history of any previous surgeries. Her personal history, she was vegetarian with normal appetite, no addiction, no substance abuse. Her sleep-wake cycle was normal with no altered bowel or bladder habits. Her family history, her mother was diabetic, father was hypertensive, no history of gynecological or breast malignancies in the family. Mother attained her menopause around 50 years of age. On general physical examination, patient was conscious, oriented, moderately built and nourished. Her height was 1.
Wait, Nikita, just a minute. Can you summarize your history and can you tell us what all differential diagnosis comes to your mind after this history? Just summarize your history briefly in 2 lines, 2-3 lines, and tell us the differential diagnosis so far. What all conditions come to your mind for your patient?
Since she presented with complaint of pain abdomen since 1 month.
Patient's age, se start karo. Yeah.
29-year-old unmarried, non-sexually active female, presented with complaint of pain abdomen since 1 month in right iliac fossa and suprapubic area. And the pain was dull, aching, and intermittent. So not any acute pain, it is chronic. The most common diagnosis that would come in mind would be benign ovarian mass, that is common in this age group. And there is no acute pain, so the mass is there is no torsion or anything, and since she has no fever or tachycardia, no history of any fever, so PID is also unlikely. And since she has also irregular period associated with dysmenorrhea, so another differentiation will be differential diagnosis will be endometrioma. And since there is no history of loss of weight or change of appetite or evening rise of temperature, so tuberculosis is also unlikely. No history of burning, maturation, or any UTI symptoms, so we will also rule out UTI.
Your patient had pain in the right lower abdomen, right?
Yes, ma'am. So
your patient is presenting to you with dull chronic aching pain in right lower abdomen. And so you are keeping it as a, but there was some history of dysmenorrhea, right?
Yes, ma'am.
So you're keeping it the first differential as endometriosis based on her history. So, but then you are ruling out COX based on some symptoms, which is like kind of, we usually do not. I mean, COX can present anyways, you know, and even PID, it's not always mandatory to have history of fever. right? Or the tubovarian masses, which could be tubercular or non-tubercular in origin. So TO masses, yes, may present to you with this. But you didn't think of any non-gynecological condition for your patient? Could she be having some non-gynecological condition?
She might have a mesenteric cyst or appendicitis.
For right iliac fossa, appendicular mass will come first, na? You're talking of a mesenteric cyst. What are the symptoms of a mesenteric cyst?
Abdominal distension, ma'am.
So it is
Pain,
right.
pain
Huh.
in abdomen with abdominal distension.
Most of them, they may be asymptomatic also. So when there is right iliac fossa pain, you should think of appendicular mass or appendicitis first. Think of common things first, right? Anything else? So, okay. So Dr. Seema, we'll let them proceed.
Yeah, sure, please.
Okay.
Yeah.
So carry on with the examination.
Old age. On general physical examination, patient is conscious, oriented, moderately built and nourished. Height is 158 centimeter, weight is 53 kilograms with a BMI of 21.2 kilogram per meter square. Thyroid, on examination, thyroid is normal, breast was normal. There was mild pellar, no icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Pulse rate was 86, regular in rate, rhythm, volume. BP was 130 by 70 mmHg measured in right upper arm in seating position. Respiratory rate 8 per minute. Spine and gait were normal. On systemic examination, on cardiovascular examination, SN, S2 heard with no murmurs. On respiratory system, bilateral chest was clear, no adventitious sounds were present. CNS, no signs of focal neurological deficit seen. On per abdominal examination, on inspection, abdomen is scaphoid. There is a localized bulging in right lower quadrant. Umbilicus is midline inverted. All quadrants move equally with respiration. No sinuses or dilated veins seen. All hernial sites were intact. On palpation, the skin was febrile to touch. A cystic mass of 10 into 8 centimeters was palpable with regular margins. Lower margin could not be palpable. With smooth surface with restricted side-to-side mobility, known tender mass, no guarding tenderness or rigidity in any quadrant, no organomegaly could be palpated. On percussion, there was a dull note of a mass in right iliac fossa and tympanic note in rest of the areas. No flute thrill or shifting dullness was elicited. On auscultation, normal bowel sounds were heard. Pelvic examination. On local examination, external genitalia appears normal for age. No ulcer, mass or pigmentation over vulva. Labia majora, minora, clitoris were normal. Per speculum and per vaginal bimanual examination was not done. On per rectal examination, rectal mucosa was smooth. No nodularity was felt. Parametria was free. This patient is, sorry ma'am, I wrote 33. She's 29-year-old unmarried female with complaint of pain, abdomen with irregular periods with dysmenorrhea with right adnexal mass.
Just wanted to add, you have written parametria free. With only a PR, is it possible to, can you reasonably tell about parametria?
Ma'am, we have to
Only a PVR. So you are not able to do a PV. So you can tell more about nodularity. Was the mass, could you feel the mass through a abdominal and a rectal examination? Was it possible to feel?
Oh, ma'am, I could not feel the mass.
Okay, okay. So PVR is the proper method to assess the parametria. It is not possible to assess parametria fully only by a PR examination. What we can see is rectal mucosa and the nodularity well, right?
And in fact, you need not comment on parametria.
Yes, you may not. Yeah,
patients where you are having only an adnexal mass.
Absolutely.
So better to comment on the adnexal mass mobility, its extent.
Yes, right.
If you find that it is abutting the rectum or, I mean, kind of bulging into the rectum or something,
right.
things will be more useful for you.
Okay. So parametria is more useful when CA cervix or endometrium you are assessing. In ovary, we are, and with this mass, with this, it's better, as Dr. Seema said, that we comment on its bulge into the rectum rather than the parametria. Okay.
So now, what is your differential diagnosis?
Ma'am, the differential diagnosis.
First of all, when you summarize, I'm sorry, just go back to the slide of your summary. Just would like to add certain things in that.
I only written the age. She's 29.
So you need to, after your history and examination, it's a good idea to always summarize your case. Can you summarize it now again? Do it.
29-year-old unmarried female, unmarried non-sexually active female presented with complaint of pain in right iliac fossa along with irregular menses associated with dysmenorrhea. On examination, 10 into 8 centimeters cystic mass with regular margins and a smooth surface was felt in right iliac fossa. Which is known.
Irregular menses. I mean, after your history, such detailed history, it should not be only irregularity. You should be able to say short cycles or prolonged cycles or heavy menstrual bleeding and whatever was the problem. So irregular menses does not tell us anything, right?
With prolonged cycles, now.
Prolonged but not heavy, right? Prolonged cycles.
Prolonged cycle. Okay.
Just associated with dysmenorrhea.
Irregular, you use the word irregular, right? So what was the cycle length and what was the duration of the bleeding? Like prolonged cycle
bleeding for
was
3 to 5 days and the cycle was lasting for 45 to 60 days.
Okay, so prolonged cycle length, you mean? Okay, right.
So now,
sorry, Dr. Seema, please carry on.
No, it's okay. It's okay. Please carry on.
In the summary slide, you've written 33 years. I think earlier you mentioned 29 years. She's 29 years, right?
I only written 33.
Summary is 33. Okay, so she's 29. Okay, carry on.
So what is your differential diagnosis?
Ma'am, first is endometrioma and second is benign ovarian mass. And
Dekho, see, endometrioma is also a benign ovarian mass. So you can divide your differential diagnosis into gynecological and non-gynecological conditions. And now you come with the gynecological conditions, benign and malignant, both, right? And in the benign, it could be ovarian and uterine conditions, right? And now just put your points like that. That will make it easy for you to always remember what are you wanting from a patient. Okay, now you just explain that again.
Ma'am, she's 29-year-old, so gynecological is more likely based on her symptoms, and it looks more of a benign mass, which is of ovarian origin.
So benign mass of ovarian. How can you make out it is an ovarian mass only? It's a right adnexal mass. Right side pe you're feeling a mass. Why? Which uterine masses can present with the right adnexal mass as a right adnexal mass? Yeah. Uterine condition which can present like that.
Broad ligament fibroid.
Yeah, patient can present with a broad ligament fibroid or a
pedunculated subserosal fibroid.
Or a subserosal fibroid. So you just can't rule out saying that your patient only had some discomfort, dull aching pain. The prolonged cycles can happen into anything. Prolonged cycles, I mean, the subserosal fibroids may not have, short cycles or any other condition like that. Do you understand? So any benign conditions in the ovary? What are benign conditions in the ovary?
Ma'am, non-neoplastic conditions, most common is the functional cysts, which might include follicular or luteal cyst, thecal luteal cyst.
So can they be such large size? Usually they are not, right?
Not, ma'am, they are not usually the
usually they are
first has to be, theca luteal. Have you ever seen? We don't see such huge size. So they have to be, you have to, when you say functional, they are generally not of such size. So the first probable diagnosis should be the most commonly which you see. So what is the most common benign thing, benign ovarian, which we'll put here?
Dermoid cyst is also.
Yes, very good. Very good. Dermoid cyst. Teratoma. Yes, that is a very common, and especially in your patient who's having some dull, aching, chronic pain on the right side. So maybe getting some little bit torsion or detorsion kind of a thing is happening with her. Very good. So first thing is dermoid cyst. Second?
Endometrioma.
Yes, and the second thing can be endometrioma. Points in favor?
Dysmenorrhea.
Points against? Points in favor, age. She's young age, she's having painful menstruation, and there's a mass on one side of ovary, right? The points against?
What are the points in the history and the examination which are against? You mentioned the exam. First, see in the history.
No history or dysmenorrhea.
No history of painful painful defecation. Then there was nodularity when you assessed on PR. So that go against endometriosis. Okay, and a very mobile cystic mass. The mobility was good, as you said. It is a mobile cystic mass. One goes more in favor of dermoid. So when you put a DD, you have to give points in favor of this and against, both from history and examination, right? And then next.
And then other benign neoplastic mass. Yes, that is the functional system that Rajan said. Ma'am, serous cystadenoma or a business system.
Yes, serous adenoma, epithelial, benign epithelial or borderline ovarian masses. Not only benign, they could be borderline also, right? And disc growth. And TO masses, I told you, tuberculosis still you cannot rule out. Always remember TO masses, they will be there in our country especially. Any malignant condition that comes to your mind in this particular patient?
Germ cell tumors.
Germ cell tumors, very good. Germ cell tumors, they can be there. And?
Juvenile type of sex cord stromal tumor.
But what are the points in favor of sex cord stromal tumor and the points against sex cord stromal tumor in your case?
Ma'am, usually there is heavy bleeding or abnormal intermenstrual bleeding in case of sex cord stromal tumors. If it is a granulosa cell tumor because of excessive estrogen secretion. But
so irregular bleeding goes in favor of that.
There are no menstrual kind of but then it's not always heavy menstrual bleeding. The sex cord stromal tumors can be androgen secreting as well, and the androgen secreting tumors would present with the prolonged cycles, maybe and maybe hypomenorrhea, and then there can be features of virilism. So you can see that also. There are no features suggestive of any functional tumor. No hyperandrogenism or hyperestrogenic features are there, right? So they're not there, right? So how would you proceed now?
Ma'am, the first investigation will investigate the patient. First investigation is ultrasonography. She says an unmarried female will go for transabdominal ultrasonography. And the tumor markers. So, ma'am, tumor markers.
So what all tumor markers would you advise for the patient? You would do an ultrasound. So what all would you like to look for? I don't want to see the report of your patient. First, I want to know what will you want to look for in the ultrasound. You will do an ultrasound. What for?
We will look for the origin of mass. Where is it originating?
Very good. Good.
Size of the mass, and then if it is ovarian or uterine. If it is ovarian, then there are benign features or malignant features like cystic or solid areas are there.
What are these benign features or malignant features? What do you want to say?
According to IOTA classification, in this there are 5 B. These are the simple rules in IOTA classification. There are 5 B rules and 5 malignant M rules. B rules are B1 is a unilocular mass. B2 is smooth. Solid area, smooth solid areas, which is less than 7 mm in diameter, and B3 is posterior acoustic shadowing. B4 is smooth multilocular tumor with largest diameter less than 100 mm, and B5 is no on color Doppler color score is 1. The M features include M1 is irregular solid tumor, M2 so ascites, M3 is at least 4 papillary structures are there, M4 is irregular multilocular solid tumor with largest diameter greater than 100 mm, and M5 is strong color blood flow Doppler color score of 4.
Right. What is the ORAD system of assessing ovarian masses?
Ma'am, ORADS is the ultrasonography features based classification system of ORADS, which suggests the suspicion of malignancies. It is like data reporting system.
So what are the 5 groups and how do they classify the risk?
Ma'am, ORADS 1 include unilocular cyst with greater than 4 papillary projections, any size or any color score is there.
Just tell the broad groups also that the benign cysts come in group 1. They have given a percentage for every group.
Yes,
so what are the benign groups? and what are the malignant groups?
Ma'am, zero, there is incomplete evaluation. It is not clearly. In one, there is normal ovary function.
There is a simultaneous window open from where you are reading.
No, ma'am, just one.
Acha, okay. Carry on, it's okay.
That shows that examiners are not asking you questions fast enough if you're getting that time. You need to ask more faster questions from them.
So the
Quickly
thing
answer now.
1 to 3 is
Yeah,
1 to
get up.
3 is benign, 4 to 5 is malignant. So the advantage of this over iota is that it is giving you a predictive percentage of the risk of malignancy. Now iota initially was a logistic regression model which could also give this percentage, but now it is not available online because as per the guidelines now it is gone for FDA approval. So now we don't have this percentage with aorta, only you have the B and M rules. So that is why currently ORADS gives you a better assessment of the ovarian mass. Iota logistic regression, which was earlier available online, is not currently available for use by the normal clinicians. So this is the ORADS thing, right? Okay. So carry on. You will observe for these masses, these things in your scan. Anything else? What else would you like to look in the scan? These features you have said. Apart from that,
Septations, if more than 3 mm, thickness of the wall, if it is more than 3 mm, solid content, blood flow, all
this color score, septation, solid area, papillary projection, that is the mass. Apart from that,
lateral, if it is bilateral or unilateral.
Okay.
Will help us to differentiate between benign and malignant features.
And what else? What else would you like to see on a scan?
If wall there is torsion.
Evidence of torsion, though there is no history of acute pain, then presence of ascites. Any ascites which is not giving you is large enough to give you a fluid thrill, that you will see. And this is if it's ovarian. Otherwise, the origin of the mass, you have confirmed it's ovarian. That is why these features are there. So we are done with the scan. And next investigation. What tumor markers will you order for her?
CA125, CA90.9, alpha ketoprotein.
So CA125, what is the importance of CA125 in this case? And how sensitive and specific is it in your 29-year-old?
It is not specific.
There's a lot of disturbance coming. Could others please mute?
From someone else's.
From some other speaker it's coming. Your request to please mute. Yeah, please carry on. So CA125 in your patient at this age.
Epithelial ovarian tumor, which is seen in perimenopausal or postmenopausal lady.
You tell me about your case. In a 29-year-old with this mass, what do you want to find out by ordering a CA125? Look at your DDs and then tell me, no?
It is also increased in endometriosis as
One,
well.
good.
Pelvic tuberculosis, PID.
So the other two DDs tuberculosis, as in Indian population, we cannot rule out in any case for any female. So tuberculosis, PID also mildly, but mainly endometrioma. And so this, because it is raised in so many conditions, the specificity decreases. Now, what about the sensitivity? When you are looking at CA125 for a risk of malignancy, what is the sensitivity of it? Low or high? When we order something, we should know, na? See, sensitivity means that
sensitivity is high.
Sensitivity is high. So what does the high sensitivity mean of a tumor marker?
That shows positive value.
A high sensitivity of any tumor marker will show that there are less false negatives, right? But in this case, CA125 may be normal in almost 50% of cases of stage 1 CA. So it has a low sensitivity also. When we say high sensitivity, that means you are not missing out. You have very low false negatives, which is not the case in CA125. They may be as high as 50%. So it has a low sensitivity for malignancy and low specificity also because it is raised in so many conditions. right? But still we order to give us an idea. Suppose if you get a CA125 of 110 or so, then the picture shifts in the direction of endometrioma, right? And if it's very high, maybe towards a borderline tumor or a malignancy. Next tumor marker.
We ordered ma'am as CEA.
Okay.
99. But
CEA, what all conditions CEA is raised?
I mean, ovarian epithelial cancers, and it may be increased in germ cell tumors also because it is of embryonic origin.
Germ cell CEA is very unlikely. What are the other conditions? CEA can be raised in conditions from disease, pathology of what all?
In other condition, non-gynecological conditions. So, like in colon cancer, it might be increased in colon cancer.
See, if your ultrasonographic feature does not give you a very high index of very high risk of malignancy, CEA will tell you about the risk of all the risks from the gastrointestinal pathology. It will be raised in that. See, so if you have CA125 and CEA, do you know about some ratio which you can see to find out whether it is a gastrointestinal pathology or if it is a malignancy? Otherwise, not. This is if your scan is showing benign, you may not order a CEA. So what is that ratio? Okay, chalo next tumor marker. First talk about germ cells. Look at your patient, she's 29-year-old. Our first DD was endometrioma, then a germ cell tumor, a benign teratoma, and all these germ cell tumors. So you have to target your investigation has to be targeted towards your symptoms and your examination and your investigation, right? So after an ultrasound and with this age group, you should have markers for germ cell tumor. So alpha fetoprotein, okay. Alpha fetoprotein is raised in which tumor? Which germ cell tumor?
Yolk sac tumor.
Yolk sac tumor, okay. Next.
LDH.
LDH raised in?
In this dysgerminoma.
Okay. Next.
CG is in choriocarcinoma.
We don't expect that, but mixed germ cell tumor and immature teratomas may have different raised germ markers. Next.
CA19.
Germ cell ke first finish the markers for germ cell. Inhibin also you will do, right? Right? Inhibin for adenosine tumor. And then CA19.9, what does that tell you?
It is seen only in dermoid tumor. Not only in dermoid tumor.
Not dermoid tumor. CA19.9 is raised in what kind of tumors?
Pancreatic malignancy.
And for ovarian, what kind of malignancies?
Epithelial.
What kind of epithelial? They are very specific for one particular type of epithelial.
Mucinous.
Yeah, good. Very good. Mucinous. So they are raised in pancreatic, that is the non-gynecological condition, and mucinous tumors. And even benign, although they are raised higher in malignancies, but even benign and borderline tumors, like which is more specific for your age. A 29-year-old, if it turns out to be an ovarian tumor, there are high chances it will be benign or maximum a borderline. Even in them, CA19.9 can be very raised. It has been reported. So that is also one marker which will tell you. Okay. So any other investigation? The routine investigations of pre-op. Okay, Dr. Seema, do you want to add anything or should we proceed with the results? And Dr. Seema, are you there? Chalo, okay, I think she's muted. Chalo, you have told all these investigations and then?
Then we'll
all routine pre-op. So what is your plan of action now?
Ma'am, since it is the tumor markers are normal and it appears benign, then we'll go for a laparoscopic resection.
So show me the reports now. So we have planned that all this will do, and then we will decide our management. Okay.
Ma'am, on ultrasound, there was a well-defined cystic lesion of 12 into 9 into 7 centimeter in right adnexal arising from right ovary with dependent highly echogenic shadowing component like fat containing with a uniform hyperechoic nodule punctate calcifications and posterior shadowing. So,
okay.
Dermoid cyst.
Okay.
In tumor markers, CA125 was 12.8 normal value, CA19.9 was 111.76, slightly elevated. CA 1.7, LDH 184, serum beta LCH was less than 1.10, AFP was 7.8, again normal value. So tumor markers were almost normal, except for slightly elevated CA 19.
Yeah, okay. So what did you plan for her? So what is a provisional diagnosis?
Yes, ma'am. Ma'am, we planned a laparoscopic.
Your provisional diagnosis is after all these reports and after the scan?
Dermoid cyst.
Okay, so if in case your sonography was inconclusive and you're not able to make out, what is the nature of the tumor, what is the next investigation you can order for her?
MRI.
MRI or a CT?
MRI.
Yeah, so MRI, very good. MRI should be done if your scan is indeterminate to about the nature of the lesion. And when do you order a CT for an ovarian mass?
Ma'am, to know the extent of the disease.
Extent of the spread. Yeah, very good. So CT scan gives you a better idea about the extent of spread if you are suspecting a metastatic disease. And MRI for the ovarian mass will tell you the nature of the mass if your scan is indeterminate or you have a confusion about the nature of the mass, so that you can decide on the management in a better way. So with your scan and your tumor markers, your provisional diagnosis is a dermoid, which is around 12 centimeters in size, right? It was 12 into 8 or something, right?
12 into 9 into 7.
12 into 9. Okay. So what was the plan? What did you plan for her?
Laparoscopic cystectomy of dermoid cyst.
So when you are going to do a laparoscopic cystectomy for a 12 centimeter dermoid, what are the things you have to keep in mind?
We have to remove an endo bag to avoid the spillage, the content of dermoid spillage, which might lead to peritonitis.
Okay. So the removal and it should be antoto removal, and even if it is to be drained, because it has to be drained before you take it out, it has to be in the bag. And a laparoscopic attempt for a 12 centimeter dermoid should be done only if the surgeon is expert in and confident that it can be done without spillage in a bag, right? Okay. So what counseling, what will you counsel to the patient? What consent will you take? What will you tell her?
Ma'am, we will explain that the 12 centimeter, the disc, we will explain to the patient.
Can you be a bit loud? A lot of people in the chat are saying that you're not audible.
Ma'am, we will counsel the patients.
Please speak closer to speaker.
We will counsel the patient regarding 1% chance of malignancy might be there in case of a dermoid cyst, and the risk of tumor spillage we should also explain to the patient. Although we will do it in endovac, but an accidental spillage might be there, and we will also counsel ma'am that's about the extent of ovaries involved, because intraoperatively we will see that most of the ovaries eaten up by the dermoid cells, then we may need to do oophorectomy of the involved ovary.
So in case you're not able to remove, otherwise it is almost always possible to remove a dermoid cyst from the normal ovary. But still, when you're taking a consent, it's always better to enter into that space after taking all consents. So you have, and if do you keep any other chances open when you're taking consent of the patient? Although your scan shows dermoid cyst. So will you tell her something else also? It may not be a dermoid cyst, so that should be included in the consent. So what will you tell her?
Ma'am, we will tell them about the histopathology report, which we will get around 1 to 2 weeks after surgery, which will tell us the final diagnosis. And then if by mostly from our clinical judgment and investigation, we suspect it to be dermoid, but in case if the report says something malignant, then we may need a second look surgery.
Second look surgery, but before that you have also to take a consent that although in most of the cases it's going to turn out a dermoid, but intra-op, if you feel that the look of the tumor is suspicious, is more like malignant, you may like to send the mass for frozen section, and accordingly the patient will be treated, because the patient is under anesthesia. You have to explain this to the patient before. that the chances are very low, but I may send the mass for frozen section if it doesn't look like which is the chances are very low in a dermoid. But when you're taking a consent, you have to take everything into account. And the second thing, that after histopathology, final diagnosis will come only after histopathology, because that is the gold standard, right? And so what was done in this patient? She has been operated yet?
Yes, ma'am. She's been operated. Laparoscopic excision was done with endobag removal, and surgical examination was corresponding to mature dermoid cyst.
I didn't get it. And histopathology?
Benign dermoid cyst.
Okay. So in case the histopathology, if the patient doesn't turn out to be a dermoid cyst and it turned out to be this is a 29-year-old, it turns out to be a borderline tumor in your histopathology. It was some solid cystic mass and the histopathology is borderline tumor. Now, what will be your course of action?
Then, ma'am, we will go for second look surgery that would involve unilateral rectomy.
She's a 29-year-old and unmarried, no?
Yes,
So,
ma'am, unmarried. Fertility unilateral rectomy.
so I have asked this, if you at the time of laparoscopy, if you feel that it has been a suspicious mass, then a total inspection of the upper abdomen and has to be done in the same sitting.
Ovary will be done.
It has to be done in the same sitting first. Okay? So that then the procedure will be changed into a staging laparotomy, or if the surgeon is very confident that he can do a staging laparoscopically, that he can take see all parts of the abdomen and take biopsy from suspicious areas, then that can be done laparoscopically. Because sometimes you may be getting surprises intra-op. Right? So that is the thing. If you have that, so when you are putting in a scope and you have a suspicious mass, she should not be subjected to a second look surgery. You have to do the staging in the same sitting. That is what we have taken a consent earlier. That if there is anything suspicious, the surgery may be changed into a staging laparotomy or a staging laparoscopy. So now the report has come as mucinous borderline. So what should we do?
Ma'am, the frozen report, I think the frozen report is...
Final histopathology has come as mucinous borderline.
Ma'am, if during the first laparoscopic surgery, if we would have done cystectomy, then again we need to do the oophorectomy of the involved ovary. Since she is very young and it is a borderline mucinous, we don't need to remove other ovary or appendix.
Even after removal of the cyst, since she is unmarried, she still has an obstetric career to complete. She has to be kept under follow-up, and you don't need to do a oophorectomy, but we can just go on with the regular follow-up, and after completion of a family, the completion surgery can be done. Because there is no role of lymphadenectomy, we can go in for a fertility preserving surgery, which you have already done. So the patient doesn't need anything further apart from the fact that a proper staging laparoscopy or a laparotomy was done at the time of original surgery. If that has not been done to rule out implants, then you have to do a second look, which should not be the case if you have found a suspicion at the time of surgery, right? So Dr. Seema?
Yeah, hi.
Hi,
Yeah.
you want to add something?
In our discussion that regarding the second look surgery, I could not understand that because sorry, can you repeat that?
I had just asked that if the histopathology, it was suspicious mass and it came out as a mucinous borderline, then what should we do? So that they were answering, but that
Coming out on frozen or on final histopathology?
Final histopathology. On frozen, that is what we were discussing, that they should do a complete staging if it comes mucinous on frozen. For a fertility preserving. So there is no need for a second look in such a case. They should have it in the first step. This is what there is no need, and they should do it in the first step only if the frozen, if the intra-op look is suspicious, or if the frozen gives you something else than a teratoma.
See, there's no current. Yes, you're right. Very true that we have to do a wholehearted surgery in the first go. There is no doubt on that. But remember, when a young woman is there, you are doing for a fertility preservation option. Then be conservative.
Absolutely. Just the mass only, but just looking at any evidence of spread.
The young girl is there. Removal of her organs is not okay until you're really sure of her diagnosis. And so another thing is, always remember frozen has its own limitations,
Right.
especially with respect to the mucinous masses, because they're large masses and they harbor the areas of benign, borderline, and malignant within the same mass. And frozen is a very limited exposure. You just take out one section and do from there. Not that those multiple sections which will be taken in a frozen section. So always remember that, and you counsel the patient accordingly that they might require a comeback in case it turns out to be malignant. So what is the extent of the peritoneal staging for a borderline mass? Suppose she's borderline serous.
Right.
Then what is the extent of peritoneal staging? What all will you do?
Ma'am, we will look for any, we will examine the contralateral ovary, and we will also look all the abdominal examination to look for any suspicious masses on omentum or in any other areas. So we'll take the biopsy from the suspicious areas, and an infracollicular omentectomy will do.
So yes, you will do a peritoneal cytology, as you said, infracollicomentectomy, multiple peritoneal biopsies. What about lymph nodes? Will you do lymph nodes or not?
No, ma'am. Ma'am,
You will not do a systematic lymph node. Very good. Well, very well said. So fine. Now she's germ cell tumor. Suppose she turns out to, as you're showing, the markers are all normal. And her CA 19.9 is 111.76, right? So then that is why she could be a mucinous adenoma, as Dr. Vashi has very rightly explained that to you. So now suppose she's germ cell tumor. Suppose she turns out to be teratoma or something. So what will you do now?
Immature teratoma. Ma'am, we will go for staging nephrotomy.
No, intra, beta, intra. You've already
Ma'am, we send for frozen section. As ma'am has explained that if it is looking suspicious, then we will convert into a staging laparotomy, and we will go for unilateral nephrectomy. If it is germ cell tumor, immature teratoma. And we will palpate each and every organ and see if there is any suspicious lesion and take the biopsy.
Right.
And this, then further we can go for chemotherapy, as these tumors are highly chemosensitive.
Okay. So as Dr. Vashi had already told you, that always remember not to morcellate the mass, as she
That
very
has
nicely to you that you should not morcellate the mass unnecessarily, unless until it is endometriotic cystectomy you are doing, where there will be spill ho jayega. Even rheumatoid cyst also you can. So your imaging and your markers and your clinical appearance will be quite suggestive to you that your patient is what you're dealing with is not a suspicious case. So laparoscopy, cystectomies, these are for those non-suspicious cases, and the ones who are suspicious, where you will go for this thing. Okay, there's some question in the chat box, ovarian tissue cryopreservation and fluid cytology, right? And there are few questions in the chat box. Appendectomy in mucinous tumors, that's one question. Then can you tell me, if your patient has mucinous mass, what will you do about appendix?
Ma'am, if appendix is normal, if there is no abnormality, then we do not need to do an appendicectomy.
Very good, shabash. So even if it is a mucinous borderline or it is a malignant, you will not do an appendicectomy as a routine, right? Then fluid cytology, definitely you will send for all these cases. And then ovarian tissue cryopreservation. Any comments from you on this? So ovarian tissue cryopreservation is a little bit dicey for this particular case, especially for CA ovaries. But so suppose she's a benign condition, you will definitely not require it. But if it is a malignant tissue, then you do not know that in the other ovary whether it is harboring the malignancy or not. So ovarian tissue cryopreservation doing for a malignant ovarian tumor is really a very dicey game. Unlike other malignancies like cervix or where the risk of having metastasis in the ovaries is very low, 1 to 3%. And similarly in the endometrium also 7 to 8%. So you don't worry about those patients. But about the CA ovary, harboring risk of malignancy in the other ovary is really high. Sometimes more than 10%, 20%, even in the epithelial ovarian tumors, it is higher. So having tissue cryopreservation done for the sake of this is a little difficult, but yes, one can have it and one can check for this cortex, fine cortex, you can check for the histopathology, but then a little bit dicey, especially for high-grade serous cancers, it's really difficult. For germ cell tumor, you're going to preserve the ovary as such within body as much as you can, because patients would respond to chemotherapy, as Nikita and our colleague has already told us clearly that yes, you will preserve the ovary for those patients. Otherwise, for younger patients, you go for fertility preserving options as much as you can. Especially even if you're in doubt, it's always better to come back and do it complete later on, rather than removing it with a suspicion at this stage. Preserve them as much as you can. Cryopreservation will not be a very good idea for these patients at this stage, 29 years old. And if she's harboring a high-grade serous cancer, which could be if she's 1A high-grade serous ovarian cancer, as such, you're going to leave the ovary inside her body. You can do a fertility preservation operation with complete staging procedure. But if she's more advanced high-grade serous, then no point of ovarian tissue cryopreservation. Also, go ahead with a complete surgery. I think we have answered all their queries, Dr. Urvashi.
Yeah, it's done, and I think we have covered all DDs also. Any other questions? I think that should be all. Any questions from you, Dr. Nikita, and yourself? Anything you want to ask? I think we have answered. Dr. Purvi, the questions in this we have addressed.
Yes, ma'am.
Yeah, that should be okay.
Yeah, we answered the questions. So with this, I think we can close our session, and we will thank.
It was well presented, Nikita, and you well presented, well answered. Okay. Always remember when you answering history or points from history and examination in sequence. And as Dr. Seema beautifully said, divide your DD into gynecological, non-gynecological, benign, malignant. If you do it systematically, you will not forget. And it is, very pleasant for the other person to understand and listen. They'll also understand that you have a basic understanding of the whole physiology and how it is working, right? So how you present and answer is also an art. You may be knowing everything, and always common things first, and don't speak about things which you don't know. Like mesenteric cyst is not the first thing which you will say.
Very well pointed out, Dr. Urvashi. Very nice tips that you've given them. I think with this we'll close the session.
Thank you so much. Thank you, Seema ma'am. Thank you, Dr. Urvashi. Thank you, ma'am.
Thank you for giving us this opportunity.
Thank you for the opportunity, Purvi. Thank you so much.
Thank you, ma'am. Now moving on to our last session, but it is very important on CTG. I would call upon Dr. Chanchal. Ma'am, are you there? Dr. Chanchal, she is lead consultant fetal medicine in Madhukar Rainbow Hospital, Madhukar Rainbow Children Hospital, and right by Rainbow Hospital, Malviya Nagar, New Delhi. Her special areas of interest are antenatal screening, high-risk pregnancy, especially in fetal growth restriction, multiple pregnancy, and fetal intervention. Ma'am?
Hi, Purvi.
Hi, ma'am. Yeah. Yes, ma'am.
So, shall I share my screen?
Yes, ma'am.
I'm sure everybody must be exhausted by the end of the day.
But CTG is one of the most important topic these days. Exam purpose as well. So I know everybody would be attentive also.
So I'll stick to time.
Yes,
I've been asked to, first of all, I would like to thank the organizers for giving me this opportunity to interact with our postgraduates. Postgraduation is one of the best times that one can have in one career, where one still learns and the responsibility is not yours. So make the most of it and keep yourself updated. So I've been asked to talk about cardiotocogram. The first question that arises is that what is the need for CTG? So the aim of pregnancy management is to time delivery in a way that optimizes the health of both the mother and child. And CTG was introduced in 1960s as a screening tool to reduce intrapartum fetal deaths and fetal hypoxic injury. More than 5 decades later, there has not been a reported decrease in intrapartum fetal deaths. However, continuous CTG monitoring does decrease neonatal seizures. It reduces rates of fetal CNS injury. So we don't know, we do not have any conclusive evidence that it reduces the risk of intrapartum fetal deaths. However, all the major guidelines across the world continue to recommend continuous CTG monitoring for high-risk pregnancies. So any tool, when I feel that when you have the correct knowledge and when you apply it correctly, it becomes a boon. So CTG abnormalities have been termed vaguely as fetal distress, but that is a poorly defined and vague term and should not be used. So whenever you write an indication for a cesarean in your, or an assisted vaginal delivery in your notes, you must use the correct terminology and not just write fetal distress. I have based this talk on the NICE guidelines, which have recently been updated in 2022, and they are similar to the FIGO consensus of 2016. Now, whenever you look at a CTG trace, you always remember this acronym, Dr. C. Bravado, and you will be able to go through that trace logically. So they always remember this acronym. DR stands for duration and quality of recording, and it also stands for defined risk. The same CTG trace will have a different interpretation for a growth restricted fetus as compared to a fetus who's appropriately grown. So DR, defined risk. C stands for contractions. We often forget that the TOCO is on, the contractions are not being recorded. So that is why it has been put right on the top of the list, because hyperstimulation remains one of the most important causes of fetal hypoxemia. So contractions, B stands for baseline heart rate, V stands for variability, D for decelerations, and A for acceleration. So whenever you are looking at a trace, always for every part of the trace, go through these subheadings and then classify that part of the trace as abnormal, suspicious, pathological, or abnormal. Now, what is meant by the duration and quality of recording? The minimum duration of 20 to 30 minutes is required for proper interpretation because it accounts for changes in fetal sleep state. It accounts for the changes occurring in the fetal heart rate owing to the uterine activity. A good signal quality is essential to enable accurate interpretation. You must always check the identification. So these are medical legal documents. So whenever a CTG is shifted from it's shifted from one patient to another. You always cross-check the name, the date, time, pay attention to the paper speed. The NICE recommends a paper speed of 1 centimeter per minute, and all my traces, which I will show, have been done at that trace. So now, if you look at this short snapshot of the CTG, this CTG is running at a speed of 1 centimeter per minute. So when the y-axis is usually not a problem in interpretation because the heart rates, these are documented 120, 150, 100, and usually one small row will correspond to 5 beats per minute and one big row will correspond to 20 beats per minute. What people mostly have trouble understanding is the x-axis. And if your paper speed is set at 1 centimeter per minute, if it is set at 1 centimeter per minute, one small column, so I had forgotten to put it on full screen. So this is just to show what important things are to be mentioned on the NST. So here there are the particular of the patient, the date and time, a good quality recording of at least 20 to 30 minutes, contractions, the TOCO is placed properly, you can see contractions on the trace. And as I said, the fetal heart rate one can read easily. So when the paper speed is set as 1 centimeter per minute, one small column would correspond to half a second. So this one big column is corresponding to 1 minute. And if you see, there are highlighted vertical lines which are set at every 3 minutes. So 1 minute, 2 minutes, 3 minutes, and then becomes this highlighted line. It has been set so that at a glance you can see how many contractions are coming in 10 minutes. So 3 minutes, 6 minutes, 9 minutes, and another one big column, 10 minutes. There are about 2 to 3 contractions in 10 minutes. Can you interpret this trace? I think it is very difficult to interpret this one because you can hardly see a trace. So the quality matters. So whenever you have a trace like this, you readjust the CTG probe on the maternal abdomen, make sure that an adequate quality of recording is available before you start interpreting it. Now, coming to baseline fetal heart rate. If you draw a straight line through a stable part of the CTG, which does not have accelerations or decelerations. So the fetal heart rate recorded between contractions over a period of at least 10 minutes that would account for the heart rate. A normal baseline fetal heart rate for term fetus is between 110 to 160. Here in this trace, the baseline is 140 beats per minute. The next most important, in fact, more than accelerations or even decelerations, the most important component of the fetal heart rate trace is variability. These are beat-to-beat variations that are neither accelerations or decelerations. These are measured by difference between two lines drawn to the highest and the lowest point of trace in any 1 minute segment. So if you see this, I've drawn a line through the highest portion to the lowest portion, and you count the small boxes within. Here, 1, this is 5, 10, 15. So 15 beats per minute is the variability. You can draw it across any 1 minute part of the trace. And if suppose that there was a small downward dip, like a deceleration, I would have counted it at the nadir of that deceleration. So this variability provides information about the ability of the fetal central nervous system to monitor and adjust to the cardiovascular changes that happen because of labor. And it can vary with time depending on the fetus sleep cycles and activity. So here you can see another part of the trace where we are measuring the variability. Normal variability is 5 to 25 beats per minute. Here you can see that the variability is 20 beats per minute. This is reduced variability. You can see that although the fetal heart rate is varying, however, it is confined to this 5 beats per minute. It is not crossing. It is one has to be careful while interpreting this, because when the baby goes off to sleep, your trace can look like this. A trace which is running at the speed of 3 centimeters per minute can also look like this because of the speed of the paper. And that is why it's very important to check what speed your CTG machine is set on. When the variability is more than 25 beats per minute, it has been termed as a saltatory pattern. I will come to the importance of these different patterns. Now, these are accelerations. They are easy to spot. An increase in the baseline fetal heart rate of more than 15 beats per minute lasting for more than 15 seconds. However, when we are talking about intrapartum trace, the absence of accelerations, when all other features are normal, it is quite common and it should not be a cause of concern. The most confusion occurs in the interpretation of decelerations. The definition is fairly straightforward. Drop in the baseline fetal heart rate of more than 15 beats per minute, lasting for more than 15 seconds. Earlier guidelines used to classify it as typical, atypical. Now they have discontinued this terminology. The deceleration should be classified as variable, early, or late, depending on their relation with the contractions that are happening. And for me to say that there are decelerations, they must be present with more than 50% of contractions. So we must learn to, some amount of the variable deceleration will always be present in 80% of intrapartum traces, because that is a normal adaptation of the fetal heart rate to the contractions. We need to identify which are the significant decelerations. So there are various documents, American College, NICE guidelines, they all agree on this, that the significant decelerations are the ones which take longer than a minute to recover. When there is reduced variability within that decelerations, within that loss, and when there is a failure to return to the baseline, or the return to the baseline is much longer, and there is loss of previously seen shouldering at the end of the decelerations. I'll show you what I mean by all these changes. So This is a usual intrapartum trace, and this should not worry you. The reason being that the baseline here is about 150 beats per minute. There are dips in the fetal heart rate. However, they are matching your contractions. Every time there is a contraction, the fetal heart rate falls, but as soon as the contraction goes away, it is recovering. And none of them is taking longer than a minute to recover. If you see, we just learned that one small square is 30 seconds. Here, none of the deceleration is taking longer than a minute to recover. So these are early decelerations. These are variable deceleration because they're varying from each other. They're present with more than 50% of contractions. However, they're recovering within a minute, and the loss of beats is less than 60 beats per minute. So these are acceptable. They are not part of normal labor. However, if you compare it with these decelerations, they are taking longer than, they are taking just about a minute or long. If you look at these variable decelerations, the fetus that I was talking about, see, when the fetal heart rate drops, just before that, there is an acceleration. This is the shouldering we're talking about. This is a reassuring feature. When you look at the decel itself, there is variability within the deceleration. So you can see that the heart rate is, there are fluctuations in the heart rate within the deceleration. And yes, these are still early decelerations because they're matching the contractions. They're recovering within a minute, though the depth is just slightly more than 60 beats per minute. Variable decelerations account for 80% of decelerations in labor. Do not forget the contractions. And here I try to just show that these are decelerations recovering within a minute. Loss of 60 beats per minute and recovery within a minute. They can be watched up to 1.5 hours, more than 90 minutes. However, if they are deeper, that means the loss of beats is more than 60 beats per minute, or they're taking longer than a minute to recover. These are significant variable deceleration. Or when you have instituted conservative measures and the decelerations are not responding, that would warrant attention. Look at these decelerations. So you can see that the baseline heart rate, there is accompanying tachycardia. The baseline heart rate is above 160. The fetal heart rate falls. It is taking 1, 2, and 3 minutes to more than a minute to recover. Baseline is 170. Though there is variability within the deceleration, there is still shouldering. However, a deceleration which lasts for 3 minutes or more, that is an abnormal feature, which is in the new classification. I will just come to the new classification of these features. And this would be a pathological trace because the decelerations are taking much longer to recover, and this warrants attention. So, whenever the fetal heart rate drops to less than 100 beats per minute, and this drop lasts for about 3 minutes or more, these are called prolonged deceleration. A single episode of decrease in fetal heart rate, however, the fetus usually copes well with an isolated prolonged deceleration. And the various causes could be that the mother has changed her position, or she has been given an epidural, or it is due to a vaginal examination that was just recently done. They can all result in a single prolonged deceleration. So if you see here, at the beginning of the trace, the heart rate is about 150 beats per minute. It looks fairly reassuring. But then there is a drop in the fetal heart rate, which has taken almost 5 minutes to recover. However, once the fetal heart rate has recovered, you can see towards the end of the trace, there are accelerations, there is good variability, and the baseline is okay. So an appropriately grown fetus with no other risk factors, they're able to withstand a prolonged deceleration very well. And this should just prompt, it is classified as an abnormal feature, and it should prompt a reassessment of the mother and the fetus. And if it recovers, then it does not warrant any change in the management. Most decelerations are early decelerations because they coincide with the contractions. So here you can see that there is a drop in the fetal heart rate. However, the nadir of the dip corresponds to the peak of the contraction, and they're literally mirror images of each other. The early decelerations start and end with contractions with no time long. They are a reassuring feature. This should not cause any concern regarding the trace. However, if you look at this trace, you can see that the contraction here, there is a contraction coming, and then the fetal heart rate stops dropping. And this is what I was talking about, that the fetal heart rate is taking longer to come back to the baseline. And the contraction is long gone here. However, the drop is taking much longer to recover. These are usually associated with a tachycardia. If you see here, the baseline is almost 180. So there is fetal tachycardia as well as late decelerations. If I were not to draw these lines comparing the depth of the fall in the fetal heart rate with the peak of the contraction, it may just look like a normal trace, because in these late decelerations, sometimes the drop in the fetal heart rate may not even be of 50 beats per minute. They may be very shallow. And that is why it is very important to try and correlate the deceleration, time it with the contractions, so as not to miss these late decelerations. Variable decelerations, they are very striking. Nobody will miss them. But it is the late deceleration that one tends to overlook unless one pays attention. And thankfully, usually it will be associated with other abnormal features like decreased variability or fetal tachycardia. That these late decelerations are also an abnormal feature. Now here, I had put in this trace just to show that sometimes traces may look okay if at first glance. However, if you look carefully, the baseline fetal heart rate here is almost 170, which is non-reassuring. And although there is variability, there is this undulating characteristic about this trace. If you see here, the variability, if I measure, if I draw a line from the top, milk in the hostel, I think. So this variability, if you see, if I check, the variability is about 10 beats per minute, but you can see that it is quite smooth, and this is a typical sinusoidal pattern. The baseline is 170. There is variability. However, there are no decelerations, no accelerations. This is an intrapartum trace because you can see that there are contractions in the bottom of the trace. And this I've magnified just to show you the typical characteristic of a sinusoidal trace. This is invariably pathological. Sometimes it may last for 20 minutes and then it recovers, in which case it would be a pseudosinusoidal pattern. But if this pattern is persistent for more than 20 minutes, it should be alarming. And it is usually associated with fetal anemia or chorioamnionitis. It is a normal feature. As I said, we will not forget the contractions. This is the old chart that we are all used to. Essentially, the categorization of each feature still remains the same, but they have now given, the NICE in 2022 has modified its guideline and given color coding to these changes. And they've put the contractions right on the top. So if you see on the first column, contractions of less than 5 in 10 minutes, a baseline heart rate of 110 to 160, a variability of 5 to 25, no decelerations, early decelerations, variable decelerations with none of the concerning characteristics that we spoke about. What that means is more than 60 seconds, reduced variability within the deceleration, a failure to return to the baseline or a slow return to the baseline, or loss of shouldering. The first trace that I showed you of the deceleration, where there was a sharp fall, sharp rise, but which was recovering within a minute. They have removed, they're saying that the variable decelerations, which are not deep, which are recovering within a minute and no concerning characteristics, they are to be not to be categorized as suspicious or non-reassuring or pathological. A normal trace, when all the features are in this white column, the CTG is classified as normal. If the contractions are more than 5 in 10 minutes, or if a single contraction lasts for more than 2 minutes, the middle column is the amber column. So it's suspicious. Any one of the amber characteristic would make your CTG suspicious. So you classify each feature individually, put everything together, and then classify the CTG trace as normal, suspicious, or pathological. So the amber features are contractions more than 5 in 10 minutes. If the baseline is less than 110 or more than 160, or if you're unable to determine the baseline, sometimes in the saltatory pattern where I saw you, there was just continuously movement and you are unable to determine the baseline. A variability of less than 5 minutes, 5 beats per minute, but for more than nearly an hour. Or if it is when we were talking about the saltatory pattern, when the variability was more than 25 beats per minute, the duration for us to classify it as suspicion has been reduced from 25 minutes now to 10 minutes. So we must take note of a saltatory pattern. This is the change from the previous 2017 guideline. Coming to decelerations, if there are variable decelerations with concerning characteristic, that is, they're taking longer than a minute to recover, there is loss of variability within the deceleration, there are no shouldering. Then, if it is even less than half an hour, that would be an amber feature. If they last variable decelerations with any concerning characteristic lasting for more than 30 minutes, and late decelerations. Late decelerations, again, as I said, it is a concerning feature. Any one amber feature would make the CTG suspicion, and that calls for a full risk assessment, including maternal observation, and you need a review for additional new risk factors, and you would start conservative measures. One can consider fetal scalp stimulation, or expediting birth, depending on the clinical situation. Now the red features, a persistent heart rate of less than 100 beats per minute or more than 160 beats per minute. If the variability is less than 5 beats per minute for more than 50 minutes, more than 25 beats per minute for more than 10 minutes, sinusoidal pattern. Any sinusoidal pattern would make it a pathological trace. And repeated decelerations, acute bradycardia, the single prolonged deceleration, and late decelerations. These are all, they would be classified as pathological. And however, one must remember that a pathological trace is not synonymous with immediate delivery. A pathological trace calls for a reassessment of the entire situation. If there's a previous cesarean, reassess the patient. Is there a loss of station? How much is the mother's heart rate? Has her BP fallen? Do a vaginal examination. Is there a cord prolapse? It essentially calls for a reassessment. And if a pathological trace does not recover within half an hour, you would want to expedite delivery. And the mode of delivery would depend on the vaginal examination. Fine. So actually, in a sense, when the trace is pathological, there are 3 situations which are quite urgent, and rather 4 which are urgent. One is cardiacism, cord prolapse, abruption, and hyperstimulation. So you would tailor your management according to what is happening. Now, the NICE also makes a very nice comment that you assess and document all 4 features. However, it may not be possible to categorize or interpret every CTG trace. So it is important that we get together, not just senior, your junior colleagues, whoever is available. If you are not sure about a trace, then one can always take help for interpretation. And in this age of WhatsApp, one can just click a picture and send it to anybody. So, and one of the reasons why we fail to use CTG as a tool that would help us is because we start interpreting it in snapshots. Rather than that, one should consider a longitudinal fetal heart rate pattern. So I always like to add that apart from the 4 features, rather 5 if you include the contraction, there should be a 6th component of the CTG, and which would be the trace at admission. So if the patient was admitted with a fetal heart rate with the baseline heart rate of 140, and now if you're getting it consistently 120, that should really concern us. So the CTG, the trick to interpreting CTG and to use it as a valuable tool in our labor ward is to consider how it is changing over the period of labor, and by interpreting it in context of the patient. And that leads to timely recognition of progressive fetal deterioration, because stillbirth happens when when we've really pushed the fetus to the end, when they can't really compensate for the hypoxemia that every fetus is subjected to during labor. So now in these audits, this audit and review of stillbirths and neonatal deaths, the error in CTG interpretation leading to hypoxemia and stillbirth, the reasons that were concluded was failure to take into account context. As I said in the beginning, the same trace may be interpreted differently for an appropriately grown fetus as compared to a growth restricted fetus. So the 3 risk factors, prolonged leaking, prematurity, growth restriction, you would interpret these CTGs much more carefully and be more proactive about taking action on these traces. Failure to recognize the effects of cento augmentation, delay in taking action, poor communication, and most of the cases of fetal hypoxia with cento augmentation were because of inadequate uterine contraction monitoring, poor technical quality of the fetal heart rate trace, cessation of monitoring the fetal heart rate or uterine contraction much earlier than the time of delivery. When the mother is in the 2nd stage and the fetal heart rate is dropping, more often than not, if you look at your trace after the delivery, you realize that the TOCO part is missing for the last half an hour. So we have no way of knowing whether this uterus was contracting too frequently, whether hyperstimulation was happening at that time or not. Commencement starting cento when there are major risk factors, for example, thick MSL, evidence of choreo, or a suspicion of abnormal fetal heart rates. And of course, the failure to recognize hyperstimulation. I have put in one extra slide because we often, are asked to interpret CTG in preterm fetuses. There's currently no guideline on interpretation in premature fetuses. We can do it after viability, or we can do it after 28, 32 weeks. However, one must take into remember that there is a baseline tachycardia for preterm fetuses, and the variability would be decreased. So the only feature on the trace which would prompt us to take an action in a preterm fetus is persistent decelerations, repeated decelerations which are taking longer than a minute to recover, or the loss of beats is more than 60 beats per minute, because these fetuses will have baseline tachycardia and decreased variability. So role of CTG in preventing hypoxic ischemic injury in stillbirth is by preventing these complications by timely intervention. Before things get out of our hand, we must interpret the CTG. And most of the errors in interpretation are because these are gradually developing hypoxemia. So the accelerations are absent. As I said, that should not concern us. However, if the baseline is steadily increasing, the variability is decreasing. Initially, you are having a variable deceleration, but slowly those decelerations are becoming broader and taking more, the shouldering disappears. So the pattern recognition is very important. And we can prevent errors in CTG interpretation by individualizing each CTG. Adopting a systematic approach, using the correct terminology, correct classification, the new, these color coding, the white, amber, and red, it is meant to rectify these things, that we are able to communicate more easily with each other. It is a continuous learning. Every time I teach CTG, again, I have to go back to the type of decelerations. So it is a continuous learning, and in every labor ward, one must have a continuous audit and, if possible, certification. So my take-home message is that one must treat the patient and not the CTG. Thank you very much.
Thank you so much, ma'am. Thank you for the discussion. Just two questions. Payal is asking what is shouldering and what is significant.
When the fetal heart rate drops, you see a small bump, small increase in the heart rate. So the baseline is 140, then there is an acceleration, and then the fetal heart rate drops. And when it is recovering, it will overshoot the baseline and then return to the baseline. So the end at the either end of the deceleration in the fetal heart rate, that shows a small peak. That is called shouldering.
And Shobha is asking to calculate baseline, how much time CTG tracing is needed.
You would want, you're asking me how long the CTG should run for calculating the baseline heart rate.
Yeah.
Yeah, it is recommended that you measure it over a 10-minute trace. The most straight part of the trace. Somebody is asking if FHS goes down from 130 to 100 and then run back to 130, but it lasts for 15 seconds. And then there's acceleration. No, we don't need to observe, because so you saw that the variable deceleration, where the fall in the fetal heart rate is less than 60 beats per minute and it is recovering within a minute. We do not, it is considered as a white feature. It is a reassuring thing. It is not non-reassuring. Unless you have a growth restricted fetus and you see these repeated decelerations which are lasting for more than half an hour, then you would want to institute conservative measures. If it doesn't recover within 30, after constituting conservative measures. So you see, it's an evolving pattern. What you have written, that does not require any action.
For the extra deceleration. Vishaka is asking what is extra deceleration.
What's the question? What's the question?
On the three deceleration. This is what she is mentioning.
And to understand what the question is.
And then there is another question. Are acute versus subacute hypoxic stages reflected differently on CTG?
What are the conservative measures that can be taken? So conservative measures essentially institute change in the posture. So left lateral position. If there is hypotension, then you give IV fluids. If there is no hypotension, then you may not, the IV fluids are not needed. Oxygen is not recommended as part of conservative measures because they're known to do more harm because of free radical injury. When I was in postgraduate, first year, anybody having a drop in the fetal heart rate, left lateral, IV fluids, oxygen. So currently, essentially, it means that you change the position of the mother. There were times when we used to try and wash away the meconium by instilling saline through the vagina. That is not recommended. So conservative measures essentially means that you change the position of the mother, and if there is hyperstimulation, you stop the symptom. There you may want to give fluids, and you may give something for tocolysis also, if it is available. Role of sota bicarb dextrose is no, there is no role of. There is no role of any particular IV fluid as a conservative measure.